हेलो जगमोहन जी, मेरी आवाज आ रही है?
आ रही है आ रही है।
हाँ, वो आईपी पड़ी हुई थी यार, कब से वही तो मैं बोला हूँ, क्या लफड़ा कर रहे हो?
क्या हो रहा था?
आईपी पड़ी हुई थी, आईपी।
अच्छा अच्छा, अब ठीक हो गया।
अब ठीक हो गया।
ठीक है।
मेरे को जो एंडोस्कोपी पहला केस कहाँ लेने वाले हैं सर?
ये नंबर में भी हुआ नहीं, वहाँ पे आने वाला है।
हाँ, जरा माइक लेके जाओ, वहां से जरा बात करो अंदर से, और वो वेबकास्ट भी जरा सेट करके दिखाओ इसके बाद। ये जूम का तो मुझे छोड़ दो, मैं इसको छोड़ दे रहा हूँ, मुझे वेबकास्ट का वाले का दो एनी डेस्क। हेलो, गुड मॉर्निंग सर।
हेलो।
टीवी पे आवाज नहीं आ रही है क्या?
एक सेकंड।
टीवी पे आवाज क्यों नहीं आ रही है? वीरू सर, वीरू सर,
यस सर।
गुड मॉर्निंग।
मॉर्निंग सर।
वीरू सर सुनिए ना,
नो सर।
पहला केस कहाँ से होने वाला है?
पहला केस एक सेकंड पता करके बताता हूँ आपको।
6 नंबर में
छह नंबर से करेंगे सर, उससे बड़े वाली ओटी से।
ठीक है, आप माइक लेके जरा अंदर एकदम चले जाओ, बात करो ना, एकदम अंदर जाओ। माइक है
हाँ
वो
सर।
एकदम अंदर। मेरी आवाज आ रही है सर?
इधर स्पीकर नहीं लगाया सर अभी।
और टीवी खसका देंगे सर, टीवी खसका देंगे।
जगमोहन जी, इधर साउंड के लिए स्पीकर लगाया क्या? टीवी में दे रहे हो? हाँ टीवी में दो फिर।
चेतन जी को आवाज दे रहे हैं, मैं कि सैनी जी से।
आवाज आ रही है अभी मेरी?
हाँ अभी लैपटॉप में आ रही है, टीवी में नहीं आई अभी आवाज।
ओके ओके, आ जाएगी आ जाएगी, कर देगा
हाँ जी
बंदा।
हाँ जी।
उसको HDMI डिस्ट्रीब्यूटर लगा दे जगमोहन, सब जगह डिस्ट्रीब्यूट कर दे।
उसी की औरत का नहीं, टीवी भी है।
ठीक है, टीवी पे दिख रहा है।
टीवी में दिख रहा है।
वहां से सिलेक्ट स्पीकर को ना, ये वाला स्पीकर डिसेबल कर दे, बार बार का लफड़ा खत्म हो जाएगा। राइट क्लिक करके ना,
ठीक है वो
तो मैं
अभी तो आज तो नहीं खुली। बाकी जैसे एक बंदे चढ़ रहा है ना, यूएसबी को इंटरनेट
एक्सेप्ट कर जगमोहन। चलो छोड़ दे,
अभी आवाज आए नहीं।
छोड़ दे।
घर में क्या है, पेंट का काम भी चला रखा है, तो बेसमेंट से ऊपर एक बार आप से चलेंगे ना।
जगमोहन दूसरा चीज कर लो, तो मैं कर दे रहा हूँ।
अभी आए नहीं ना। मोहन जी। हाँ जी। अरे यार थे भी बड़ा दिमाग लगाया। मोहन जी नमस्कार। नीति नहीं भेजे वायरस मेरी तरफ से। सारा डॉक्टर के कोरोना हो बताओ। स्टाफ के तेरी दुआ से 12 तो निकले हैं ना आराम से। स्टाफ किसी की नहीं हो, देखो मोहन जी। स्टाफ को हुआ होगा, उन्होंने जांच ही नहीं करवाई। उन्होंने पता लगाने की कोशिश नहीं की। बहुत हल्की सी फीवर हुई, जांच ही नहीं करवाई। उन्होंने पता लगाने की कोशिश नहीं की। जांच करवाओ, नहीं आए तो 100%। हाँ अब तो जांच करा, उसके फायदे वो तो एंटीबॉडी बन गई उसकी। हाँ बस अब ये बात है कि एंटीबॉडी बन गई, क्यों बैम को आते हो देखो।
सर जी, मेरी टीवी में आवाज आ रही है, किसमें आ रही है?
लैपटॉप में आ रही है।
यहाँ पे तुम्हारा HDMI दिख ही नहीं रहा यार।
अभी
HDMI डालो, एक बार निकाल के डालो। हेलो एक बार।
नो सिग्नल
डाल दिया।
वीडियो माइक तो सही जगह यार, दूसरा ले आओ।
बोलो एक बार।
यो तो ओरिजिनल वाला यार, असली वाला। असली वाला यो है। असली मेन यो है।
हेलो, मेरी
हेलो।
आवाज आ रही है?
हाँ दिनेश जी, अभी टीवी में नहीं आई आवाज।
अब देखो मेरी आवाज ठीक उसमें आ रही है?
हाँ, अब आ गया, अब आ गई दिनेश जी।
आगे एकदम मस्त।
हाँ आ गई सर, डन।
ये सर किधर नहीं जाएगी आवाज?
अब सही आ रही है सर आवाज। अच्छा अपना जगमोहन जी, अपने उन टीवीओ में भी आएगी ना सब में?
टीवी का पावर क्या करें लंबी का।
यार वो पिछली बार जोड़ी तो थी अपने। बस एक बार एक्सटेंशन बोर्ड देता हूँ मैं आपको। मैं एक्सटेंशन बोर्ड देता हूँ जगमोहन जी, ये पकड़ो। पिछली बार एक्सटेंशन बोर्ड देता हूँ।
और सुनो ना भाई, ये वो क्या नाम है तुम्हारा, जगमोहन?
हाँ हाँ,
मैगवेल लगाओ यार।
क्या लगाऊं?
मैगवेल मैगवेल।
लगा दिया ना मैक। अच्छा मैकवेल लगाऊं?
हाँ इसमें मैगवेल लगाओ, क्योंकि ना इस बीच बीच में अटक रहा है वीडियो।
ठीक है, मैकवेल लगा रहा हूँ।
हाँ लगाओ, HDI लगाओ या HDMI लगाओ, जो भी लगाओ।
ठीक है ठीक है।
तो और कोई डाल देगा स्क्रिप्ट को?
नमस्कार मालिक, ये तो एकदम पीछे बैठे हुए हैं आराम से। लगा के 1 मिनट वेट करो। हेलो, हेलो। हेलो मेरी आवाज आ रही है? हेलो जगमोहन, मेरी आवाज आ रही है? ठीक, आराम से जगमोहन, सॉरी
आ
सॉरी।
रही है आ रही है आ रही है आ
एक
रही
बार
है।
माइक ऑन करके बोल देना, ठीक है? अरे कैमरामैन भाई को दे दो, वो टेस्टिंग करा देंगे।
हाँ सर, हाँ बिल्कुल आ रही है आपकी आवाज, बिल्कुल ओके आ रही है।
हाँ मालिक, जरा एक अकेला आदमी इसको हेल्प कर देने का।
नहीं नहीं, अरे प्लीज प्लीज, आपको जरूरत ही बोलने की, हम तो करते ही हैं एक दूसरे की। हाँ
और
बताएं।
टीवी, ये टीवी अंदर जाएगी। दूसरी ओटी का कहाँ पे एंडोस्कोपी भी एक बार दिखा देते तो मेरा।
अभी कंफर्म ही नहीं है कि एंडोस्कोपी अभी
और इसके बाद वेबकास्ट पे लग भाई। सिर्फ अपने पास 15 मिनट बाकी है दोस्त। 15 मिनट में 100% चालू हो जाएगा इवेंट।
ठीक है, कोई दिक्कत नहीं। वीडियो सर, एंडोस्कोपी चेक करा था ना, कौन सी में एंडोस्कोपी चेक करवा रहे हैं सर।
भाई वेबकास्ट का एनी डेज दो, वेबकास्ट का एनी डेज।
वन सिक्स थ्री 163 704। दिनेश सर
1 मिनट 1 मिनट।
सर नमस्ते, कैसे हो सर?
अजय सर गुड मॉर्निंग, अजय सर।
बोर्ड माउंट यूज करते ना।
अच्छा से मशीन लाया टेस्ट करने के लिए।
हाँ
वायर उठा लो यार, वायर उठा लो, वायर नहीं कटे।
वायर उठा रहे।
एक्सेप्ट कर लो ना एनी डेस्क,
एनीवेज बताओ।
एक्सेप्ट कर दो बस। जगमोहन तो दूसरा कर ले, मैं यहाँ पे सेट कर दूंगा।
हाँ हाँ कर रहे
क्या
कर
कर रही है? कैप्चर कार्ड लेकिन एक ही है,
एक ही है,
मतलब एक वो मैकवेल वाला है, एक एवर मीडिया वाला है।
चलेगा ना, ठीक है ना। काम नहीं हो जाएगा क्या? दोनों एच डी आई की, दोनों एच डी एम आई है,
दोनों HDMI है।
एंडोस्कोपी आ गई ना एक तो।
दोनों एच डी एम आई है ना,
हाँ
ठीक
हाँ।
है। एक डिस्ट्रीब्यूटर से उसमें डालो, और एक ये जूम का एच डी एम आई डिस्ट्रीब्यूटर से डालो, और एक रिकॉर्डर से डालो।
रिकॉर्डर से तो जूम में जा रहा है ना।
एक एच डी आई वाला इसको दे दो ना यार,
HDMI वाला है नहीं ना कैप्चर कार्ड।
तीनों एच डी एम आई है।
दोनों HDMI वाले ही है। एक तो डिस्ट्रीब्यूटर इसलिए रखा है जो इसमें जा रहा है लाइव में।
सुनना,
हाँ
ऑडियो तो नहीं दे सकते।
इंडोस्कोपी दे दिया मैंने।
ओके ठीक है, ठीक है।
हाँ।
दीपक से बोलिए।
दिनेश सर कुछ बोलना, आप साउंड चेक कर ले एक बार टीवी में सब में।
सर टेस्टिंग टेस्टिंग 5 4 3 2 1 आप लोग जरा बोलिए।
हाँ एक मिनट देखना आ रही किसमें आवाज। हाँ बोलिए। बोलना दिनेश सर।
टेस्ट टेस्ट 1 2 3 4 1 2 3 4 माइक टेस्टिंग 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 टेस्टिंग।
ओके सर ओके, सब टीवी सब ओटी में आवाज आ रही है।
टेस्टिंग टेस्टिंग हेलो हेलो
बराबर आ रही है, बराबर है।
हेलो 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 हेलो।
ओके सर ओके।
क्या हो गया?
दिनेश सर,
बोलो 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 भाई।
सर डॉक्टर साहब आ गए।
हाँ, मालूम है सर। 2 minutes to go।
ओके।
गुड मॉर्निंग सर। जगमोहन जी, आवाज आ रही है मेरी? थम्स अप कीजिए
ये आ
बस।
रही है।
गुड मॉर्निंग सर। अभी तक कोई ज्वाइन नहीं हुआ। नो प्रॉब्लम, नो, सर को काम करने दो। थोड़ा सा ना जगमोहन, हल्का सा ना टीवी की आवाज कम रखना, अदरवाइज थोड़ी सी आवाज दोबारा लेती है बस, ठीक है?
हाँ हाँ ठीक है, कम ही है ऐसे तो।
जस्ट इंक्रीज द ब्राइटनेस। और सर का और रेडियोलॉजी का पिक्चर पूरा लगाओ। लैपटॉप का आउटपुट लो। एक बार लैपटॉप का आउटपुट लेके टेस्ट करो। ज्यादा हो गया लाइट, कम करो लाइट।
ठीक है।
सर डॉक्टर साहब क्या कह रहे हैं दिनेश भैया?
बोलिए ना सर, बोलिए ना।
दिनेश जी,
जगमोहन जी।
दिनेश जी,
गुड मॉर्निंग सर, गुड मॉर्निंग सर।
गुड मॉर्निंग, गुड मॉर्निंग। बाकी लोग कनेक्टेड है उधर?
हाँ सर, नहीं अभी तक कोई आया नहीं। मैंने एसपी सर, सिंह सर को फोन किया, वो ज्वाइन कर रहे हैं। मैंने उनको बोला 5 मिनट बाकी है सर।
कोई भी नहीं आया अभी तक?
अभी तक कोई भी नहीं आया।
एक भी नहीं है जूम पे?
एक भी नहीं है।
उनको जूम लिंक तो दे दिया था ना?
सबको दे दिया, रात को हमने 2-3 घंटा टेस्टिंग भी की है।
तो फोन करो ना, किसका नंबर है आपके पास?
मेरे पास एसपी सिंह से का नंबर है, मैं उनसे बात कर रहा हूँ, भागलपुर।
करो।
ओके ठीक। डॉक्टर प्रकाश सर, गुड मॉर्निंग सर। गुड मॉर्निंग सर। सर आप दिखाई नहीं दे रहे हैं सर।
मेरा 1 मिनट।
चंद्रा सर, गुड मॉर्निंग। गुड मॉर्निंग सर, वी कैन हियर यू।
गुड मॉर्निंग, गुड मॉर्निंग।
डॉक्टर प्रकाश मोनका सर, आपकी आवाज बहुत ब्रेक हो रही है सर, इंटरनेट थोड़ा अनस्टेबल लग रहा है। डॉक्टर चंद्रा सर, योर एवरीथिंग इज फाइन, ओनली इफ यू कैन क्लोज द कर्टन बिहाइंड दैट, सो आपका फेस अच्छे से आ जाएगा सर। काफी लाइट आ रही है। Yeah, hi sir, you can talk with the doctor sir. Yeah, Dr. Chandra sir.
Yes. Good morning to everybody, sir. Welcome, Dr. Satish Jain. Good morning, Dr. Jaiswal Sahab and Dr. Munka. And all the audience.
Sir, it's a 9 o'clock. Can we start go live, sir? Satish,
Yes,
sir.
yes.
Hello, am I audible to all?
Yes, yes. Now it's perfect, sir. Good morning, sir.
Okay. Good morning. Dineshji, how many people are logged in the other network?
Sir, total approximately 450 people are waiting on a live. So can we go live? Still, I'm not started.
Okay. So I will declare it on behalf of. Should I start?
अभी चालू नहीं किया सर, जस्ट वेट
Yeah,
अभी
yeah.
चालू नहीं किया सर। आप स्टेबल हो जाइए, जब मैं चालू करूंगा तो मैं आपको बताऊंगा।
या ठीक है।
यस सर, रेडी सर। सतीश सर लाइव कर दो, सर को माइक दो ना। जगमोहन जी, just give a mic to a sir.
प्रणाम सर, झाजी को प्रणाम।
प्रणाम प्रणाम प्रणाम। की हालचाल? ठीक छी?
ठीक एकदम ठीक छी, ठीक छी।
Good morning, sir.
Good morning, good morning.
Dr. Satish, can you hear us?
Just 1 second, sir. He can hear us.
Yeah, sure.
We are just adjusting the mic. The mic will come, sir.
हेलो
हाँ जगमोहन, आवाज आ रही है?
आ रही है आवाज आ रही है।
Give a mic to sir.
यहाँ तो नहीं बोल रही आवाज।
अजय दवा लगाना। ಇದು ಉಲ್ಟಾ ಲगा। Hello.
Yeah, hi sir.
Yeah, good.
Hello, sir. Am I audible?
Dr. Satish,
Yes, sir. Good morning.
good morning. Can we have the formal starting?
Yes, sir.
Good morning, sir.
Dinesh ji, you can start live.
Hello,
Yeah.
sir.
Yeah, we are live, sir. Start.
Okay. Good morning, everyone, and welcome to all. This is a proud day
Okay,
for
sir.
AOI Bihar Jharkhand branch to have a workshop by none other than Dr. Satish Jain. I think Dr. SP Singh, our president, has joined. So let him speak first, then I will introduce. Dr.
Okay,
SP
sir.
Singh, please.
Okay,
Yeah.
sir. Please,
Yeah,
sir.
please.
Please, sir. Sir. Very sorry for delay, sir. Sir, I as a
आप पहले बोल लीजिए, then I will speak.
captain, welcome the dignitaries Dr. Satish Jain, the Chief Operating Faculty of today's workshop, and all the persons, operators, judges, delegates, all the participants of PG students who are participating in today's webinar and the workshop. So I hereby declare the webinar seminar open today for the workshop and all the sessions, and I now hereby hand over to the mic to Dr. Prakash Munka, the chief moderator of the today's operating session. So Dr. Prakash Munka will now continue the proceeding for the workshop. Thank you, sir, so much.
Thank you. Good morning, everybody. I, on behalf of AOI Bihar Jharkhand branch, welcome you all to the great workshop by none other than Dr. Satish Jain. Basically, in the pandemic, we thought we cannot hold the conference physical form, so we decided to have a half day of the workshop followed by the award session. That was to encourage our PG and SRs so that they don't lose the habit of presentation, and we will award them suitably. Uh, our team, headed by Dr. SP Singh, have done a lot of work to streamline the thing. Without coming in between you and Dr. Satish Jain, I just will say few words. Dr. Satish Jain do not require an introduction, at least to the ENT community. He has just to say for the few juniors who might not be very clear what he is. He is director owner of the Jain ENT Hospital, one of the most high pressure, high volume centric center of the country. And I think the Jain ENT hospital I have visited personally has more number of faculty or surgeons and residents and the facilities, and per day surgery is probably higher than many of the big institutions doing in a month. With all these words, I request all other moderator and chairpersons, when they are not speaking, please put their video off when he starts. Right now it can be on, but please be on the mute, otherwise it disturbs. Dr. Satish, sir.
Thank you, sir. Good morning, everybody. And can you hear me, sir?
Yeah, very clear.
So first of all, I extend my thanks and regards to the team AOICON Bihar and Jharkhand for giving me this opportunity to telecast this live surgical demonstration. And I'm indeed grateful to the office bearer of the AOICON Bihar and Jharkhand, especially SP Singh, sir, who is the president and the organizing chairman of this event. Dr. Farooq, who has been the secretary of this event. Farooq has worked with me, is like brother, who has worked in Jain ENT for 2 years. And, you know, he was that time was the otologist of our institute here in Jaipur. So it's a pleasure to see Farooq online today. Thank you, Farooq. And then the other team members, office bearers, Dr. Samit Lal, Dr. Sanjeev Kumar, they all have been friends and doing great job. And a special thanks to Prakash Munka, sir, who has always been inspiring us in all academic activities. And it's always pleasure to interact with him. Thank you so much, sir.
Oh, it's my pleasure, Satish.
Thank you. So today's program, with a time limit of 9 to 1. So from our list, we have number of cases. We'll try to demonstrate as many as possible. We have 16 cases lined up. We'll probably be able to show 5 or 6. So the first case to begin with. Camera on.
Last one, probe graft.
So after this, whenever they want to cut me off, Satish is welcome to do that. Satish, if you're around, cup. This is going to be a routine grafting, a quick grafting in order to save time and keep with the saline. So I dip it in saline gel foam, ready? Yes, sir.
How to ensure the stability of this vertical structure?
That's the most difficult thing, and you cannot. So that is the problem. That is the weakness. That's why you talked about staging. When you stage it, your tympanic membrane is fixed, and the foot plate is also reasonably in one place. So it becomes easier to graft it at that point of time. In the first stage, we'll talk about that in a minute. So let me do the grafting. See, I push the
Dr.
graft.
Satish, we are in between some surgery.
All the way down anteriorly and inferiorly, if you see it.
Hello, sir.
We are in between some other surgery.
Inferiorly, if you see it, it comes up to my incision. That is my incision, which I showed you in the beginning. This goes underneath the incision. So the graft is fine. This is the inferior flap. The superior flap I lift off to make sure my graft is well positioned. The graft is well positioned, so I replace my superior flap. That's my superior flap repositioned. And then you've got a little bit of unhealthy tissue, which I will remove. You've got my inferior flap coming up. Be careful how to open it. No, it's not how it's supposed to be. That is how it comes. That is the incision. See the incision.
Yeah. Dr. Satish, Dr. Dinesh, Mr. Dinesh.
Yeah, sir.
Yeah, probably we focused on the ongoing surgery, some other one.
Yes, sir. We already focusing on that. That's me.
Yeah.
So,
now, Dr. Satish, please
Satish, sir,
introduce the
can you hear
case.
us?
Hello?
Yeah, Dr. Satish, we got into some other case probably. Yeah.
Yeah, he played the previous one.
Yeah, that's what I.
Are you getting the picture now, sir?
Yeah, very clear.
Are you seeing the subtotal perforation in this here?
Yes, very clear.
Yeah. So what we have done until now to save the time is we have raised the post-auricular incision and we have made the margins fresh so that we can proceed to the important steps.
Right.
So like we discussed in the previous webinars, the perforation repair is one of the commonest surgery in otolaryngology, and it should not be taken so mechanical. There is a scientific basis, a lot of physiology involved in managing these situations. Perforation can be end result of problem anywhere in the middle ear cleft. That is eustachian tube, middle ear mesotympanum, eustachian tube or mastoid air cells. Or this perforation can lead to problem anywhere in the middle ear cleft. So by and large, we need to reconstruct the middle ear cleft in total to ensure good results. See, there are so many techniques to deal with such situations. To repair the tympanic membrane, we all know the number of techniques, the most popular being the underlay, onlay technique, and what we propose is interlay for such large perforation. Is the choice of our technique for the regions which I'm going to tell you. So by and large, what do we do for junior colleagues? What is underlay, onlay, and interlay?
Yes.
This tympanic membrane consists of 3 layers, we all know. The outer one being epithelium, the middle one being fibrous, and the inner one being mucus. In underlay grafting, we make the underlying mucosal membrane raw and place the graft underneath all the layers of tympanic membrane. That's why it is called underlay. It's a good technique, simple technique. You raise the flap from behind and place your graft underneath after making the surface raw, under surface raw. And it's a good technique, and over 90% of the cases in simple perforation without having any problem in the middle ear cleft, it works well. In only technique, the graft is placed on the fibrous layer of the tympanic membrane. You need to elevate the fine epithelium and all around and place the graft over the fibrous layer. That is technically challenging. You need to elevate the thin epithelium all over. If you happen to leave, even a bit of epithelium can convert to a cholesteatoma underneath. So that is one of the biggest drawback. Number two, the graft may become exteriorized at most of the time comes over the malleus. It may not be connected to the ossicular chain properly to give a good lever effect. And the third is because the graft all around at the edges comes in contact, the canal part comes in contact with the drum part, may lead to blunting. The blunting has a ability to reduce the vibration of the tympanic membrane, can lead to conductive hearing loss. So the technique is good. In the good hands, the results are much better than, I would say, underlay. But these, drawbacks one need to overcome. The technique which we propose, interlay, it overcomes all the disadvantages of onlay and underlay. Here the graft is going to be sandwiched between the layers of the tympanic membrane, between the fibrous and the mucosal layer, so it remains well supported between the layers all around, so it doesn't medialize or lateralize. No question of blunting, no question of removing the epithelium, separating the epithelium. Rather, we separate the epithelium fibrous layer together from the mucosal layer. So that requires a complete separation of the tympanic membrane into layers, which I am going to demonstrate. So the steps of this surgery, we have already made the margins raw. Margins, freshening the margins is an important step. The reason being, in long-standing perforation, this outer epithelium layer going across the fibrous layer joins the mucosal layer, and this epithelial mucosal junction may become non-healing. If you don't separate these junctions all around, that part of the drum may remain non-healing and can exist as a same perforation. So it is always better to freshen the margin of perforation to enhance the healing. Though in interlay, we are literally going to separate the tympanic membrane into layers. It is not warranted, but still always better because this epithelium sometimes can grow along the margin to a distance and you can leave the epithelium below. So we have already made the margins raw, and now the next step would be, sir, please feel free to interrupt me anytime.
Yeah. Continue, please. I will.
So the simplest way of carrying out this surgery, it's not difficult, believe me. My margins of the flap are little different than from the underlay. Little different.
Dr. Satish, before you proceed with the interlay, can I ask what are the things, if you see a case, when to decide I am going for interlay, onlay, or underlay?
Yeah, mostly for all large and subtotal perforations, we prefer interlay.
Yeah.
In a smaller perforation, quadrantic perforation, we may have to change the technique. Like for example, if we have a perforation with malleus handle in the margin of the perforation, we do a combination of over-underlay, wherein we make the malleus raw and place our graft over the malleus to support it. In the posterior quadrant perforation, underlay. In the anterior superior quadrant perforation, we do reverse interlay. There we raise the flap in the reverse way than what I am raising. I will tell you while I am raising. In the inferior quadrantic perforation, we do underlay with inferior tucking. So more anterior perforation, solitary anterior small perforation, we do underlay with anterior tucking. So there are a variety of techniques. There is no single technique for all, but in large and subtotal perforation, this is our technique of choice.
Please go ahead, sir.
Okay, so my incision margins. Our next case is, sir, going to be a mucormycosis debridement, which is already induced now. Without wasting time, after this case, we'll move on to the other one. So now my margins of incision for the flap are tailor-made. This is the anterior superior margin of the perforation, posterior superior. My incision is few millimeter beyond this. See, this
Yeah.
is where my section is the margin of perforation posterior superior. And this is the incision all the way along the posterior wall, just lateral, ending just lateral to the tympanic membrane, like this.
Yeah.
So this is through and through the incision right up to the level of the tympanic membrane. This is posterior superior.
Yeah.
Then posterior inferior.
Well,
Pardon, sir?
the problem is, yeah. The picture is good, very good. It is well analyzed. Go ahead.
Sir, this is antero or posterior inferior margin of perforation, and here my incision is again tailor-made few millimeters beyond the margin of perforation, but I am not deepening right to the level of tympanic membrane, leaving it, stopping it, limiting it few millimeters lateral to the tympanic membrane. Okay?
Yes.
This is my posterior incisions for the flap. And I
Yeah.
can simply raise like underlay technique. Simply.
Yeah.
Keep your sucker behind the instrument so as not to directly traumatize the flap. And raise it like underlay technique right up to the annulus. See the annulus.
Yeah. Yeah.
Not supposed to go beyond the level of the annulus here. Annulus.
Yes.
See the annulus. So this is posterior perforation, posterior flap. Now,
Flat.
so the flap elevation is different from underlay. Because we have to separate the tympanic membrane in layers, we have to divide the tympanic membrane into layers. What I am doing, see, this is my margin of the medial margin of the posterior inferior incision. See this? I did
Yes.
not raise it to the level of the tympanic
Yes,
membrane.
yes.
And from here, I will see, complete this incision circumferentially beyond the anterior superior margin of the perforation. See, this is anterior superior margin of the perforation. This is even beyond that. See till here. Bang on the bone deep in multiple goes, because this anterior part of the skin is very thin. If you try to go in one go, you may traumatize the skin. I hope the picture is good, sir. Hello, sir.
Very good.
Yes. Good.
Okay. Now I
picture
am
is
raising
good.
the rest of the flap simultaneously at all levels. See this?
Yeah.
One should not raise the flap at one level deeper, as it may traumatize, lead to tears. See this? All levels simultaneously, staying bang on the bone. This is circular knife. Now, to all quadrants one by one, I will go to the level of the annulus. My first target to reach the level of the annulus. See this. See the annulus here? Antero superiorly. Now see the annulus anteriorly. See the annulus anteriorly.
Yeah.
Now see the annulus antero-inferiorly. This way I will reach the annulus all around.
Yeah.
See that?
Yes.
This is some fibrous band. Antero-inferiorly, you have to divide them sharp. See the annulus antero-inferiorly. Now inferiorly. See, all these quadrants to be need to be seen separately. Now this is inferiorly. Farooq has done hundreds of such cases at our hospital. I don't know he's following still the same, or he must have developed some new thing, add on new thing to this. Please comment, Farooq, if you are doing something different, please. This is posteriorly. See the annulus. And this is the
Yes.
posterior superior region. See all the way. My first goal is to reach the level of the annulus. That is it. Number one. See this? The same
Yeah.
perforation. Okay?
Yes, yes.
Yeah, I hope it is clear so far.
Yes, yes.
Yeah,
Now
excellent.
Now my second goal is to get the annulus out of the bony sulcus. See this.
Yeah.
Let me focus. I will show you under high magnification. Very clear. See this annulus?
Yeah.
Yes.
And I am getting it out of the sulcus. Out of the bony sulcus. Simple.
Yeah.
Using this side knife
Yeah.
without traumatizing the annulus. See this.
Yeah.
See, this is the bony sulcus.
Yeah. Absolute clear.
So now, everywhere, all around, where I elevated the flap, right from the, see, this is the anterior superior limit of the annulus, where the notch of Rivenus starts.
Yeah.
Band. This is the area where the anterior superiorly the annulus ends. See this?
Yes.
Here. To the anteriorly, anywhere the annulus is out of the sulcus.
Yeah.
Anteriorly out, inferiorly out. Now inferiorly. You just have to bring it out of the sulcus. This is
Sulcus.
second step.
Yeah.
Gently without traumatizing the annulus. See this? Get this out.
Yeah.
Out of the sulcus. Same thing you have to complete now posteriorly and posterior. Superiorly till the posterior superior notch of the annulus. See this?
Centralize
Out.
a bit.
Yeah. Yes, sir.
Yeah. Good. Good.
And see the annulus getting out.
Yeah.
And see the
Chorda.
underneath the annulus chorda tympani.
Yes.
Chorda.
Okay.
Yes.
So this is the second step.
Yeah.
Again, I will deposit the flap. You can see the same perforation.
Yeah.
Now my third and the most crucial step, which is the hallmark of interlay, is to separate these three layers
From the
tympanic
mucosa.
layer, to separate the tympanic membrane into layers. And what I am going to do now, see this, we'll start antero-inferiorly. That is the most suitable angle, sharp angle of the tympanic membrane. When the annulus is what? Annulus is simply the condensation of the
Fibrous layer.
layer of the
layer.
tympanic membrane.
Yeah.
Yes.
So this is the condensation of the fibrous layer, and what you see underneath is the mucosal layer. Can you see?
Mucosal layer.
Yes.
Yes.
Now my epithelium and the fibrous layer together, I am going to engage this blunt needle, 45-degree needle,
Yeah. And
engage
separate
it
the.
and gently peel it off the mucosa.
Yeah.
This is not supposed to be broken. The mucosa is supposed to be peeled off. See this now.
Yes.
The
Yes.
mucosal layer is separate from the rest of the two layers. You can see very, very clear. And that is the hallmark of interlay. The layer on which we are going to place our graft, that is mucosa, and the rest of the two layers which are going to come above the mucosa. So that is how the graft.
Again, centralize, please.
Yeah, in the same layer.
Satish, again, centralize. Centralize.
Yes, sir. So
Yeah.
all
Good.
the way,
Good. Yeah.
all the way. See this.
Yeah.
See this antero-superiorly, anteriorly, antero-inferiorly.
Yeah.
The mucosal layer standing absolutely separate, and
Yeah.
the rest of the two layers have been elevated, and we have to continue this all the way.
360 degree.
360 degrees. Same.
So,
Now-
Dr. Satish, just to interrupt, till now, the most important step was be gentle, don't cause any tear, and the annulus should not have any tear. That should be in
Yes.
one go.
Yes, yes, sir.
Suppose by mistake, if you have created tear in the annulus,
Yes.
can you still go ahead or you should
Yes,
abandon?
yes, you can approximate it again while repositing. That's what you can do.
Okay, that's
Now
good.
see inferiorly, posteriorly,
Yes.
everywhere the mucosal layer is standing out.
Yeah.
And what is this mucosal layer? See the mucosa over the promontory.
Yeah.
This mucosa over the promontory drapes around the margins of the tympanic membrane walls
Yeah.
and then come underneath the tympanic membrane, the same mucosa.
Yeah.
That's how it makes the air containing cavity.
Yes.
Now see posterior superiorly.
Yeah.
See this same mucosa.
Yeah.
Same mucosa. See the
This is chorda tympani. You can see. Yeah.
see the chorda tympani very clear.
Yeah.
And see this, oh, very, very important finding. Amazing.
Yes,
Yeah.
yes. There is disruption.
Yes, you notice that.
Yes.
See that. What is the finding? That is the malleus.
Yeah.
That is the stapes mobile. And see what is happening once I mobilize.
Yes.
The lenticular process of the incus is necro. See this.
Yes.
Only mucosal continuity. See that?
Yeah.
A very common finding.
Yes, because the lenticular process of the incus is forced to go when the vascularity is compromised. That is the most fragile vascularity.
Yes.
And this in the chronic suppurative otitis media is the first thing to go. Can you see this?
Yes, yes.
Yes,
Very
yes.
clear.
And let me curate. That is so obvious now that we have a lenticular process necrosis.
Yeah.
So we need some ossiculoplasty also along with.
Yeah.
See this posterior superior overhang I am removing to show you better this quadrant.
Yeah.
Yes. See the incus? Ball probe.
Yes.
Some mucosal, edema in this region. And now I am passing my ball probe in this region in the incudal space.
Yeah.
See this mucosal blab?
Yes,
Yes.
yes.
It was blocking this isthmus.
Thickened mucosa. Yes.
Yes, thickened mucosa. This is the space between the malleus and the incus. This is called the tympanic isthmus, which is important for the aeration to the adductus from the eustachian tube. And if this area is blocked, whatever tympanoplasty you do can result into a failure.
Yes.
Because we
Yes.
need to ensure that all mastoid air cells are
Aerated.
aerated down the eustachian tube. So this is the tympanic isthmus,
Yes.
which was practically blocked, which I have opened up with some, all this thick mucosa. That
Is
is
there
very,
any sclerotic patch also over there?
yeah, little bit which I'm bringing out.
Yes.
Yeah. See, in every interlaced tympanoplasty, I always mention this is a middle ear cleft reconstruction. We need to look at the eustachian tube function pre-operatively we do with the tympanometry and the saccharine
Yeah.
test intraoperatively by flushing
Yeah.
the eustachian tube, and then we assess the mastoid air cell system aeration by means of, assessing the patency of the adductus. So now situation
Adductus.
is we have divided the tympanic membrane in layers. We have a mucosal continuity. A graft, if I reposit back, it looks like the
Satish?
same perforation in the tympanic membrane, but now the rest of the two layers have been separated.
I want to ask one thing. Are you going to, I think you will be opening the antrum?
Yes, sir, you can say opening, but I call it ensuring the patency of the adductus. So I will open from behind until
Yes.
I get the patency.
Yes, yes, yes.
Yes.
That's
Now
what I
towards
am
the
asking.
eustachian tube. Yes, sir. Yes,
So
sir, you're
far
right.
we have not seen any, Dr. Satish, so far we have not seen any cholesteatoma in this case.
In this case, no question of cholesteatoma. You can see absolutely dry middle ear. What we can see is the erosion of the lenticular process with some mucosal edema over there. That could be blocking the editors as well.
Yes.
So now here I will flush the Eustachian tube. Simple. You can't do anything to the patency of the Eustachian tube intraoperatively, but at least we flush it. अरे सिरिंज छोटी थी भाई anyway ये लगा 18 number. Yes, what I will do simply I will flush the Eustachian tube to see if anything lodged there. Sometime in long standing perforation there may be foreign bodies lodged.
Yes, yes.
So at least flush them. It doesn't take time.
Not uncommonly, we have also found so many things coming out of it.
Yes,
like
lot of
a
people have a habit
straw,
of
some small insects.
yes, a lot of people have a habit of picking the ear with a matchstick.
Yes.
Recurrent infection can result into, you know, like you said, the insect lodged in the Eustachian tube.
Yes.
All these things are not uncommon, I would say. See this thick mucosa. That becomes the reason to the blockage of editors, which now we have to ensure. Okay?
Yes.
Because there is a high possibility in this patient that the editors may be closed. And in that situation, I may have to, even in the extreme of the situation, I may have to remove the incus to open up the area completely if required.
Yes.
Not always.
How are you going to reconstruct this disruption?
Cartilage. I will show
Cartilage.
the simplest of the technique of ossicular reconstruction. This is the commonest and the simplest ossicular reconstruction situation, I would say. Commonest and the simplest.
Yes, yes.
Now, first of all, the most important step, checking the patency of the editors. So the best way is, a lot of people rely nowadays on the endoscope. You can take 45-degree endoscope from anteriorly and see if the editors is open. But that doesn't 100% give you a guarantee that editors is open beyond that as well.
Right, right.
So this, I am not doing a cortical mastectomy. I am not doing a antrostomy. I am not making a window. This is simply a test to ensure 100% on table that my mastoid air cells are being aerated down the Eustachian tube.
Yes.
And see this. This step I have seen people giving complications. So the best way to carry out is stay superiorly. See, this is canal. Stay as superiorly as possible. Open widely from laterally before going deeper. Stay superiorly and then keep going deeper. As you go deeper, widen further. Superiorly, it is better to define the tegmen, so you go along the tegmen.
Yes.
This is to avoid damage to the critical structure inferiorly here, like semicircular canal or facial now. I have seen such complications, which is something not acceptable to anybody. So always stay superiorly along the tegmen.
Okay.
In a good pneumatized mastoid, it is never a problem. But you never know what kind of mastoid you are going to encounter. This is thinning the canal wall at the same time in process of widening this. I will stop when I see the patency, as simple as that.
Yes.
Until and unless I don't get the patency, I'll keep going to the level of the editors and clear it.
Yeah.
To ensure the patency, whatever is blocking, I need to clear that down. See superiorly that glimpse of?
Yeah.
Yes.
Yes, yes.
See this? The thick mucosa.
Yeah.
It's still not got the patency. In a very well pneumatized mastoid,
Yes. Now we got
you
it.
would have got this patency right at the beginning, most laterally.
Yeah.
But still see this? Lot of thick mucosa blocking the Aeration, and imagine you do a tympanoplasty in such a dry looking perforation, absolutely dry looking perforation. See such thick mucosa. See this?
Yeah.
Without clearing this blockage, what would you get ultimately? This could be the reason for the utter failure. So I will keep going until I get the
patency.
Editors and
so this is a very, very interesting case.
yeah.
Many times in demonstration we get the straightforward with no blockage.
Yeah.
But this is important to see in case you happen to get the editor's block, what all you can do. Option number one, what I'm doing, go directly and clear the editors. Most of the time, more than 90% of the time, you can easily get rid of that. Number two, in case of thick mucosa with eroded incus and difficult to negotiate the clearance to get an absolute patency, you can remove the incus and get a full patency and do ossiculoplasty. Third one is you can do a posterior tympanotomy. See this thick mucosa?
Yes, yes.
And now see it opens up.
Patency, yes. Now it has become patent.
It opens up. This is the thick mucosa. Give me forceps. I will take a, this is a routine to take a biopsy of such pale looking mucosa. See this?
Yeah.
Thick pale looking mucosa always need to stand for
Tuberculosis or like something else?
Pardon?
Is it tuberculosis or for exclude tuberculosis or anything else?
Could be. We can't rule out.
Yes.
But probably most of the histopathology shows chronic inflammation or chronic.
Yes. Sometimes even in spite of being tubercular, the histopathology may not reveal on this granulation. So it is
Dr. Satish, at this point, should I ask that in all your cases, you do this patency test?
Always. Yes.
Because there used to be a controversy.
Sir,
there used to be a controversy. People say, what is the fun in opening the editors if it's a dry looking perforation?
Yeah, it was
one
a dry
guiding
looking perforation, wasn't it?
Pardon?
It was a dry looking perforation.
Yes, it was. Yeah.
And see what happened.
Yeah.
You never know. And secondly, if it is a dry perforation with no blockage, it won't take more than a minute to carry out this procedure.
So it's always better to just open the editors, do a water test, and if it is okay, you can continue. Am I right?
Yes. See, the incus was involved in granulation completely. Better I remove it and do a good ossiculoplasty for this purpose, particular purpose.
Yes.
So now this gives the widest space and give you a full patency through and through once you remove the incus.
Yes.
Can you see? And see the ossicular chain was already in discontinuity.
Yeah.
See this. Now, there is no question of aeration issues. That is one of the most important.
Yeah.
Taking the results of surgery from 90 to 99 is the task.
Is the challenge, yeah.
And
up to 90, everybody can get it, but 90 to 99 is the challenge, yes.
Yes. Because every technique will give up to 90%.
Yeah.
You need to look at the aeration issues, the Eustachian tube issues, the grafting technique, all these things matter. And see, this patient is a great example of editor's block. Now, this is a complete, once you remove the incus, there is nothing to block the editors. See this?
Yes.
The through and through patency now. See this? You can check from either side. The water level test, you can see the suction test. There is no question of any thick mucosa or anything blocking now. Fine?
Now, Dr. Satish,
Yes, sir.
Now, will you be doing the overlay at the level of the handle of malleus?
At the level of the
handle of malleus?
Not really, sir.
Because,
Not really.
because now you will be going to join the malleus with head.
No, no, not really. I'll be using the cartilage. I will not
directly,
be taking the malleus
directly
into
to
the
the
assembly.
tympanic membrane.
I will not be taking the malleus into assembly now.
Okay, okay, okay.
In my osteoplasty, which gives us the best result within 15 decibel, I will tell you, and this is the simplest situation of osteoplasty.
Yes, yes.
So for that, what I will do, I will harvest the tragal cartilage, the triangular tragal cartilage, and use the tragal cartilage triangular, the base being in the tip being inferiorly to the stapes.
Head, yes.
This entire cartilage will remain in contact with the eardrum.
Yes.
This will augment the stapes, and that gives you the most stable assembly in this situation. Okay. You have seen in the AOICON Ashim doing few of the cartilage osteoplasty.
Yes,
yes. Yeah.
So here, this is simplest of all the assemblies I can show. And see this. I will make a facet inferiorly, sir.
Yeah.
For the cartilage tip.
This facet I am making inferiorly on the inferior canal, inferior annulus. See this?
Yes.
Right on the inferior annulus, bony annulus, to lodge my one end of the cartilage into
cartilage tip, yes.
So that will give stability on both sides.
Yes.
Yeah.
And this will be a very, very stable assembly. So now the last two things left, the osteoplasty and the tympanic membrane grafting.
Yes.
And I have to harvest material for both.
Yes.
I will harvest now the cartilage, then I will harvest the fresh graft for the tympanic membrane grafting.
Yeah.
So the cartilage, the simplest way. Cartilage, the simplest way, I will use the tragus. See this? Use the horizontal incision, keeping the lateral part of the tragus intact, which has a cosmetic value.
Yes.
I will harvest this cartilage like this, through and through, keeping the perichondrium intact.
Have you already injected it?
Yes. We inject by default in every case, whether required or not.
Actually, this lateral is very important because nowadays most of the people use the earphone and all that. So that should be maintained.
Same, I am harvesting this strip of cartilage simple.
Yes.
This long strip of cartilage here, and this is having the perichondrium on both sides. You should at least have on one side. This is a huge cartilage. I will refashion it to a smaller one now, required one.
Preservation of perichondrium reduces the resorption of the cartilage.
Yes. In terms of acquiring vascularity, this perichondrium is the key.
Okay.
Perichondrium is the key. I'm just, see?
Yes.
This is a huge cartilage.
And both sides the perichondrium is intact.
Both sides, I will show you.
Yeah.
I'll show you, sir. I am making little triangular.
Yeah. there were a lot of query even in otology conference also about the strength of this cartilage and how long it will stay.
Yes, that's a very important question. And that is, I would say, one of the most important things, prerequisite for a good osteoplasty.
Yes.
The stability.
Yes.
That is why I already mentioned I made a facet on the other side.
Yeah.
My cartilage will stay on both sides on a platform. Number one.
Yeah.
Number two, it will be sandwiched. It is
Between
staying on the both sides and then will be sandwiched between the graft and the support which the cartilage is getting from below.
Yes.
So it will be, I would say, one of the most stable assembly I can think of. Now,
and
this
long-term
is
results. Long-term results with this type of cartilage is good.
Amazing.
There is no
amazing.
Okay.
Because this is autologous tissue.
Yeah.
Perichondrium over it. And
here the key is perichondrium must be intact on both sides.
At least on one side, sir.
Okay, fine. Please.
Both sides is
Ideal.
nothing like it, but
Yeah.
At least on one side.
Yeah.
Now see what I'm doing. Keeping it little larger, I will first check it.
Yeah.
That how big my cartilage is. It is bigger.
Yes.
So that I can show you how much I can trim it. See, this is the facet which I created. And on this side, this is going to stay on the stapes head. And see how big the cartilage is. See the stapes below? Hello?
Hello.
Yeah, see the stapes below.
Yes.
So now it is so big, it is coming even into the editus. Can you see?
Yes. Yes.
And
Very
see
well.
the other end, which is, lodged in the facet. See this?
Yes.
Make this stable. Now I will trim to a smaller one. This was to show that how big the cartilage is.
Satish sir, good morning.
Good morning, sir.
Sir, this is Farooq sir. Sorry, could
Hi,
not
Farooq.
continue. Yes, sir. Because of some interference, could not connect. We have
Please,
been watching
Farooq,
you, sir.
welcome, my dear. See
Yes,
the
sir.
perichondrium on both sides.
Yes, sir. Very well appreciated.
Actually, these are fine points, Dr. Satish. These are the fine points which are standing between success and failure.
Sir, see the perichondrium on both sides.
Yes, I can.
Now what I'm going to do to trim this to a smaller size. Yes. Little smaller because it was a bigger one. We
Yeah.
saw that in length.
So one thing I want to ask, sir,
Yes,
the
please.
cartilage that we are using, the length part we have discussed. What should be the width of the cartilage that we use? It should be very.
Width should be at least twice the size of the stapes head, so that it can
To make
stay
it stable.
comfortably on the stapes head without slipping from that. Number two, in that situation, you don't have to even make a facet for the stapes head. Otherwise, to stay on the safer side, you tend to make a facet over it.
Yes.
To take the stapes head.
Yeah.
And now there's a very important step to irrigate it thoroughly. To remove any foreign material, powder material or anything onto it. And this looks like my final size of the cartilage. Let me check it again.
Yeah.
and then last part would be the grafting. See that?
Yeah.
You are not going to make a facet?
Not for the STPs. It is going to work because I've taken the width much than the twice of the STP's head. It is not going to slip, and since it is going to be sandwiched between the tympanic membrane and the,
And with a small facet, we are supporting the lower part also.
Yes.
So we can get the stability from the three sides.
Now,
you can see. Yeah.
See now the step is below.
Yeah.
Yes, it is mobile, moving.
Yeah. Look at the both ends first.
Yeah.
See the lower end into the facet.
Yes.
See the stability. It is not going to go anywhere. See that? Number one. And see the upper end. See this end on the stapes and see the mobility of the stapes.
Yes, yes.
And that gives you amazing assembly. Very, very stable one. See that?
Yeah.
If
The
I
upper
tilt, I can
end
show
has
you
to
the round
be
window
free.
reflex very well. See the round window reflex now. See the round window.
Yes.
Yes.
Now focus on the round window now, please. See the round window.
Yes, yes, yes.
Very clear?
Yes, yes. Excellent. Dr. Satish, this cartilage had got support from lower side by the facet, and on the two sides, one is from the stapes head and other is the graft. So
Yes.
three sides we are getting the full support, isn't it?
Yes. You can additionally make a facet for the stapes, but it doesn't matter actually if you use a good width of the cartilage. Got my point? Actually, you don't need to make a facet for that.
Clear.
Because it may, I believe, weaken the cartilage. That situation, the narrow cartilage on this side, that too you weaken by, because cartilage is always questioned for its strength.
Survival.
So
Strength and
generally we
viability.
don't make, unless sometimes it is warranted. Now see my graft. This is my fresh graft technique. We call it bed-to-bed grafting.
Okay.
I don't say that a dry graft doesn't work, but what we are striving for the betterment. And other way around, I can say this fresh graft cannot be inferior to a dry graft. That much I can say. You maintain the fibroblast much better. See the true temporalis fascia. Can you?
Yes, yes.
Yes.
After removing the superficial layer already. See now, I am injecting the saline underneath the fascia
To elevate it from the muscle.
The muscle.
Yes.
I don't want to traumatize the muscle. Sometimes this matters a lot because more you traumatize the muscle, bleeding, then cauterizing, leads to some cicatrization, fibrosis, and pain in this region.
Yes.
And many of these patients complain post-operatively of pain behind the ear, above the ear, and many a time we label them psychos. Don't traumatize. We need a fascia. Fascia has the minimal metabolic requirement, and being a free graft,
Yes.
the ideal graft should have the minimal metabolic requirement where the fascia suits.
Yes.
See now with practice, they are able to measure the size, required size on the bed only, rather than manipulating it outside.
Yeah.
Don't crush the graft at all. Now see, having injected the saline underneath, it easily separates from the underlying bed.
Yeah.
You can see. Can you?
Yeah.
See, all the blood vessels are there underneath. See that? And this is the true fascia, I can say. Isn't that? This is true temporalis fascia, nothing else than temporalis fascia. See this? And now I will harvest this. This is true temporalis fascia. And this being harvested, now this is pure fascia. I hope the picture is good.
Excellent.
I am not taking anything else than fascia. See all the vessels, everything below. And this is the graft, required length of the graft, required size of the graft for my particular case. I don't need beyond that. Harvest it and place it onto the bed. I revert it, keeping the surface facing the muscle laterally towards the tympanic membrane. See this?
Yes.
This is what? Fresh temporal fascia graft.
Yeah.
I will place my cartilage later after grafting.
Yeah.
Now the grafting becomes very simple. Once you have a bed all around, this mucosal bed all around, for the graft to stay, now everything is much simpler. See this graft. 3 steps. The step number 1, advancing the graft into the middle ear. Yeah, I will centralize. Just a minute. See the first step?
Yes.
Advancing the graft into the middle ear.
Yes.
As much as required anteriorly. See that?
Yes.
You can do little adjustment later as well. But this
This
is
tucking is
important.
just below the annulus.
Below the malleus.
Okay. Yeah.
See now. Spread it all over the canal. See like this?
Yeah.
See the fresh graft, how it looks like. See my handle of malleus?
Yes. Yes.
And I have spreaded it beyond so that it comes on the mucosal layer anteriorly as well. See this?
Yes. Yes.
Spreading all over from here to here till margin to margin of the incision.
Yeah.
Now the second step is to reflect your tympanic membrane, this flap, over it. See this?
Yeah. Yeah.
Over it. And make one unit. Because being a fresh graft, because of the surface tension, it joins the other layer very quickly.
Easily.
See now, I will elevate both layers together. Can you see now?
Yeah. Yeah.
So that I can make these layers, form with each other like this. So they will not, dissociate once I've managed my graft anteriorly, manipulate anteriorly.
Yeah.
Now what I will do, simply elevate the anterior margin. See this?
Yeah.
Elevate the graft.
Yes.
And lift it and place on the mucosal layer. What a simple way.
Yes.
This is the simplest of the grafting technique, I can say. Now my posterior, see this flap, is not going to allow the graft to dissociate from place. And now anteriorly, I am not only keeping on the mucosal layer. See the mucosal layer below?
Yes. Yes.
Not only the
You are
mucosal
beyond
layer,
that.
but on the canal wall as well.
Yes.
So this is pure sandwiching.
Yes.
Pure sandwiching the graft between the mucosal layer and the rest of the 2 layers now coming over it. See now.
Yeah.
See these 2 layers coming over it.
Yeah.
The graft was on the mucosa and the rest 2 layers are over it. And see the malleus.
Yes.
See the cone of light. To me,
It
this
is
is the
same, sir.
most physiological place for a graft, being a fibrous tissue sandwiched between the epithelium and the mucosal layers.
Mucosal layer.
The most physiological one.
Yes.
Rather than underlay and overlay technique. See this? Now, since it is sandwiched all around, see this?
Yeah.
It cannot medialize, it cannot lateralize, and the handle of malleus is taking care of it. Can you see?
Yes.
Now, once again, I will elevate from all around and check my sandwich, whether it is in order or not. See this?
Yeah.
Posterior superior quadrant, everything in order. The
Yeah.
flap and this thing posteriorly. See that?
Yes.
See the good middle ear space?
Yes.
See inferiorly now the mucosal layer and the graft over it.
Okay. Yeah.
All the way.
Yeah.
Now I will deposit it back here again. Back here means, see this, the graft and the flap being allowed to sit over the mucosa without any tension. See this?
Yes.
Without any tension. Everything being comfortable here, all the layers in place,
Yeah.
without any push or pull or anything.
Yeah.
Now, elevate anteriorly, anterosuperiorly. See this? This is the graft, under surface
Yeah.
of the flap. See that? And these 2 layers are going to be placed. See this? Under vision, without tension being placed on the mucosal layer. See that? No question of
Excellent.
anything hidden. See that?
Yes. Yeah.
Now, lastly, the most important anterosuperior quadrant. See, these are the risky areas in underlay to
Yeah.
tackle. See this? My margin of perforation, and see where till I place my graft. See this completely like this.
Centralize a bit, please.
Okay, okay, sir. Not centralized? Yeah.
Yeah.
Now see all around. All the 3 layers in place.
Yes.
I will tighten at the periphery like you tighten the tennis racket.
Yeah.
See?
Dr. Satish, you
What I'm
said
feeling is
about
the
the
mucosa.
muscular layer of the graft to be. Yeah.
Pardon, sir?
You said the muscular part of the graft should be lateral. Does it really make an impact?
Yeah, I don't think, very sure, but it gives me
Yeah.
intraoperatively that surface more raw.
Easy to slide.
More raw.
Yeah.
To stick to the under
Yeah.
surface.
Satish
See
sir,
this?
good morning.
Yes.
Yes, sir. Good morning.
Yeah, this is Sanjeev here, sir.
Hello, boss. How are you?
Thank you, sir. I'm fine, and I was watching all the procedures, fine procedures. One questions from my side.
Please.
And there is no need of malleus in this conductive mechanism in this case. So why you are keeping? Because if you can see
Because
the
this
ventilation.
holds the graft. You know,
Yeah.
what happens normally in a normal situation?
Yeah.
Malleus envelops the graft. It envelops the tympanic membrane to transmit the pulsations, the hearing further. Here it is holding the graft to prevent its lateralization or medialization. to keep my keep my graft in contact with the entire tympanic membrane in place, it helps it. Now see, lastly, after having done everything, I will place my cartilage.
Okay.
Just a minute. Give me a small piece of small piece of gel foam. See, everything, the middle place is good. So your point is valid. The value of malleus, once it is not included in it, what is the value? The value is to keep the tympanic membrane physiologically in place.
In other way, some researchers say that if you are keeping malleus in this way, there is a chances of getting blocked the narrow ventilation pathway supraaortic region.
No, that ventilation pathway we have opened wide here mechanically.
Okay.
That can happen if you have a intact tensor fold, you have a compromised isthmus in that situation. But here we have opened it mechanically so big. Gel foam.
Thank you, sir. Thank you very much for nice.
Thank you. I know these questions are very relevant. Dr. Sanjeev is a renowned endoscopic otologist. He does a lot of endoscopic otology surgery, and in that, the ventilation pathway is always a very, very important thing to discuss.
Okay.
Very important insight from him. He is a dynamic secretary of the association there. Thank you, Dr. Sanjeev, for being actively involved.
Okay, sir. Thank you.
See now what I'm doing. Before placing my cartilage, 1 or 2 gel foam pieces to keep my, this sandwich in place anteriorly and anterosuperiorly. Can you see? Rest I'm elevating now. See this. Rest I'm elevating now. See the graft. It is so fresh. I haven't crushed the graft at all. And now my next step is to place the cartilage in place and come out. The next case is ready. That is a mucormycosis. I told you.
Yeah.
See, simply we have already checked the dimensions, required size and everything.
Yeah.
See the facet there?
Yes.
First place in the facet. There. And then deposit it over the incus.
Yes.
Malleus. Oh, sorry, the stapes. See this?
Stapes head.
See now the mobility.
Yeah.
And see, it is in the entire length of the graft. See that? See like this. It is in the contact with the graft, the future tympanic membrane all the way.
Yeah.
And this way, this is sandwiched between the graft
and the stapes head.
Inner surface. The stapes and the inferior annulus.
Yes.
It gives an amazing contact, very, very stable. So it's a zero cost osteoplasty. No foreign material. See how the cartilage is so stable.
Yeah.
I can elevate it and show you again. See this. It will never ever mobilize. See this most stable assembly I can think of.
Yeah,
and more
100%.
importantly, it maintains the middle space. Can you see all the way?
Yeah, exactly.
Even if your middle surface is a little bit raw someplace or anywhere, you don't need any silastic or anything.
And sir, one situation where a stapes is not present, then how you will arrange this?
I would show in one of the case of the cholesteatoma today.
Okay.
That is the most, I would say, from osteoplasty, most difficult situation what you have asked, when no stapes. So we make a cartilage with a joint to give a malleable assembly, and that is something wonderful. Believe me, I will show in the other case. See now, finally.
Yes, sir.
The final picture of the drum, the cartilage, the fresh graft you can see. I hope the picture is clear there.
Excellent, sir.
Yeah, excellent.
And this gives us hearing within 15 decibel.
Yeah.
We have done in thousands of our cases, and you can see then your cartilage through the tympanic membrane absolutely fine in place. See this, the advantage number 1.
No foreign material required. This is so stable, unlike the TORP or PORP. In the ISOCON, we have shown you one revision of the TORP or the PORP, which got displaced because of instability. And see the amount of middle ear space it has created. What I'm using, the available blood in the field, soaking this gel form and placing it all around on the periphery first to tighten my racket, to tighten my sandwich all around. See this?
Yes. Hello, Dr. Jain.
Yes, sir.
I am S.K. Jaiswal, retired professor HOD NT PMCH Patna.
Sir. Good morning, sir.
Good morning. And I watched your demonstration. Very good demonstration and very good approach.
Sir, thank you.
And really, you are great.
Thank you so much, sir, for sparing your valuable time. So senior people are, so keenly involved. It's amazing to see. It's inspiring.
Okay, fine.
See now, my simple placement of the gel form, which is very important without displacing anything below. First place all around the periphery, and then you can fill up the canal. Ensuring no raw areas in the canal. See this?
Yeah.
Your incision for the canal. See this?
Yes.
See this? Margin to margin approximation, leaving no raw areas for secondary intention of healing.
Yeah.
Graft is very well supported by the cartilage all the way.
Yeah.
Very well supported by the cartilage, and cartilage is very well sandwiched between both the surfaces on either side, the stapes and the inferior annulus, and all the way laterally by the tympanic membrane. So this way, everything is supporting each other.
Yes.
And one more thing I would like to add, Dr. Satish,
sir,
that this graft is stabilized from both ways.
Yes, sir.
It
All
will
around
neither
over the
medialize
mucosal layer and the
nor
canal.
lateralize.
Yeah, it will neither lateralize nor medialize.
Yes.
It is very well supported. And
yes.
Sir.
Hello. Hello.
Hello. Yes, Dr. Satish.
Yes, sir.
You are audible.
Without wasting time, we move on to the next case.
Dr. Satish, I will like to read some of the comments by Professor Dr. Majumdar.
Sir.
He writes, Dear Satish and all my old and young friends of old United Bihar, I was well connected to Chhapra in childhood and Devghar Madhupur in my younger days.
Majumdar sir has always been
it is
kind.
so. Very, very sunny good morning from Cyclone Pondicherry. Satish is great, and he continues, he says, being an ABR fan and disciple since late 60s, practiced his famous bow and arrow technique, tympanoplasty, since 80s and was very happy with it. Blue elastic cartilage with perichondrium is ensured for long survival. This I wanted to just share.
Yeah, thank you. Thank you, Majumdar sir, for your input. He has always been kind to encourage us. He's, you can imagine, one of the most senior ENT surgeon in the country. He's 87-year-old. So amazingly active.
I never knew this, that he also had his childhood in Bihar and Jharkhand. So this is another connection to Professor Majumdar sir.
Sir. Now coming to the next case, sir, without wasting time.
One more question Raju Pachori has asked. How often you use elastic sheath?
Very, very, very infrequently.
Yeah.
In situations when you have adhesions for the promontory which you separate and leave a lot of raw areas on the promontory. In that situation, elastic sheath is useful. We are now running out of short of gel film. Earlier, I started using gel film as you don't have to remove it; it absorbs. The cost is a limiting factor.
But always to be removed, no?
With this cartilage in place, with a silastic going below the cartilage,
the chances of extrusion of the
Mhm.
silastic coming in contact with the tympanic membrane are rare. You can safely use the silastic in case you want.
Okay.
Dr. Satish, there is one question from
Elastic
Dr. Ashwini Kumar Verma.
Sir.
He asked how mastoid exploration helps in improving the take of the graft. In some surgery, adductus is closed with fat and patient does not develop TM perforation.
Sir, can you repeat? Sorry, I couldn't hear it completely.
How mastoid exploration helps in improving the take of the graft. In some surgery, addutus is closed with fat and patient does not develop tympanic membrane perforation.
Okay. So this question comes from a very senior person, Dr. Ashwini Verma. Convey my regards to him. See, the reason behind exploring the mastoid is to ensure patency of the mastoid air cell, which is required down the Eustachian tube in a normal situation. So this is just a test to ensure patency. In case it is blocked, you can go and open it like we did today. Now, suppose if we leave it blocked, it's not hard and fast. Sometimes the mucosal edema resolves after the, the grafting the tympanic membrane, the infection edema resolves if it is there, and you may get away without giving any problem.
Yes.
But leaving this mastoid block is something inviting problem, which something you can avoid on the table. This definitely improves the take rate of the graft. As I said, from going from 90 to 99 calls for a lot of things, and this is one of them.
Yes.
It is always better, advisable to ensure this patency to rule out any chance of failure from this side. There are so many regions to failure. So many regions. Eustachian tube is one region. Your grafting pattern is another region. And the quality of graft is another reason. The way you freshen the margins, you place the graft is another reason. And this, patency to aerate the air cells is one of the reasons. Why not to rule out this simple region, which is avoidable. This is practically mechanical, which you can simply rule out in not more than a minute or two. That is the reason behind that.
Doctor, second this comment, but just one thing, there was something written that if a mastoid is cellular, probably you can expect that it is having a good ventilation and you need not to do the water test or see. But in a sclerotic mastoid, you must do it. How you agree with that or disagree with it?
If theoretically,
if it is a sclerotic mastoid, you must explore and you must see the patency. But if it is a cellular mastoid, it is supposed to be, well ventilated. Will you take that or no?
I agree to your point that the pneumatized mastoid itself is an indication for the aeration.
Right. Mm-hmm.
But see, the point is, it doesn't take for a minute or two.
Yeah.
To ensure
so why to take a chance and be sure about it?
To ensure 100% on these on the table rather than assumption and presumptions.
Right.
So just to rule out that possibility.
Yeah, just one last comment from John Sado of Australia.
Sir.
He has appreciated our endeavor and said, we all learn a lot from your webinar, and thanks to the team who have organized it. And Dr. Satish Jain, he is a great teacher and improve the skill of both budding and experienced ENT surgeon. I fully agree with him. Thanks, Dr. John Matthew from Australia, to participate in our webinar.
Thank you, Dr. John Shadow, who has always been part of our webinars, who has been very, very in the forward league to be part of academic activities and contributing. Thank you so much.
Yeah, so now we can move to the next case.
Discussion. Sir, we can continue question during the next case as well.
Yeah, that's better. Yeah, please.
We're short of time because what is this? Man, remove this. Hello, audio visual. Okay, look. Remove this. So this next question, next patient, can you hear me, sir?
Yeah.
It's a very interesting situation. I purposely kept because this is a dreaded disease which has a definite mortality in some percentage of patients because of the regions of immunocompromised situation. Mucormycosis. We have, discussed a lot of time in our previous webinars.
Yes.
And this is the opportunity to demonstrate some fine things about the surgery for mucormycosis and the reason for surgery. And believe me, in the next 5 minutes, I'm going to focus on one thing, which is decision making in mucormycosis management is an MRI. MRI, which gives you everything about the decision making. If you are doing mucor surgery without MRI, it may be a joke to your patient sometime. You never know what exactly is required to be debrided. So number one, what exactly this disease is? This disease is, which is prevalent in immunocompromised patients, maybe diabetic most commonly, maybe organ transplantee who are on immunosuppressant medications, or any immunocompromised situation, wherein this fungus happens to, invade, and it preferentially invade the vessels. As compared to the other invasive fungal situation like aspergillosis, this has a special, affinity to invade the vessels. And once it invades the vessel, it gives vascular necrosis. So what happens? Wherever the vessels are involved, plugged with the fungus, plugged with the fibrin plug and the fungus, the rest of the blood supply beyond that vessel is gone and gives vascular necrosis. And this fungal disease is a medical disease wherein amphotericin B is the treatment of choice. It's a pure medical disease. It's not surgical disease. The role of surgery is to remove those necrotic areas where the amphotericin is not able to penetrate, because the amphotericin has to penetrate through the vascularity. Since the vessels are plugged, how will the amphotericin reach to the fungus in those necrotic areas? So the role of surgery is to purely remove only those areas where there is no vascularity. Where there is vascularity, no need to remove those areas. Just simple give amphotericin, it will work like magic. So how to ascertain this? What areas need to be removed, debrided? What areas need to be left from debridement? Unnecessarily giving morbidity of surgery is to be decided by MRI. The reason is, in a contrast MRI, where the gadolinium is given as a contrast agent, wherever gadolinium is not reaching, there is no contrast enhancement after the gadolinium, because the vessels are plugged, gadolinium is not reaching, no enhancement on gadolinium. Those are the areas need to be debrided. Where the amphotericin is not going to reach, where the gadolinium is not reaching, simply the amphotericin will also not reach. And the areas where the gadolinium is giving enhancement, that means the gadolinium is reaching, the amphotericin will also reach. There is no point in debriding those areas. So that is how the role of the surgery decided in mucormycosis. Let me show you something. This is the T2 weighted MRI. On the other side, I will place a contrast MRI. Now see the difference. What I am getting, what I am trying to show, what all areas need to be debrided, all areas not need to be debrided. See this. This is the fungal element on the right side. Let me come from anteriorly, more anteriorly. See now, the more anterior areas, compare on both sides. This is a biopsy proven. Yesterday we took a frozen section and proven as a mucormycosis. This is the maxillary sinus. Compare with the contrast also.
Yeah.
Now this is the area of the turbinate where the tumor is. And see, this is what happening. The patchy contrast enhancement. Patchy contrast enhancement. Not clearly. Patchy. And all invaded and expanded. Now more importantly, the floor of the orbit, you can see showing patchy non-enhancement. Patchy non-enhancement. And more importantly, as you go behind, see now, this is maxillary sinus. Now behind the maxillary sinus, see this fungus is
extending to the infratemporal fossa. See this infratemporal fossa. And what is there in that region? Lack of contrast enhancement. Can you see?
Yes.
That is the area where the contrast is not reaching. Your amphotericin is not also going to reach.
Yeah.
And if you don't debride this, this is going to kill the patient. This is a killing disease. This can very soon, in no time, it can spread to the orbit and then to the brain. This week, we have debrided 4 mucormycosis. This year, 70 cases we have been able to save. And simply the reason was MRI. We need to see on MRI which all areas see lack of contrast enhancement. Now see, compare with the opposite side, simply. This is the region of the pterygoid on the other side. See the pterygoid muscles?
Yeah.
And this is the region of the pterygoid. See all this disease, which has completely destroyed the pterygoid.
Yeah.
And if we don't debride this, we are not going to succeed in this, outcome, in getting outcome for this particular. This is my target. This is my target for this patient, number 1. Number 2, look, very important, look at the palate. Look at the hard palate coming from anteriorly. Look at the hard palate on this side. See the palate on this side enhancing. Can you see?
Yeah.
Yes.
And this palate is not enhancing on this side. Completely not enhancing. This entire palate is destroyed. Now posteriorly this is soft palate. See, this is soft palate. Coming anteriorly, this entire palate is not enhancing. The opposite side is enhancing. See this?
Yeah.
Even more than, crossing the midline, this entire palate is necrose. Not enhancing, no gadolinium reaching.
Yes.
No amphotericin is going to reach. And this is all full of fungus. And necrotic areas will need to be immediately debrided. This is like a poison, it needs to be completely removed. So the goal of surgery in this particular patient is to debride these necrotic areas where the amphotericin is not reaching. Now, for example, the fungus is suppose going into the orbit, but it is enhancing. That means the amphotericin will also reach. You don't need to debride the eye unnecessarily. If you find any necrotic area, you go and debride. We have debrided several eyeballs with the micro debrider only, no necrotic areas, no vascularity. You can go on with the micro debrider and debride it. Convert, change to corona. Connect to power.
Excellent, Dr. Satish. What about contrast CT? Is it going to give, because gadolinium contrast may not be available at all places. So what is the role of contrast CT in these cases?
Yes, I got your point, sir. Actually, CT is never a choice for the soft tissues. CT will never be able to differentiate into soft tissues what exactly it is. So it is always the MRI which is decision making.
Yeah.
MRI decision. Now, just in last 2 minutes, about the last 2 cases we have done. This one we did yesterday. This was what this? No.
Is this the one you were talking to me about?
About?
Is this the one you were talking to me day before yesterday night?
Not really, sir.
Okay.
Yeah, yesterday night, yes.
Yeah.
Discuss. I told you.
Yeah.
Let me show you. This is Jyoti. Sarika. I forgot the name of the patient. So the idea is whatever soft tissue, whatever tissue involved,
that has to be excised, because
if it is extending to the, the soft tissues of the face, you need to debride them. There is no question not to debride any area which is involved by the mucor. If mucor is involving anywhere, you need to debride it. So the case is ready. After this, I am going to the case.
Yeah, I think
This
that's
particular
better.
patient,
Yeah.
this was a child, 12-year-old child, 7-year-old, and see the area involved, loss of contrast enhancement. See this, going to the soft tissues, going to the eye,
Yeah.
infratemporal fossa, eye, and the anterior facial soft tissues.
Yes.
See this?
Yes. Yes.
This entire area was debrided and the child is doing so well. Saving the eyeball, saving the vision apparatus, which was not involved.
Yes.
Only the inferior rectus, all this is involved, which was debrided.
I think this is the greatest advantage of MRI because you
MRI.
can preserve the eyeball, which
you know
otherwise you cannot make out.
Yes.
Yeah.
Exactly, you know what need to be debrided, what not to be.
Yes.
Because if you debride unnecessarily the enhancing area, it is going to add on to the morbidity.
Right.
Because in all those enhancing areas, your amphotericin will penetrate as well. If gadolinium is penetrated, your amphotericin will also penetrate.
Yeah.
As simple as that. So we need to be very, very clear which area need to be debrided, which area need not to be. See this particular patient, the facial soft tissue here necrotic, no enhancement.
Yeah.
See the maxillary wall, the bone completely necrotic.
Yeah.
And this in continuity went to the soft tissues and the infratemporal fossa muscles, all got necrotic, which we needed to debride.
Yes.
And the patient is doing well. If you leave any non-enhancing area left undebrided, the patient is never going to do well. Believe me. This is going to spread like anything and patient is going to die. And that's why the mucor is considered fatal. In the past literature where MRI was not used to be considered as a decision-making thing, the mortality in the literature has been up to 80%. But now in the contrast, in the present situation in our hands, the mortality is less than 10%. Believe me, using only and only MRI.
Dr. Satish, at this point, should I ask you why the incidence of mucor has gone so high? Because I remember in our Patna National Conference, I presented a poster for which I was awarded gold medal. It was rhinocerebral mucormycosis. That time, the total reported cases in India, if I remember correctly, were 100 odd number. So, over a period of say last 15-20 years, why the incidence is so high?
Yes, that I tell you the reason. Your point is valid. The incidence has increased. The incidence of immunocompromised situations have increased. One of the reasons.
Yeah.
More and more, you know, the number of transplants have increased.
Yeah.
Not only kidney transplant, liver transplant, heart transplant, and so many organ transplant is increasing day by day, and all those patients are on, you know,
immunosuppressants.
Immunosuppressive medication.
Yeah.
Number one. And number two, the diabetes. The incidence of diabetes, you all know,
yes,
has been increasing. And that is one of the major reasons behind the increase of these muco patients. So many other diseases, immunocompromised conditions have increased. Number two, like the last patient I told you the day before we operated, had because of nephropathy, diabetes leads to nephropathy as well. Sometimes clinical, sometimes obviously overt clinical. That patient had a creatinine 9.
Yeah.
Since we have to start amphotericin, though liposomal still has a nephrotoxicity.
Yes.
That is something, a complex situation sometimes. You have to keep the patient in a nephrologist observation on repeated dialysis, because anyway you have to debride, you have to give amphotericin. That you can't compromise to save the patient. Leave the kidney for dialysis and other management parallel. But you can't delay the treatment. If you delay, this will progress to the brain.
Yes.
So that is one thing one has to keep in mind. Even post-operatively, once you start amphotericin, maybe liposomal, sometimes it, it gives the kidney, the creatinine going up, and that is one of the reasons you need to keep a close eye, but don't stop the treatment. Are you getting the endoscopic picture, sir?
Yes, very good.
See, this is the right nose, and see the necrotic areas.
Yes.
See the black eschar. No blood supply.
Yeah. Actually, Dr. Satish, those days when we used to operate was the you remove all the black areas, see the viability of the tissue and go ahead. That used to be our approach.
Yeah.
Because earlier we were not so sure about how to proceed with it.
Now see the palate, sir.
Yes.
See the palate on the right side, completely necrosed.
Yeah. Yeah.
And see, tongue depressor means depress the tongue. See the palate on the right side. Even crossing the midline is completely gone. It has to be debrided. Got my point?
All the black patch with some margin.
Yes. All non-enhancing areas, all necrotic areas have to go. As simple as that.
Yeah. Yes.
Now see the necrotic areas towards the maxillary sinus and behind that.
Yeah.
So now let me start.
Yes.
Removal of this and going quickly. Our next case is going to be a parotid surgery.
Yeah, that will be. Actually, I think the incidence of mucor is still in our part of the country is not very high. Yours being a high volume center, referral center, you are getting lot of cases. But probably somebody from Patna may comment if they are getting lot of cases. I don't think so. Dr. Chansekharji and Ashok sir.
Occasionally, very occasionally.
Very occasionally.
Very occasionally.
Yeah.
No,
actually, when you are doing regularly, the result and your approach will attract the cases from different city of the.
Exactly. No, that is what I said. My question was the incidence in our area is not much because we hardly got to see a case once in few years. So that I wanted your opinion. Being a referral center and a high volume center, you will have lot of cases.
You are right. You are right. We are having a less incidence of this.
Yes.
But I don't think the incidence is less.
Yeah.
I don't know the trains, the area wise on all those things, but.
Sir, can I add on this? Sorry.
Yeah, please, Kranti. Yeah.
Okay. Sorry, I was perhaps confused and on a different link.
Hello,
so,
Dr. Kranti.
Hello. Good morning, sir, and welcome to AOI Bihar Jharkhand conference. Sir, actually, the incidence, it depends where it is presenting. So, multi-specialty centers where you have especially endocrinology departments and departments dealing with immunosuppressed conditions, the incidence of mucor is high.
Transplant surgery department, there the incidence is more.
So all these places, incidence is, I would not say that it's less. It depends where it is presenting. Like now, since we are having all those departments functional, we are getting mucor cases to, so wherever you have
like say in last 4 years, how many cases you have encountered, Dr. Kranti?
No, so we have started doing it now on I think last 2 years we have had few cases of mucor. Okay, unfortunately, we had one patient of mucor, a young boy, in COVID, when we started COVID, and we were doing both COVID, non-COVID. Okay. And we had a young boy which we suspected as mucor, and we actually lost the patient. Ultimately, it was an 18-year-old boy. He ultimately developed intracranial complications as well. So mortality.
That's a good input. That is basically. That is the good input, because this is what I wanted to emphasize, that this disease is now no more area specific, as Dr. Satish has said. So one has to be vigilant. Usual presentation sometime to begin with may be just a black patch. And so many a times the cases who comes to you are in a much later stage. Yeah. Am I right?
I tell you, sir, I tell you the simplest, earliest way to diagnose the mucor. Every immunocompromised patient, particularly diabetic patient, because diabetes is the commonest immunocompromised situation.
Yes.
Any diabetic patient coming to you in OPD, we have diagnosed so many in the earliest situation. Coming to you in your OPD with some abnormal sensation in the nose and the face. You put your endoscope and you find excessive crusting.
Right.
Or mycosis. That is the earliest diagnosis.
Yes.
Because otherwise, the moment these patients you get late in the advance in the course of disease, the difficulty the treatment. What I have done until now quickly is just the exposure part. So I just it quickly.
Yeah,
Without wasting time. What I have exposed, the area, because my goal is to remove the dead areas. Now, which I will show you what I have seen on MRI.
Yeah.
This is just to improve the field, improve the access to all those areas. You can see the posterior wall of the maxilla and the posterior wall of the maxilla, and behind that region has necrosis we have seen on MRI, which I am going to show you. And this is the area which is most often overlooked by the surgeon if they do without MRI.
Yes, that is very important. Yeah.
Cannot pick up. CT scan cannot pick up this soft tissue disease.
Yes.
So MRI just before the surgery to ascertain the extent of, debridement, and then after the surgery to see any non-enhancing area left. On slightest doubt, take the case back to the theater and remove that. Because on those areas, the amphotericin is not going to reach at all. This is the disease, medical disease where amphotericin is the drug of choice. But what you do when amphotericin doesn't reach is what we are doing here, operating.
Debride the thing. Debride as much as you can, which is...
Yes. So now, this is my initial exposure, which I am now taking forward to the disease removal. This is my lamina papyracea, you can see.
Yes.
Sir, would you enlighten us about your orbit management in case of mucor patients who have lost vision, and what do you do? Would you actually take away, because we have had some very extensive mucor cases in which literally the ball was gone, and if you
I tell you, in the beginning I was little conservative about the orbit.
Yeah, but now
as long as the vision was good, we did minimal debridement. We did minimal debridement and preserved the orbit many a time earlier.
Yeah.
And few of the patients we lost as a little area, necrotic area left, the fungus progressed, went to the brain, cavernous sinus and lost the patient. After that, we have become little aggressive about the orbit. Now, even if the vision is good, if I have a disease which has gone to the orbital apex, given necrosis, or to the areas which need to be debrided irrespective of the vision, we need to take a call to save the patient. It is the life which is more important, which is otherwise under danger. So don't leave the necrotic area, number one. Now, if you have a disease gone to the orbit, with enhancement, you don't have to be very aggressive. If those areas are enhancing,
there are a lot of background noise. Please mute yourself, the person who are not speaking. Please mute all. Only the person speaking should make it unmute. Yeah.
Now see,
Go
sir,
ahead,
what I was saying. Can you see the posterior wall of the maxilla? Can you see the black areas?
Yes, it is very clearly visible.
How would I get to know? By MRI.
MRI.
Now see those necrotic area where it is. I told you the pterygoid. Region of the pterygoid. See this all necrotic behind here. See this all necrotic. This is all mucor.
Yeah.
This is all pure mucor.
Yeah.
This entire area.
Point well stressed that CT scan doesn't pick up these.
Never.
And it is a postgraduate question also. So what to get in mucormycosis
MRI
and CT
is
scan.
life-saving.
Yeah. Yes, true, sir. I totally agree.
See now, this is all necrotic area. Can you see?
Yes, very clearly.
Yes,
seen.
yes.
The typical mucor appearance of white ischemic tissue is gone. Yeah.
I know all these areas which are involved because of only MRI. Give me luck.
MRI.
And now see the hidden areas coming up, which are most often overlooked. My purpose of keeping this case was this only. See the bone.
Yeah, it will completely go off.
Yes. This is all necrotic bone. Believe me. See this.
Yeah.
And what is there behind? See this, all necrotic.
Yes.
All hidden in a box. See this bone, it is necrotic. A normal bone you can't pick up like this.
Yes.
All involved. And I knew this because of MRI.
Yes.
So what is the vision status of this patient?
Vision is good.
Because what are you going to do about this? Because I think this will go to the orbital.
Yeah, it is going to the orbital floor.
Yeah. Yeah.
We have
Not
told
the
the
apex.
patient, we have told the patient, most likely will preserve your vision.
Okay.
We may have to, you know, if involve these muscles in extraocular. See all this necrotic.
Yes, yes.
Yes, yes.
How does it work?
So would your because amphotericin, as we know, you can give maximum to 3 grams, or maximum at max when your serum creat starts rising. So what will be your protocol for amphotericin if you are planning to?
That's again a very important person who is dealing mucor. Actually, those person only can ask this question. Amphotericin, it is a myth. Let me tell you, it is a myth. See the orbit.
Yeah, it's almost
in the orbital
bad.
floor.
Yeah.
I showed you on MRI. It is going to the floor of the orbit towards the extraocular muscles.
Yes.
See the bleeding areas now. Can you see?
Yeah.
No, it's better.
Bleeding areas, you have to leave.
Yes.
Now, coming to the amphotericin, let me tell you, amphotericin is a myth that you need 3 gram, 4 gram. You can't calculate like this.
Okay.
If you debride all necrotic areas completely, you don't that much of amphotericin. Sometimes we give amphotericin for 4 or 5 days, 7 days. When everything heals up, we step down to posaconazole.
Yeah.
So if you debride thoroughly the complete, necrotic areas, you don't need amphotericin for long. Number 1. Unnecessarily, cobbleter.
Okay.
You need amphotericin for all those enhancing areas, and that minimum 4, 5 to 7 days is good enough to tackle those once the amphotericin is penetrating there. If it is not penetrating, you give for a month, nothing will happen. It will not work.
Dr. Satish, do you start amphotericin at the beginning the patient comes pre-op only? What has to be our usual practice that is
No. We start amphotericin as soon as the patient...
Then work up the patient, get the...
Yes. See, our hospital...
Yes, that is what our practice used to be.
Yeah. In our hospital, when the patient comes with a suspicion of mucormycosis, the first thing on the very same day...
Start on amphotericin.
First thing on the very same day, we take a biopsy.
Yeah, we take a biopsy first. Yeah.
Send for frozen section.
Yeah.
Yes. Yes.
Frozen section will clearly tell you what broad accepted fungi mucor is not there or not.
Just send for fungal staining.
Yeah.
In half an hour's time, we confirm a diagnosis on frozen section. And immediately start the amphotericin and prepare the patient for surgery with all due, see all this necrotic area in the infratemporal fossa.
Yeah, ITF is totally
gone. See this all non-enhancing area. See the bone.
Yeah.
I'm able to break with my mic. See all this mucor?
Yes.
Yeah.
How could I pick up MRI?
Yes.
This one can easily overlook and leave behind. And that is a joke to the patient, believe me.
Actually, this is more lethal than any of the malignancies in that area.
Yes, it is so fast progressing. In no time, we have seen the disease going to the brain.
Yeah.
2 of the patient this year, when the disease had gone to the temporal lobe, half of the temporal lobe was replaced by the mucor, and we had to do some temporal craniotomy. See this all necrosed tissue.
Yes.
Subtemporal craniotomy, and remove the fungus with our hand, with our palm, completely removing the necrotic areas. See this all necrotic tissue. What will amphotericin do to this necrotic tissue? Tell me.
They will cause end arteritis and further progression of the disease.
Sir, there is no blood supply.
No.
Where will amphotericin reach?
Yes, that is there. So it will keep on expanding,
Yes.
Dr. Satish, what are the important structures to be taken care of in this area?
See, sir, in this area, Forget about the vascularity, number one, because vascularity is preferentially targeted by mucor.
Yes.
So don't scared of the sphenopalatine artery, this and that. If anything comes in the way, you can tackle that.
Yeah.
But most of the time, it is already gone by the mucor. Number two, as long as it doesn't involve the critical cavernous carotid or anything, you can go on debriding.
Yes.
Orbit, you should always have a consent. In spite of a good vision, you must have a consent that you may have to debride in case you find intraoperatively the need.
Okay.
Yes.
That should be the first consent. And we have, unfortunately, had to take this decision of debridement of a seeing eye with a good vision to
Yeah.
save the life. Learning from our own less, failures, leaving the eye because of the good vision led to the mucor spread to the brain. Life
Yes.
is more important. You need to tell your patient. Pandan.
So basically, that's where the area from the orbital apex and so earlier, whenever we used to do complete exenteration, when you see the orbital apex, everything is necrosed. So it's almost like the potassious material which you are, necrosed material which you are.
Many a
You
time.
get it in the apex here.
But in that case, the vision already will be gone if it is gone up to the orbital apex.
Yes, many
But
a time
Dr. Satish,
vision
what
gone
you
up
said
to
about the eye with the vision, so how you decide that with the vision eye up to what extent I should stop? Because it has not gone up to the apex.
Yes, in that situation, with this exposure, you keep on debriding until you get the vascular tissue.
Right.
That's why I told you we should always have a consent of this. See this is the eyeball here. We have debrided with this micro debrider many a times the eyeball like this in mucor.
Yes. Okay.
The good tissue, vascular tissue coming up laterally.
Yeah. Yeah.
I want bleeding.
Yes.
I want bleeding tissue at the margin everywhere I leave.
Yes.
To ensure that my amphotericin will work.
Yes.
All necrotic areas have to go.
Yeah.
See this now laterally the good bleeding areas have come. See this?
Yes.
See this area? It is not necrosis.
Yes.
Necros areas I am using very freely the micro debrider.
Yeah.
Now see the pterygoid fossa.
Yes.
See the pterygoid process, and this is affected. See that?
You're going to remove that as well.
Yeah. See this? See this? All necros. See the tissue I am removing is all necros.
Yes.
Yeah.
So my
anything which is not bleeding, you have to remove.
Yes. So my target is very clear from my MRI. See this?
Yes.
You can't remove the pterygoid bone so easily like this.
Yeah, usually you need a drill. Or a
Yes.
chisel.
Need a very high speed drill.
Yeah.
Remove that. You can't remove like this. It's all mucor. And I knew this from my MRI.
Yes, yes.
Even a slightest portion of the non-enhancing area you leave behind, whatever good job you have done, can be an utter failure. So immediately after debridement, it is our protocol to get a contrast MRI done.
Okay.
And that is always
do you
a
go
problem.
back again, sir? Do you go back again in case
Yes,
if you have...
yes,
Okay.
without thinking twice. And the problem comes, from the kidney side many a time.
Yes.
Patient may not be suitable or not fit for
we
anesthesia.
give.
For contrast, they might not be fit, and that
Gadolinium
becomes
is
a
never
problem.
a problem. Gadolinium
Yes.
is not iodinated contrast.
It's a non-iodinated.
Yes, non-iodinated contrast. So gadolinium is never a problem.
Yeah.
Yeah.
True.
This is all.
So for the palate, which obviously needs a complete debridement, in cases, do you use obturators post-op?
Yes. Palatal obturator prosthesis we will use. There is no other choice. What you can do later on once everything heals up.
I think there is no role of reconstruction, immediate.
No, not
Dr.
immediate, sir.
Satish,
No
is there
immediate.
any place for?
Yes, sir. That's what I'm saying. In immediate post-op,
Yeah.
no reconstruction, because we want to see the necrotic
Right.
areas under vision.
Yes.
Later on, once everything heals, patient gets all right and wants, you can give a free flap for the palate.
Yes.
That can be
So
done
that
later.
too, I think we'll have to do it much later when the vascularity is some. For
Yeah.
free flap, you need a good vascularity.
Right.
See this necrotic region. See this.
Yes.
See how you have to pick up.
Yes.
See this
I think
wall.
I think this is the area at the base of the sphenoid.
Yes. This is the base, the part of the sphenoid bone. Laterally, the pterygoid process, below the pterygoid process. And see, I am very, very radical about it. See the nerves. See the nerves. See the median canal.
Yes.
Median nerve.
Yes. Yes.
Doesn't matter. Now this is good area. Good, just behind is the carotid. See here the sphenoid sinus. See the sphenoid I already opened
Yes.
for my reference. And this is my reference. This is median canal.
Yes.
See above now the area is good. All bleeding area.
Yeah.
Everywhere I will see the bleeding areas until I completely get through that drill. The surgery for mucor is very rewarding, provided you know what exactly to be debrided. It should not be overdoing.
Dr. Satish. Yeah.
Yes, yes, sir.
Dr. Planyapan has asked from Trichy, vision is there. How will you take care of ophthalmic artery to protect optic nerve when you debride? I think you have already answered that.
Yes. So if the ophthalmic artery is already involved,
Yeah.
the vision would have been gone completely.
Yes.
But yes, if the vision is good and you are going debriding all the way, reaching the ophthalmic artery which is not involved can lead to bleeding. See, there the question is, if your major part of the orbit is involved, necrotic, you have to remove it. You have to sacrifice
Yes. No
it.
point keeping it.
Otherwise, you will lose patient.
Yes.
Yes.
See this greater wing of the sphenoid I am drilling.
And moreover, I think the ophthalmic artery bleeding is not at all a problem.
Yes, yes. Except carotid, any artery you can tackle. See now the normal bone coming into picture.
You can tackle, yeah.
Can you see this?
Yes.
See the dura below.
Yes, yes.
Yes, dura can be seen here.
That is the temporal dura.
Temporal dura.
I am very, very radical about this bone removal. I don't want to leave any single necrotic bone.
Yeah.
See
You are
this?
working with a stylus, Satish?
Yes, sir. High speed stylus, our favorite.
Dr. Satish, many people have asked the same question. Dose of amphotericin and its duration.
Yes, let me tell very clear. Our amphotericin dose is 5 milligram per kg to give it a full dose. We always prefer to give it a full dose, except the limitation coming from the kidney. Now, full dose means we start the injection of liposomal amphotericin comes with a 50 milligram vial. 50 milligram in each vial. So we start with in adult patient roughly, rather than per kg, 250 milligram to begin with.
Okay.
See, all this is dura. This is dura.
Yes.
Temporal dura. This is sphenoid sinus. This is the pterygoid base. This is your, looks like V2 here. V2 in the floor of the, middle fossa. See here. The VDN we have divided already. See this V2. This is your foramen rotundum. VDN was here.
Yes. Yeah.
See my all bleeding areas. Can you see? That is what I want.
Yes, sir.
I see the entire surface.
We are happy with the bleeding areas than with non-bleeding areas.
Yes. Laterally, I am not sure, so I will do a Dankers now immediately to ensure that it should not leave. See all this bleeding. This laterally, I am not sure here. So I will do a Dankers to get me good exposure. You have to be very careful, give time not to leave any necrotic area. See now, my pterygoid process is not existing at all. Now see, completely drilled away in the upper part. Lower part, this could be, which I am removing. See this? All necrotic. See this? All necrotic. Debrider. Once you remove the necrotic region and amphotericin start working, it's a magic. These people respond so good. अरे फ्रोजन भिजवा दे दोबारा गंजे के. See this? Now I will do my Dankers and see my lateral part. I am not happy with the lateral exposure. Immediately, without thinking twice, I can complete this in no time. And this is the situation warrants. Hello?
Yes, sir.
This is pyriform aperture. See this pyriform aperture?
Yes.
And see, I suspect some disease still there laterally. I can't take a chance.
Yeah.
See this? See this? This is mucor.
Yes.
Yes.
Yeah. Full chunk of it.
Yes. Not to take a chance. See, endoscope has revolutionized. Your MRI has revolutionized. And imaging without these two things in consideration, what people used to treat the mucor in the past. They were always, in the problem. See now laterally this necrosis?
Yes.
Yeah.
Can you see this?
Yes.
That's why I see this necrotic area.
I think
see this.
In the past, probably we just follows the tissue.
This is necrotic area.
Yeah. Dr. Satish, to answer your question about the past, what we used to do is follow the disease and whatever denuded, debrided tissue you find which is unviable, take it off. That used to be, that's it. And we never knew the hidden areas which are created or seen by the MRI.
Yeah. So if you leave the necrotic tissue in the hidden area,
your whole
will
surgery is of no
progress,
use.
patient will die, and that's why we know this is a dreaded disease. See the mucor.
Yeah, I can.
See, this is nasolacrimal duct invaded by mucor.
Yeah. Dr. Satish, Rajat Jain from Lucknow has asked a question. Can we differentiate between aspergillosis and mucor on MRI?
Yes, very clear.
Yeah,
so that's a very important question from Rajat. Very valid question. See, I told you in the beginning, this mucor has a preferential invasion of the vessels. That's why contrast MRI is a role, because see the disease.
Yeah.
Can you see all this necrotic?
Yes.
See what would have happened if I left it without doing a Danker. It would have been a joke. See all this necrotic. See this necrotic tissue. So Rajat's question is valid, worth discussing, because this mucor is typically, suspected and diagnosed on MRI by basis of necrosis. Lack of contrast enhancement on MRI is the way to diagnose mucor. In aspergillosis is an invasive fungus which is spread contiguously from sinuses to outside with minimal intrasinus involvement and maximum extrasinus involvement with patchy enhancement, because that is not a vascular necrosis. See now, just a minute. See the nasolacrimal duct below invaded. See this? And
Yes,
above,
sir.
oh, it is clear. So I am cutting it sharp over here to prevent epiphora.
Yeah.
Yes, cut sharp over there. Can you see?
Yeah.
Now we have lot of necrotic tissue I can see behind. It's amazing. See this.
Yes.
See this area. See all this necrotic tissue. See this?
Yes. Rajat has asked one more question.
Yes.
Dr. Satish, can you hear me?
Yes, yes, please.
If the mucormycosis, cavernous sinus is involved, then how you should do the debridement?
That is the, I would
Ultimate.
say, the most difficult situation. And that
Yeah.
is how, in those cases, you need to prognosticate your patient, telling them that you have a high chances of mortality. We cannot debride so extensively, the cavernous sinus being the carotid and the cranial nerves being there. Forget cranial nerves, it's carotid most importantly. We cannot be so extensive in a debridement. And if we leave that area without debridement, the chances of, failure are high
Yes.
mortality. So if the patient is prepared, you can go ahead with whatever you can, with the limited or whatever debridement safely you can do. Otherwise, send to your enemy.
The best way. I think nobody will dare to touch other than just I can name few guys in this country, because
See this necrotic tissue. See this
Yeah.
necrotic. How could somebody remove it without knowing from the MRI? Tell me, number one, and without doing this dankers.
Yes.
Not possible, sir.
And then we label the mucor as a high incidence of mortality.
Yes.
The major reason to the high incidence is lack of understanding, lack of ascertaining what area need to be debrided, and lack of complete debridement. So we can, I just purposely put this case so that we can discuss all these things and
Yeah.
improve our, outcome of these patients. See this.
Dr. Satish,
Rest of the areas,
Dr.
rest of the
Akhilesh
areas.
Darade,
Pardon?
yeah. Dr. Akhilesh Darade from Nasik has asked which brand of the micro debrider you are using.
Which angle?
Any special wand you are using for this case, or,
So far
or
I
it is
was
the
using-
simple one, the micro one?
No, I was using in between cobbletter also. Micro debrider straight and 40 I have used so far. I've used the stylus drill from Medtronic.
Yes.
Using the
So nothing special about
possible thing
nothing special about mucor. Then Sanjeev from New Delhi has asked, has radiation any role? I think there is no. Has radiation any role?
Hello.
Has radiation any role? No, there is no no role of radiation. So
no question.
that's still
No question. Debrider. No question of any radiation. Not to think of.
It is more deadly than any of the what you call carcinomas, but it is not a carcinoma, so it is not a malignancy.
See this necrotic. See, so much of the necrosis is still left behind. To save this patient, I have to remove all this. See the palate below. I need the bleeding surface. See, I am in the infratemporal fossa. See what I am removing is all disease part. See the normal musculature coming in the picture. Can you see the normal fat plane coming in the picture? Hello?
Yes. Yes, yes.
That is how you are certain that you are debrided adequate in that region. And now give me chisel and hammer. See, in the deepest part of the infratemporal fossa I am working, the part of the zygomatic bone. This patient definitely will have a transient squint. See this bone?
Yes.
This is with a chisel and hammer.
You used chisel hammer to get a sharp cut, isn't it?
Yes, yes.
Yeah.
To get this chunk of bone completely.
Yeah.
Because that region, I need to ensure thoroughly that I don't leave behind. Yeah. See, this is the end. You will see this all bleeding areas.
Yes, yes.
Wherever we have operated, all bleeding areas, all the dead bone has to go. Give me. Avascular. This is pure avascular bone. See this bone.
Yes, yes.
In the COVID times was a challenge to deal with some of these patients who were COVID positive, actually. And developed mucormycosis, and we had to treat some of these patients, operate in the COVID positive phase. Because there was no other option left behind. We can't see them dying with all consent, with all difficulties in mind, obvious difficulties in mind. We had to operate few of these patients with COVID positive status.
Just a non-academic question. How did you motivate your staff to work on a COVID, or yourself motivate you yourself in a COVID positive patient to operate? Because the risk is all high.
I know. I am so grateful to our staff members. They work like army, you know.
Yeah.
Never say no to anything. I am so proud of them.
Good morning, sir. Samit Lal.
Hi.
How are you, sir?
All good, boss. Nice to hear from you. See this
Great.
dead bone?
Yes, sir.
It's so difficult to get out from this angle. Drill. It's such a deep area. This is zygomatic bone I am working at.
Yes, sir.
Nahi. Hi. See this dead bone?
Yeah.
And I need to drill away. Until I get the normal bone. See this?
Yeah.
This is all dead. All this bluish bone is dead bone. This is all avascular. We discussed in detail in our second webinar we did with Pachori boss for the radiology part, and this issue was thoroughly discussed, probably 7th or 8th of June.
Yeah, I remember.
On the radiology, the role of radiology in mucor management, the role of MRI, the drill. See this bone now?
Yeah.
Dr. Satish.
Yes, sir.
One budding surgeon has asked from Muzaffarpur, Siddharth Shankar, will total maxillectomy by external approach give similar clearance? I think the answer is no.
No, no way. It is not the maxilla actually, which is the only culprit.
Yes.
It
Yeah.
is the pterygoid, the greater wing of the sphenoid, infratemporal fossa.
Right.
See the
Yeah.
dead bone coming out?
Yes, yes.
Yes.
See the healthy tissue behind?
Yeah.
Yeah.
Now we see
The beauty of this stylus is the control. See this? How will you ensure this with maxillectomy, sir?
Never possible. That's why I said young and budding surgeon has some query. And yes, we should entertain them to come up and learn, ask questions. That was the precise reason I asked.
Yes. The question is very important so that we should not do that.
Yeah, and secondly, they should feel involved and get some interest in this type of teaching program. That is the main thing.
See this? The tissue behind. It is so healthy behind.
healthy tissue.
Yes.
All dead bone is gone in that region.
Mm-hmm.
See now the area, what it was before. See that?
Yeah.
See this area completely healthy now.
Yes.
All the dead bone.
Entire dead bone has been removed. The entire area is looking reddish, vascularized. All surface is looking vascularized. Can you see?
Yes, sir.
Don't say yes if you are not agreeing, please.
Yeah.
I totally agree with you.
See this now, entire area completely vascularized.
This is one surgery where we are more happy if it's bleeding. If it's not bleeding, we are not happy.
Now I am coming to the palate and this bone. See, this is completely necrotic.
Satish, can you show the orbit area once again if we have cleared that?
Yes.
Yeah, because that is very important for the patient's eye preservation.
Yes. See, this is orbit.
Yeah.
This is medial wall. This
Yeah.
I debrided and showed you the fat.
Right.
Fat. Absolutely normal area, no necrotic. This is floor of the orbit again. See that?
Yes.
Yes.
That's the dura.
Clear.
Of the dura.
Yeah.
And this is all the necrotic bone has gone.
So looking at the MRI earlier and the clinical picture right now, probably we can save the orbit. Sorry, the eyeball.
Yes. Now this is the palatal
Palate
mucosa
area. Yeah.
gone, and now I am going to remove the entire involved part of the palate. Give me gauze and hammer. Osteotome.
There is a question, you see, sir.
Can somebody bring the microscope, please?
Mucus present in the Habersen canals. Will that be taken care of by the amputation B?
Pardon?
Mucus present in the Habersen canals of the adjoining bones.
Yeah.
Will that be taken care of by the amputation B?
See, if the mucor is there, and if it is given necrosis of that bone, then obviously that thing will not work. Now see from below. Now see from the oral cavity side, sir.
Yes.
Please go ahead. Yeah.
Everything good? Microscope.
Yes.
See, everything good? Healthy?
Yes.
And now this is the dead area which we need to remove. See that?
Yeah.
All dead area. See, this entire palate got necrosed.
Yes.
Tongue depressor. Take a tongue depressor like this. Yes. See the dead region of the palate, very clear?
Yeah. Yes.
And now I am going to remove in no time.
Yes.
Give me.
Do you want to get a good margin, healthy margin before removing, or just be guided by the bleeding if it starts bleed?
See this, everything is in your view.
Yeah, so.
No time it has been removed. See this?
Yeah.
This is all necrose.
Yeah, so there is hardly anything. Yeah, yeah,
There is nothing.
yeah,
All macros.
yeah.
We will give a obturated like I mentioned to Dr. Kranti.
Yeah.
See now, my surgery is going to be over in no time now.
Yes.
All healthy tissue. We have a very good prosthodontist
Yeah.
colleague who makes obturator for us, for the eyeball, for the palate.
One question by Muhammad Tabrez from Vellore. Can you hear me?
Yes, yes, please.
How often you bring patient to OT every day to assess and debride necrotic tissue?
Yes.
I don't know.
Post-operatively, you mean to say?
I think that is what he meant.
Yeah, like for this patient, let me tell you.
Yeah.
We will get a post-op MRI today only.
Yes.
Today only, and we will compare with the previous one and critically analyze the areas beyond our debridement.
Yeah.
To see any lack of contrast enhancement.
Yes.
Any such area debrider.
Okay.
We will immediately take up and remove. Now there will not be too massive a disease left behind.
Right.
But still I don't want to leave because this is a dreaded disease. My entire, purpose will be defeated.
If there is a remainder or residual disease left.
Yeah.
There is another.
Areas.
Yeah. There is another question by Salu Gupta from Ahmedabad.
Yes.
Sir, what if a biopsy we get fungus other than mucor?
What could be that?
If we get on biopsy, we get a fungus, I mean, semen fungus culture or what, other than mucor, how will you plan the surgery? Will it be same?
That's a great question which Rajat also asked.
Yes.
On biopsy, we get a diagnosis of mucormycosis.
Yes.
Suppose, aspergillosis. Suppose.
Aspergillosis, not the mucormycosis.
Now my target will be totally different, plan. The reason is like this, amphotericin.
Yes.
Like this mucor, the aspergillosis is also a purely medical disease.
Yeah.
Here the drug of choice is voriconazole. What I will do, I will establish my diagnosis with the biopsy. I'll open up any sinuses blocked.
Okay.
Only my surgery will be of that extent only to open up the ventilation and drainage of the sinuses and start aspergillosis. I will not be radical to remove the entire fungus at all.
Exactly.
Because that's a pure medical disease, and for that, the voriconazole is a wonder drug. Wonder means wonder.
Yes.
See, some part of the palate is still left behind. See this?
Yes, yes. Dr. Satish, there is another very interesting question from Manish Munjal from Ludhiana, a good friend of mine.
Yes, yes.
Dural plate black, but no edema of the adjoining. Probably he meant cerebral tissue.
God. It was going beyond the midline, I told you. See this?
Yeah.
Necrotic. Oh
Yes,
God.
yes.
See, you cannot leave this.
Yeah.
Hold this. Somebody hold
Almost
this.
the whole of the palate has to be sacrificed.
Not only a little bit of the palate is left.
Yeah.
Doesn't mind. We'll give a prosthesis. We will give a
Whatever is required. First is to get rid of the disease.
Yes, first he has to survive.
Yes. So should I take up that Manish Munjal's question?
Yeah. See this, just a minute, sir.
Yeah.
See this part, absolutely bad bone.
Yeah.
How could you leave?
Never, never.
See the extent of debridement.
Yeah.
We saw on the MRI, the palatal involvement was going across the midline.
Yes.
And this is what again we have seen.
Mm-hmm.
See, the soft palate is totally good.
Yes.
See the area of the soft palate.
Yeah.
Just a minute. No, karo. See the uvula and soft pellet, can you see?
Yes, yes.
It's pretty good. The soft pellet is completely good. Our processes will still work.
Yes,
We have a margin for our processes here on this side.
yes.
So engage. And now I can say I have a complete debridement done.
The margins of the pellet, are they healthy?
Yes, yes.
Okay,
That's why
good.
only I
Left it,
extended this
kept it, yeah.
excision. See this now.
Yes. Yeah,
Every
yeah.
margin is bleeding now. Every
Yes.
margin.
So that's the biggest sign of,
That's the opposite maxillary sinus you can see there.
yes.
Complete soft pellet intact.
Mhm.
See the extension of debridement in this patient. Everywhere bleeding. I don't want to see any non-bleeding area.
Yes.
All necrotic tissue has to go. You have to have a complete thorough surveillance again, because debrider, if you leave any dead area, it's a disaster.
Yes.
So in the end, I would like to tell everybody, particularly junior colleagues, to understand the concept of surgery in mucor, why we are operating, removing dead areas, how much we are operating, ascertaining the dead areas by MRI, leaving enhancing area. You don't need to remove non-dead areas.
Yes.
That will add on to morbidity. See the rest of the pellet, rest of the other areas which are bleeding, I am not removing.
Yes.
Yes.
We have 2 more mucor cases tomorrow. Not very extensive one we got last night. Working up today.
Yeah.
See all
No, it is astonishing that how so many cases of mucor are now coming.
Yes.
So can I take that question, Satish, now?
Now, yes.
Manish Munjal from Ludhiana wanted to know, dural plate black, but no edema of the adjoining cerebral tissue. Removal of CP tissue leads to loss of nose-brain barrier and likely intracranial spread. So what's the take on it?
Sir, can you repeat the last part?
Did you
Can
get
you
it?
repeat again? Debrider, 40.
If removal of the CP plate lead to loss of nose-brain barrier and likely intracranial spread. So what is your take on it?
Same. Keep on
Same.
removing.
Yes.
I told you we have removed the intracranial part of the brain, half of the temporal lobe.
Yes. So follow the disease till you get the healthy tissue, the bleeding tissue.
You need to understand, leaving the necrotic area is inducing death, a certain death.
Then there is another interesting question from our own Dr. Chitranjan Agarwal from Dhanbad. Is there any role of local irrigation or application of amphotericin B?
It doesn't work practically.
Yeah, I know that.
Sir, post-operatively, how long do you keep the patient on amphotericin? Sir, post-operative, how long do you keep the patient on amphotericin B?
Yeah. How long means we titrate with 2 things. One is the improvement in the general condition, improvement in the local condition endoscopically, and third is the improvement in the ESR. ESR is a very important guide, you know.
Yes, good prognostic.
Resolvement of the inflammation is very, very practically suggested by ESR. By 3, nowadays we are not extending our amphotericin after complete debridement to any patient beyond 7 days. They do very well, and we immediately switch over to step down therapy of posaconazole syrup.
Yes.
So one more thing about amphotericin, a myth. Let me clear it very well. The amphotericin reconstitution is very important.
Yes.
Like I tell you, 5 vials of 50 milligram you are giving, 250 milligram. Each vial has a powder of 50 milligram. First, you dissolve that 50 milligram in 12 milligram of distilled water and shake it completely, shake it well to remove any particles, Make it transparent. So 12 ml of distilled water dissolved in 50 milligram of powder makes it 4 milligram per ml. Make this same for all the 5 vials, all 550 milligram powder vials. So 4 milligram per ml together. Mix them in a dextrose again 4 times to make it 1 milligram per ml. And dilute, neutralize with the insulin, because dextrose is not to be given to the diabetic patient. Take it 1 milligram per ml, all in distilled water. Continue it for, 1 to 2 hours every day. This should be the ideal protocol for these patients.
I think this probably most of the people were not aware for bringing it, sir, because the concept is to give in a IV saline bottle and anything you just dissolve and put it. So this is probably very important for the
Distilled
lyophilized
water, no
this thing.
saline.
Yeah.
No saline
Yes,
particularly,
no
it
saline.
could be distilled water.
Yeah.
If you use the saline, it may agglutinate the amphotericin. So
Yeah. Last question, a very interesting one. Dr. Paliappan from Trichy. Sir, what will be the total cost of pre-op, post-op, contrast, MRI, and prosthesis? Approximate cost, sir. Probably he has some patient in mind.
Approximate?
So he is asking that.
Approximate?
Cost.
Cost?
Probably some patient he is thinking of.
See,
yeah, that's why you cannot
question
say.
is valid. Question is valid. The cost depends upon so many things. MRI, pre-op, post-op may be a fixed cost. Amphotericin is variable. You may have to give 5 days, 7 days, 10 days. And the liposomal is a little one. Per day amphotericin cost. We have in Jaipur is a very good system from government about the life-saving medication at the most economical price to the patient. So still, which liposomal amphotericin, which costs 7,000 something for 50 milligram, is available in Jaipur at 2,100. But still 5 vial means more than 10,000 per day for amphotericin.
Yes.
Then surgery, of course, can be a fixed price, but the medical condition, most of the patients have compromised kidney. They are in the nephrological care. Like I told you, the patient we operated day before had a creatinine 9. We got dialysis done a day before. Operated yesterday again, we got the dialysis on amphotericin. The creatinine is shooting. So, so many things, how many days the patient will have to stay in ICU, kidney care, so many things.
About the cost, I just wanted to have a comment. Lyophilized, I got it. Satish, just one question. Lyophilized cost a lot because I remember once I was in job, our store procured one from Sanat Pharma. 50 milligram was costing around 300, whereas the lyophilized one, yeah. So, and the lyophilized one is 6,000. So the purchase people said, sir, why you are procuring that particular brand?
Yes, sir.
And
I agree with you.
Ultimately, they could not supply the lyophilized. I gave the simple one, and it worked well. So, what is your take between the two? Because cost difference is great.
See, why the liposomal is introduced? Because the known liposomal is severely nephrotoxic.
Yes.
All diabetes patients reaching to this immunocompromised state have almost always subclinical nephropathy. The moment you start the amphotericin, the creatinine starts shooting. So, since I told you that 2 things are required on time for these patients to save their life. One is the debridement on time. The second is the complete course of amphotericin. Whatever coming in between has to be managed parallel. And the only thing which comes is the kidney. So you have to have your nephrologist in team. If the creatinine shoots up, you have to prevent it by using liposomal, number 1. Even if it shoots up, you have to take the help of the nephrologist to give a parallel dialysis or any other management. But you are not supposed to stop the debridement. You are not supposed to delay the debridement and amphotericin at any cost. Otherwise, you may lose the patient.
Sir, what precautions are you taking apart from regular precaution for COVID-19 patients? So for COVID-19 patient surgery, what is your protocol? How do you deal with those patients?
So like I operate in a corporate, they have full COVID-19 dedicated operation theater with level 3 protection.
So
With
you're not
all
doing it in your
informed
hospital?
consent from the patient and everything, and they are being operated. No issues. The
So
government
you
of
don't
India
have
has
to
laid down level 3 protection guidelines. You have to follow that and you can operate under that. And these are the patients who require, you can't delay. The delay is at the cost of life because this mucor is not going to stop on its own.
Yes.
It starts in the nose, spreads to the orbit very fast and then to the brain. That is a predictable course of mucor spread.
So, Dr. Satish, we move on to our next case.
Yes, sir. Our next case is ready. It's a
Yeah.
pleomorphic adenoma of the parotid.
Yeah.
I know the time is 11:40 and the
Yeah.
limit is 1 o'clock as much as we can show.
No, after one also we can continue. Those who are interested will continue because this is going national wise. We will go at least. I have announced up to 2.
Okay,
So,
no problem. We can continue up to 2 o'clock. That's great.
Yes, sir. Yeah.
So the next case is after this parotid is going to be, as you said, we have to keep the basics more and more.
Yeah.
So the case for functional endoscopic sinus surgery.
Great.
Then we have in lineup, we have 16 cases otherwise.
Yeah, you told me.
The likely to be shown are the thyroid, the mastoid, subtotal petroid, whatever we can show, we'll see.
Yes, you are going the great.
11:40, move on to parotid.
Yeah.
Funny, no? So this case is a usual common one, FNSC proven mobile pleomorphic adenoma in the left parotid gland. Parotid can give rise to heterogeneous, pathologies. This is one of the gland which can give rise to heterogeneous pathologies. Maximum number of pathologies which can arise in a single gland is the parotid. More than 23 kinds of cancers can arise in parotid. So always the workup is very important because the decision making depends upon the extent and the pathology, histology. It is all histologically driven treatment nowadays. Maybe parotid, maybe skull base, whatever. In parotid, our workup involves, we prefer a MRI for many reasons. Though for very superficial mobile lesion, your USG can be sufficient, but the best details of the gland, the soft tissue details are given by the MRI. By MRI, up to 95% of sensitivity, you can differentiate a benign from the malignant tumor even without histology. By various sequences of MRI, taking into consideration the diffusion and the contrast sequences, you can ascertain whether it is malignant or not quite consistently. So, number one. Number two, the role of MRI is to distinguish the tumor, whether arising in the superficial gland, deep lobe, the relationship to the facial nerve, superficial or deep to it, which is a great bearing during surgery. Great bearing on the surgical procedure. So that is best depicted by MRI. Number three, any other pathology in that gland, if it is missing by sonography or anything, the MRI can give good details about the ductal system with the MR, xylography. Every detail, possible detail can be ascertained from MRI. And next is FNSC. FNSC can pick up pleomorphic adenoma quite easily. Not as consistent as for thyroid. So many a times in doubt, we take a core needle biopsy. Because the core needle specimen can be sent for histopathology and can be sufficient for immunohistochemistry also. So we believe in core needle biopsy in suspicious situations. We are big proponent of core needle biopsy so that you don't need an open biopsy for those patients. Now, are you getting the microscopic picture, sir? Hello?
Yes, sir, we are getting the microscopic picture.
This is the adenoma. Can you see? And our technique is always a microscopic surgery. We always emphasize for the regions, very obvious. And the number one region is the preservation of the facial nerve and its branches. Not only 5 branches, but number of branches. How's the picture there, sir? Is it centralized? All good?
Yeah, all good, sir.
So the first important part in the parotid starts with the flap raising. Flap raising has 3 important, concerns. Number 1 is I would say the cosmetic issue. And for that matter, we take this preauricular incision behind the tragus. So first is in the incision, the first concern is the cosmetic issue. Second concern after this is the flap thickness, which is a bearing on preventing the so-called Fraisse syndrome. We need to elevate the SMAS. Aponeurotic tissue, we need to elevate along with the flap to prevent Fraisse syndrome. I will show that. And the third one, so this is my incision. This is the retroauricular occipital incision. See this. Leave it, leave it. See this. This incision is hardly visible pre-auricular. Can you see this? And the cervical is hidden behind the mandible.
Yes.
So the first part of the incision importance is the cosmesis. Second part is the thickness of the flap. That is very important to prevent Fraisse syndrome. And the third part is the preservation of the posterior branch of the greater auricular nerve. Greater auricular is an important nerve in this region. Earlier used to be important for the facial nerve reconstruction point of view. The important nerve graft it provides. The posterior branch, the greater auricular, after arising from the Mechanism point, I will show you. It runs over the sternomastoid. See this part of the flap, I am being careful to protect this greater auricular nerve posterior division. I will show the divisions of this nerve. And this incision through the knife so that you can identify the tissue planes much better rather than using the cautery. See, this nerve is quite superficial. And there are certain landmarks for the nerve, which I am going to show you. Stay in the superficial plane. Superficial means superficial to the sternomastoid. See?
Yes, sir.
How superficial I am here
Yeah.
to the sternomastoid. Now, the landmark number 1. This is the angle of mandible. This point is known as gonian. Stay in the gonian plane where it crosses the sternomastoid. And see this now? See this now?
Now you can see it. Yeah.
Can you see?
Yes, sir.
This is the gonian. See this? Right in the gonian plane, it crosses the sternomastoid. And see, it is lateral to sternomastoid. And still if you are finding difficulty, don't look for the nerve. Then look for a vein which runs parallel and a centimeter below this. That is the posterior division of the retromandibular. And that is quite consistent, you know.
Yes, yes.
This is the vein.
Yes.
Here is the vein. This is the vein. So you can identify this by the vein or the gonian. And once you have identified, and now you know your planes, that how deep you need to elevate. Clear? So
Yes,
the
sir.
second part of the flap raising importance is because of this nerve. The third part. We should always try to protect or preserve the posterior branch of this greater auricular. The reason is, this is important now, particularly the females who wear the earrings, as it supplies the ear lobule. See this now? If I follow that, just see the nerve going there?
Yes, clearly.
So now, having positively identified this nerve gives you a good idea of the plane in which you can go further and preserve this nerve as well. I should not damage. 98% of the time we are able to preserve the posterior division. No. See the nerve now dividing into two divisions. This one is going anteriorly, which we are going to sacrifice, and the other one going behind. That is your, can you see the posterior division now?
Yes, yes.
That is going towards the pinna knife. That needs to be preserved. This is the posterior division.
Hello, sir.
Yes, sir.
Can we know the situation where you are not able to identify this, sir?
No.
No.
In the revision situations, you may not, but in the primary situation, almost always. See the anterior division which I am going to sacrifice going to the skin, preauricular skin, and this is the posterior division which I want to preserve. Answering to your question, in which situation you can't. Now, let me tell you, practically where you cannot. First is the revision, where you have no control of what the previous surgeon has done. Number two, in the primary situation when your tumor is coming behind on the muscle.
Yes, sir.
You have a malignancy centered behind. It is difficult to preserve. Then the target is malignancy. All these things are secondary.
Yeah.
See this posterior division going to the root of the pinna. Very clear?
Yes, sir.
See this.
Sir, one
this
more for trainees, if you could just say that how broad should be the posterior curve which you took. At times you see superficial parotid or parotid surgery where this this curved limb gets necrosed and then
this one.
So that is
this should be obtuse.
Yeah.
This should be obtuse rather than very sharp turn, otherwise the tip can go. Now see, here is very clearly the posterior division going to the root of the auricle. Can you see?
Yes, very clearly.
And that is how the posterior division need to be preserved. See the anterior division I am sacrificing.
Yes.
Sacrificing. This I am elevating to mobilize it a little bit. See this?
We are able to preserve this even in very large carotid tumors, benign in this. Malignancy is a different story. but
Malignancy
benign.
sometime you can't,
Yeah.
as if the disease is coming behind.
Okay.
If
But
the
in
disease
all
is not
benign, you
centered
preserve the
behind, yes,
posterior.
you can still preserve.
Okay.
Now see, I have separated it from its place. Very clear?
Yes, very clear.
It is, I am leaving it far away from our area of interest.
Area of interest.
Mr. Dinesh, can you see the audience if they can see the video? Some people have commented they are not able to see the video.
Video?
Yeah, the other link, we can see it on the Zoom, but the audience link. Mr. Dinesh, please check up.
Ajay, what has happened to the video? Dinesh?
Yes, sir.
What is happening?
The audience link we have provided, is it working? Because somebody has commented not able to see.
Sir, one person can basically comment because we have internet issue, but it's working fine, sir.
Okay, fine. That's okay. Go ahead.
Please ensure again. Huh?
Yeah.
So this is the tragal cartilage which I am preserving. See this?
Yes.
And tragal preservation is very important from cosmetic point of view as well. Knife is not working proper, man. Now the second part of the flap, as I told you, beside the cosmesis and the greater auricular nerve, the other part which is important to be taken care of is the thickness. See this. Muscular aponeurotis tissue. See my depth of the elevation of the flap. See, focus on this.
Yes.
Absolutely till the depth of the gland. Can you see?
Yes, yes.
Hello?
Yes,
Yes, sir,
it is
sir.
very clear.
And I can see under microscope very, very clear. I want to raise a thick flap. What happens otherwise if this flap thickness is not adequate? Post-operatively, after the superficial parotidectomy, the nerve endings of the deep parotid may come in contact with a too thin a flap, subdermal, neurovascular elements, and can result into stimulation. While eating, the patient will have, sweating.
Yes.
The stimulation of the blood vessel will lead to redness in this region. See my thickness flap right to the parotid tissue.
Yes.
That is important.
Dr. Satish, one Dr. Girish from Bhilai has asked, have you infiltrated the area before incision?
Pardon? Yes.
Okay. And when do you advise for wide bore core biopsy in parotid? And
Yes.
how much
So
rely on
in
FNC?
suspected malignant lesions, your FNSC is not, revealing anything.
Yeah.
Then we go for core needle biopsy, and majority of the time you get the perfect diagnosis because you get the core of tissue.
Yeah.
That tissue can be subjected to immunohistochemistry as well. And
Yeah.
I told you in parotid, you believe in histology-driven treatment.
Yes.
That is very, very important. Now, the next part of the flap, which is very, very important now, see, which can otherwise ruin everything, is the anterior extent of elevation. See now,
Yeah.
being very, very careful.
The facial branches are very superficial here, so
Yes.
I always
Yeah.
use a cold.
Go to the anterior
instrument.
border of the gland, not on the masseter. See the masseter coming?
Yes.
All the branches which you preserve here on the parotid, inside the parotid, they traverse superficial to the masseter anteriorly, all the way. If you keep raising this flap and divide, if you don't take care of that fact and go deep on the masseter, everything is ruined, finished.
Yes.
Whatever facial nerve branches you have preserved, all gone waste.
All gone.
So now see my anterior limit. My gland is ending and masseter is starting. Can you see?
Yes, sir, very clear.
This should be the anterior limit of flap raising. Because of these 4 issues, I started from beginning raising the flap. You know the importance of flap?
Yes.
Cosmetic, greater auricular nerve, prevention of Frey syndrome, and protection of facial nerve branches, that you don't have to go far anteriorly beyond on the masseter. See, all these are branches. All these are branches. Can you see?
Yes, very clearly seen.
Yes.
Very
So
clearly.
never ever go beyond the parotid on the masseter. Everything will be ruined. Lगा दे दो. This is so important.
Dr.
Sometimes we
Sanjeev,
think that
Dr.
we give
Sanjeev from
Juliet
New
to the flap
Delhi.
elevation.
Yeah,
Mind it, this is the
Satish,
most important part of the surgery.
yeah, Dr. Sanjeev from New Delhi has commented posterior branch of greater auricular is also called nerve of foreplay. I don't know what he means. so, I think after seeing this, general surgeons who are doing this parotid without microscope will think thrice before going to it.
Believe me, I
It has
condemn
to be
for the
condemned.
reasons.
Yeah.
Microscope, uncomparable.
Yeah.
You can
Yes, sir.
use.
We
See,
never do it
I am-
without.
I can say other way around, like we discussed for the graft.
Yeah.
The naked eye surgery or loop surgery cannot be better than microscope. I can say.
Microscope, yes.
Microscope
Totally agree,
cannot be
sir.
inferior to that.
Yes.
Microscope cannot be inferior to that. It's not a matter of debate. The reason being, I tell you, the majority of the so-called, the oncosurgeons who are doing are general surgeons. That's the reality. And they are never so used to microscope like ENTs.
Yes.
So they don't propagate.
Yes, sir.
This is a hard fact, I tell you.
Yeah.
Now see, the next important point of surgery is the facial nerve.
Yeah.
Parotid is all about facial nerve preservation.
Right.
Identification and preservation of the facial nerve is the key in parotid surgery.
Yes.
So
And
let me
with
fix
time
the
you
auricle.
become habituated to microscope so much. Like I
Yeah,
haven't done any parotids without microscope since
right from the
years
skin,
together.
right from the incision.
Yes,
We
yes,
do
very
all
true. I do everything under
parotid,
microscope.
thyroid, submandibular under microscope, and it gives you excellent view
And
of
Dr. Satish and Kranti, this will show the result also. Yeah.
Yeah, we have never had difficulty finding
The
patients.
parotids done by general surgeon. Yes. Dr. Kranti, you will agree with me, most of the general surgeons doing parotid have some degree of facial palsy because they cannot visualize without a microscope. It is just not possible.
I tell you the reality, sir, how people get away.
Yeah.
The God has given us why this the nerve plexus in the parotid is known as pes anserinus.
Yes.
There's a huge network of branches,
Yeah. So overlap
proximally
is
and
there.
distally. If any of the branches suppose sacrifice, it regenerates from
Yeah.
other. And that is a,
Yes.
the welcome thing for the surgeons as well. See what I'm doing.
Yeah.
Now
Separating
coming to
it
the
from
facial nerve identification. There are so many landmarks,
Yes.
in the literature. I tell you our short landmarks, the technique which we propose as a convergent technique. I will use 2 landmarks. One that I will tell you the reason behind that. To make your life so easy during parotid surgery, first of all, the landmark should be easy one to identify. And it should make the surgical course easier. But number 1, my landmark, why it is convergent, I told. I will converge through 2 landmarks, one from above, one from below, and it will automatically come to facial nerve. Nothing else than facial nerve. This is my adenoma.
Yes.
So now my superior landmark is this, the medial end of the tragal cartilage, which
Yes.
ends at the free end. As a pointer, we call it tragal pointer.
Dr.
See this
Satish,
tragus? Can
Dr.
you see this
Ranjit
tragus ending
Nath.
freely? See this
Yeah.
tragus?
Yes,
Yeah, yeah.
very clearly.
Ending as a pointer there. See here?
Yes.
That is my pointer here. Okay?
1
Yeah.
centimeter.
And that's a very important landmark. The facial nerve is 1 centimeter below.
Below.
Below means inferior.
Inferior. Inferior.
And 1 centimeter deep means medial to it.
Yes.
Inferior.
Okay. So this is one landmark. Let us take into consideration. Number one. Now the other landmark, I will take up another. I told you the landmark should be easier to identify.
Yes.
Scissors. Let me separate my nerve first. I would request all junior colleagues to practice this preservation of the greater auricular. It really helps your patient, you know.
Yes.
Otherwise, they complain they are not able to sense the earrings they wear.
Right.
Doctor, you didn't tell me before surgery that this is going to happen. I would never get operated. Now, my second landmark again is I told you the landmark should be simple. So, you know, the digastric is a very important muscle we see in our practice.
Yes, yes.
We identify digastric in neck for many reasons, for neck dissection, for so many things.
Yeah.
And it is a simple landmark to identify. And once you have sternomastoid in view, you can identify it much easier. You know?
Yes.
So I am again separating this nerve behind.
Yeah.
See this?
Yes, yes.
So nerve is far behind from our view. Okay?
Yeah.
I don't want to put it in any, danger. Okay. So now this is our sternomastoid. Can you see?
Yes,
this is the tendon of the sternomastoid. And we know deep to it, anteromedial to it, I would say, the next muscle is what?
Digastric.
Digastric. So it is never difficult to identify. See the digastric below.
Yeah.
Yes.
See the digastric coming?
Yes, yes.
I told you the landmark should be easier to identify.
Yeah.
People in the parotid I see in the literature use so many XYZ landmarks which themselves are so difficult to identify.
Yeah.
Branch to posterior auricular branch of the posterior auricular artery crosses the nerve is such a good landmark. But how to identify that?
Yeah.
That is much difficult than identifying the facial nerve itself. Now,
yes.
Having seen the digastric, why I call this technique a superior one, not that I am doing. It gives you, opportunity to explore the facial nerve in your view. The facial nerve automatically comes the area you look at. And see, I have seen people digging a well here for the facial nerve.
Yeah.
And you can end up injuring the nerve. So I will not dig a well, I will open like a book.
Yes.
Why digging the well? Because you never know facial nerve can come anytime. You're always scared of facial nerve once you start looking for the facial nerve from here. I tell you, this is tragal pointer. See this?
Yeah.
The facial nerve is 1 centimeter deep. The facial nerve cannot come here. This is my digastric. The facial nerve is inserting here on the mastoid tip.
Mastoid tip.
The facial nerve is anteromedial to it. It cannot come lateral to it.
Yes.
So why to dig a well if I take this line of the tragal cartilage here? Line of the tragal cartilage, simple. Line of the tragal cartilage and all this tissue lateral to it. Still my facial nerve is 1 centimeter deep.
Deep.
I remove this. It is very, very safe.
Yeah.
See this?
Yes, yes.
Not to dig a well unnecessarily. Why to complicate your life unnecessarily? See now, it will open up like a book.
Yes. Dr. Satish, one doctor, Ranjit Kumar Nath from Khulna, Bangladesh, has asked, would you please mention how you made such a bloodless field?
Simple infiltration, your microscopic, with this microscope. See this, I am able to identify even the small capillaries.
Yeah, and you follow the tissue plane. That is more important.
The plane.
Yeah.
It is the tissue handling which matters.
Yes.
A lot. Now see, this is my tragal pointer. This is my digestic coming. Let me follow the digestic properly. See the digestic?
Yeah.
See where the digestic is ending. Let me show you. It's very important so that you don't get disoriented. See the digestic very clear?
Yes.
Feel the digestic where it is ending. That's a very, very important point, that the facial nerve is always just above it. It cannot be below that. So you don't have to look for facial nerve below that level.
Yes.
See this. Digestic, I can see it is ending here on the mastoid. This is mastoid tip.
Yeah.
It is ending here. See this?
Yeah.
Now my facial nerve cannot be below this level. Below means inferiorly.
Yes.
The facial nerve is just above the attachment of the digestic and medial to it. That is how we see in the during mastoidectomy, the digestic ridge is an important landmark.
Yes.
Where the facial nerve is just anterior to it and deep to it.
Yes.
What's my point?
Yeah. Yeah.
So this is my digestic attachment. My facial nerve should be just above
Yeah.
and deep. This is my tragal pointer. My facial nerve is 1 centimeter below and deep. So converging these two landmarks, my facial nerve comes here.
Yes.
Can you see?
Yes. Yes.
But 1 centimeter deep still.
Yeah.
Now I know where to work. Rather than hitting trial here and there,
Yeah.
I know my area where my facial nerve should be. Okay?
Yes.
That is the beauty of this technique. Convergent. My facial nerve is going to converge at the level of these two landmarks. Again. But
Sir, could
we see the open book approach? Know well. This is your tragal pointer. My facial nerve is going to be here. And this is digestic. My facial nerve is going to be here, but little deeper. What all you need to do is open up this space.
Sir, could you improve
In a minute's time, I'm going to show you the facial nerve now.
Sir, could you increase the magnification one step, sir?
Yes, yes, yes. Good. Good. Yes. Now see, I'm opening up the space like open book. I tell you it is 1 centimeter deeper and now my facial nerve is in view. Again, see this facial nerve. This is digestic. Yeah, this is the tragal pointer. Exactly 1 centimeter below. Can you see?
Yes, yes.
And 1 centimeter deep. And this is my facial nerve. I can see the facial nerve. This is facial nerve.
Yes.
Yes. Yes.
See that? See,
The message is you should make a wide opening, then plunging your artery forceps into that space.
Yes.
Is that correct?
Parallel to the nerve. Parallel to the nerve.
Yes.
Not digging a well.
Yeah.
The beauty of this approach is not digging a well. Now, the people who talk about the posterior auricular artery branch, let me tell you where it is.
Yeah.
How do you take this into consideration? This is posterior auricular artery branch. Can you see this?
Yes, yes.
This is vessel.
Yes.
This is vessel. Let me cut it to show you. Just to show you. This is vessel. See that?
Yeah, yeah. Very clear.
Just to show you, I cut this. Now this is lateral to the facial nerve. But how to find this vessel so easily? So don't take into consideration those landmarks which itself are difficult.
Yeah.
Our job is not to make our life difficult, to make life simpler. Now see again. Retrospectively, go to the landmarks in convergent technique. This is, tragal pointer.
Tragal pointer.
This is 1 centimeter below 1 centimeter deep. See this now?
Yeah.
Exactly.
Yes.
Now with digestic, what did we achieve? This digestic is inserting here. Can you see here see the muscle?
Yes.
I can see the muscle and image where my finger is and see immediately above that and deep to it. Keeping this digestic in view, you don't have to go inferiorly to look for the nerve. You know your digestic is ending here, your nerve is going to be above that. That simple as that.
Yes.
Believe me, I get so many phone calls, people following this technique, which has made their life difficult. The most junior ones, so if they can do, anybody can do. This is to simplify the parotid surgery.
I think this is one of the easiest technique where the landmarks is so easy to find.
Yes.
And if you follow
See,
it, it
we are
is
not digging
hardly
a
any
well.
chance to. Yes,
Yeah,
that is the
I
main
have
point.
seen people struggling for hours and hours to look for the facial nerve. Why too? See, it is like an open book approach.
Yes.
Now, see now, I'm spreading my artery lateral to the nerve. See this? This is inferior division. See that?
You can see the division very clearly.
Yes.
Yeah, yeah.
Now let me spread your artery. Now the technique is not only spread your artery lateral to now, lift the artery. See now I've lifted the artery.
Yes.
Lift the artery to protect the nerve, not to give any tension on the nerve, tension on this tissue. See this? The
Yes.
nerve is lying in the bed, medial to it, because the tension on the nerve is the major cause of nerve weakness. It's not that you always damage the nerve and get weakness. It is the traction on the nerve, which is most important. So lift the tissue lateral to it rather than lift the nerve. See the lower division now?
Yes, yes.
See the lower division. See small venules I can see and cauterize.
Yeah.
You were asking about the bloodless field.
Yeah.
And this is one of the regions.
Yeah.
I can see the smallest of the venules under microscope. Oh, Lillian, next case. Yes.
I think the best message is to follow the plane, follow the landmarks, and don't hurry up, don't do anything without vision.
Yes. Now see, follow the lower division. It is dividing into many branches. You have to follow individually.
Yes.
Preserve these branches. See the branches?
Yes, yes.
This one, the inferior one, I am following. Sometimes this division separates very early in the course from beginning of the division and sometimes later on. So it is variable. And see, it is never just 5 branches. I can show you more than 100 branches of the facial nerve in the parotid.
Yeah.
So never think that you have to preserve. Now see, why I am calling this is a cervical division, cervical branch. See this, what is there below? Can you see there something? Retromandibular vein.
Oh, yes.
Yes, the
Retromandibular.
retromandibular. Yes, yes, very clear.
So the branch which is in relation to the retromandibular is the cervical one.
Cervical branch. So simple. Yeah.
So this is the vein. Give me. Can you see very clear?
Yeah.
So the branch in relation to the retromandibular vein is the cervical. See this? The vein is always medial to it.
Yeah.
This vein is one of the source of identification of the level of the facial nerve in scans. In MRI or CT scan, you can identify this vein. You can't see the nerve itself proper.
Yes.
If the tumor is lateral to vein, means in the superficial lobe. Medial to vein means in the deep lobe. It is so simple. See the cervical branch going down?
Yes, yes.
This is going to the platysma. Platysma is a very important muscle in parotid. Sometimes you make a flap of it to, fill up the parotid lodge, the dead space, the area which is, depression which we get after parotidectomy in this region. See this?
Yeah.
And secondly, the platysma flap can be used to prevent the French syndrome or treat the French syndrome. Now, the second branch of this lower division, see this, going anteriorly and that is the marginal mandible. That is the marginal mandibular branch. Let me show you. That's a very important branch
Yeah.
for the angle of mouth movement. It gives a very bad deformity, which is not acceptable to the patients again. See this division, this branch, still lateral to
Yes,
it.
yes.
See this?
Yeah.
Lateral to it, elevate your forceps. Use bipolar, you can use harmonic scalpel, that is too good. Quicker. Yes. See the marginal mandibular branch.
Yes, very nice.
That was part of parotid, isn't it? Which you have just cut.
Yes.
Pardon?
This was part of parotid, superficial parotid.
Yes.
Yeah.
See this branch?
Dr. Satish, one of your followers from Peshawar, Pakistan,
Sir.
Faisal Wahid, he says, stalwart Satish, I always follow you. Let me know if a substitute for microscope to be used for this surgery. I don't think.
You do naked eye, but why want to substitute when you have a better alternative?
Yeah, true.
See this vessels just lateral to the facial. See this?
Yes.
How efficiently you can coagulate them, see them, identify them rather than tearing them and getting bleeding and then controlling. This is all to preserve the facial now in a better way.
Very difficult to do it without microscope, sir.
Yes.
You can do, but this quality work of preserving all the branches.
Yes, yes.
Is
It will
something.
never match.
Yes.
Even loops
Probably
will not
naked
match.
eye, you can save only the big branches, the thick branches,
Yes.
but not the twigs like we are following.
See now, this branch, how many branches it is giving? See this.
Yeah.
Microscope.
Multiple.
This is the lower one. This
Yeah.
is some more communication with the posterior auricular branches.
Right.
This is again a communication between this and this branch. See this?
Yeah.
And this is a communicating branch. This is marginal mandibular. This is cervical. With lot many branches, communicating branches. This to the lower buccal branch. You see all these communications?
Yeah. Yeah.
N number of, see this small branch? So
Yes.
all these branches are not visible without microscope.
Yeah.
See, I have elevated from the marginal. Without any hassle, my marginal is very safe. Now my area of interest is above. I can say in this patient, my marginal will remain good.
Yes.
But I don't need to dissect any more inferiorly now.
Yes.
See, all these veins are in close vicinity. Wherever the nerve branches are the veins, you have to be very, very careful. Huh? And here the microscope helps you. Microscope helps you. See this? Under high magnification, there is no bleeding. Now, coming to the upper division. See this?
Yeah.
I hope the picture is good.
Yes, very good, sir.
See now to the upper division. Let me follow the upper division here. See that?
Yeah.
Staying lateral to it. Again, the same philosophy.
Yeah.
Let me elevate this. Elevate the forceps, not the bed.
Yeah.
If you elevate the bed, your nerve will be under traction.
Yeah.
See this?
Yes. Beautiful.
Sometimes you have a tumor in the deep lobe, then you have to be between the branches, then the microscope is of utmost value.
Yes.
You may have to mobilize or sacrifice one of the less important branches sometime in the extreme situation.
Yeah.
See that? See the upper division, the thicker one?
Yeah.
This is going to go more deeper.
Yeah.
And now let us follow. See, just superficial to it. Under magnification, your strokes are very, very controlled.
But the junior colleagues to emphasize once more the way of dissection that you are doing is going parallel to the nerve and then lifting the tissue above and then
Lateral,
putting it.
lifting the
Yes,
tissue lateral to the nerve.
lateral to it. Yes, sir.
Not to put traction on the nerve at all.
Bilkul.
If traction is there, the nerve function is inevitably going to be compromised.
Yes.
Now, how much traction, whatever you have done depends upon neuropraxia or even severe. See this.
Yeah.
Further, slowly, slowly. Now, this is your, the branch going up. See that?
Yeah.
That is the
Yes.
frontal branch, temporal branch, whatever you call it. And our tumor is here.
Yeah.
I need to circumscribe from there.
Yeah.
I don't need to go up there anymore.
Yeah.
Because my tumor is not going there. See my upper limit of the tumor there?
Yeah.
And see the normal parotid tissue.
Mm-hmm. Actually, Farooq made a good point that we should always follow the nerve without stretching and be superficial to it.
Yes, sir.
Yeah, Farooq. Excellent.
See now.
So the upper limit, Dr. Satish, we can stop here.
Yeah.
Following
In
the
this
facial nerve.
particular patient, you don't need to go high up.
Depending on the tumor, we have to follow.
Yes, depending upon the tumor. So this is the
Right.
frontal branch.
Yes.
And this is the most important zygomatic branch.
Yes.
To the eye.
Yeah. So we have to follow. This is very important.
And this is my limit of the tumor. See again. So I can follow this and circumscribe here. See again. Leaving the branch below, I can rotate my specimen here. See that?
Yes, sir.
I can leave this branch above.
Excellent, sir.
So Dr. Ranjit from Khulna again asking, how much magnification you use?
This is my not step magnification.
Right.
I can still check how much it is.
Wherever you are comfortable and
I am comfortable at a high magnification. I am used to.
yeah. So that varies from person to person where you can see the structures clearly.
Yes, exactly. Now see the lower division branches, upper division branches, and communicating branches.
Yeah.
Now see, this is upper buccal branch. See that? Very slender. Can you see?
Yes, sir.
Yes.
Again, I am leaving this. Leaving that above?
Yes.
Like
Because
this.
that is beyond our tumor area.
Yes. See the small, slender lower buccal branches. Many. See how many?
Yes.
1,
Yeah,
2,
Yes.
3, 4, 5, 6.
Yeah.
Who says the facial nerve has 5 branches only?
And we should try to preserve as much as we can.
Yes. Now these zygomatic and the buccal branches have extensive anastomosis anteriorly.
Yes.
Distally. That's why we can take one of the branch for the cross nerve graft without giving too much of donor side morbidity.
Right.
Cross nerve graft is a very common nowadays.
Yes. With the more extensive surgery we are doing.
Yes, this is I can now see all the branches you can see now.
Yeah.
See all these branches. All I have left in the depth.
Yes.
See under magnification now. One cannot count how many branches the facial nerve has.
Yes.
Maximum
Satish?
you preserve, more the spontaneous facial nerve function will be there.
Yes.
See this?
Yeah.
And now finally I can remove this tumor. Cut off. That's it.
Satish, I have one question.
Please, sir.
That we usually do this superficial parotidectomy.
Yes.
The pre-op investigation consists of only this ultrasonography and FNAC, like that.
Yes. Yes.
And the report comes like that there is a parotid tumor and like that. They don't mention whether it is from the superficial lobe or the deep lobe. At
On
one
sonography,
occasion,
you cannot be 100% sure.
yes, I was in trouble that when I opened, I found that the
Full of
superficial
surprises.
lobe was completely normal,
Yeah.
and the tumor was coming from the deep lobe.
Deep
Yes.
lobe.
Yes. Yes.
And
Those
at that
surprises
time,
are
what
always
happened
there.
that this zygomatic branch was turning around the deep lobe from its upper part, and while removing this deep lobe, it got some sort of traction or like that, and post-operative weakness was there in the leads.
Yeah.
So
So all
can we
these
have some
surprises can be avoided
pre-operative
with a good
idea?
MRI.
So
Without-
MRI, that is why we do MRI
Yes.
routinely.
No,
sir.
I'm talking about the clinical
And
examination.
MRI is
Can the
radiation free.
mobility be a clue to know for this deep or superficial?
Not necessarily, sir. Not necessarily, I think. Yeah.
Okay.
Even
And
the
now
deep
see
lobe
the
tumors at
final
times
picture,
do.
sir. Now
Yes.
see the final picture. कितना बोला हूँ, फेस वाली सीडी इसमें डाल दे लैपटॉप में.
Yes.
फेस वाली सीडी लैपटॉप में डाल दे. This is the final picture with all the branches of the facial.
Beautifully shown. Yeah.
See all these lower jaw branches running on the masseter muscle. Can you see?
Yes. Yes.
If we raise the flap anteriorly over the masseter deeper,
Yeah.
you can cut all these branches what you have saved.
Yes.
Everything can be ruined. See all these branches.
Yes,
Yeah.
yes.
You raise your flap anteriorly on the masseter, the job is done before even surgery. Finished.
Yeah.
So this is the hemostasis finally.
Yeah.
Any questions?
There is one question by Sahid Rasool from New Delhi. Yeah. Can nerve stimulator be an alternative to microscope? How it can be?
Yes, nerve stimulation is always good, I tell
Yeah.
you, to get used to. See, this is my greater auricular branch.
Yes, yes.
This is facial now, the retromandibular vein. So nerve stimulator is of great use. We do use, particularly in the revision situations,
Yeah.
in the bigger tumors. It
No,
gives
his
you,
question is, can it be alternative to microscope? That it cannot be.
no, that has a different role than microscope.
Right. Yeah.
Nerve stimulator, if you are getting real-time stimulation, will tell you if you are giving too much of the traction,
Right.
the monitor will warn you.
Mm-hmm.
And that is something amazing feedback.
There
Secondly,
is, yeah.
if you are not able to identify the nerve branch, that happens mostly in larger tumors and revisions, the nerve stimulator can help you identifying it. Thirdly, at the end of the surgery, if your nerve stimulator is showing good response,
Yeah.
you can be rest assured that your patient is going to do fine.
Yeah.
Sometimes you leave the nerves anatomically intact, but with a lot of traction, you end up damaging the nerve completely. Nerve stimulator can help you prevent
Yeah.
that.
But if you are doing the way you have done just now, under vision, all the nerves, there is no need for a stimulator to see.
Pardon?
The way you have done all under vision and without damaging any of the nerves, then still do you need to test for the nerve stimulator? I don't think.
I do use in larger tumors, sir.
Yes.
I do
And in
use
malignancy.
And in malignancies where you are...
revision cases are
Okay.
most challenging. Believe me, preserving the facial now, preventing the traction in the revision situation is next to impossible. It is so
Yes,
difficult.
it's a very tough job. Then there are same question, one by Sohail Aslam from Karachi and Girish from Bhilai. After removal of the superior superficial parotid, please guide about the steps which can make deep lobe easy to remove?
Deep lobe easy to remove is through
Yeah.
the branches, through the in between the branches.
Yes.
So many a times you can deliver it through between the upper and the lower divisions.
Yes.
Sometimes you may have to sacrifice one of the less important buccal branch
Yeah.
because distally they again have communication, so it
Yeah.
regenerates. Distally, all the buccal branches have good communication with the zygomatic branch. Even if proximally you sacrifice one of the buccal branch, in times to come, it regenerates from the other branches there.
Yes.
So you may have to sacrifice one of the less important buccal branch to remove this tumor in toto along with the superficial part.
Right.
In malignancy, the situation is different
Yes.
because in malignancy, your goal is not only to remove the tumor what you see, your concern
Yeah.
is lymph nodes also.
Yes.
So in malignancy parotid, except the low grade tumor, we always recommend a limited, sampling, next sampling, level 1 to 3.
Yeah.
If it turns out to be positive, then MND.
Yeah.
Along with that, we recommend a complete radical superficial parotidectomy.
Good.
Number one.
Yeah.
What is different than a superficial parotidectomy? It is not a terminology, but to explain this, a radical superficial, because like in this tissue, we
Yeah.
went around the tumor with good cup of tissue,
Yeah.
still some part of the superficial parotid is left behind.
Yes.
In malignancy, I would try to do a complete radical superficial parotidectomy in order to remove the complete lymph nodes in the superficial parotid.
Yes.
Superficial parotid contains 12 to 20 lymph nodes.
Yes.
In a malignant lesion, if lymph nodes are positive and frozen,
You have
in
to.
spite of not having involvement of the deep lobe, I will go in and remove the deep lobe to
Yes.
remove the complete block of lymph nodes. Got my point?
Yes. Yes.
That's why in malignancy, the scene is altogether different.
Yeah.
So my superficial parotidectomy specimen on frozen, if shows lymph node positive in the superficial gland, is an indication for deep lobe clearance, irrespective of the disease going in the deep lobe.
Okay. And in that case of the deep lobe, even if we have to sacrifice a part of facial nerve, we can always go for the masseter facial graft, isn't it?
Yes. So in case your main division is gone,
Yeah.
obviously you have to think of reconstruction at the same time.
Yes.
And the best alternative in the same vicinity is the mesenteric nerve.
Yeah. Yeah. And you have shown in our earlier webinars, it gives good results as well, and easier to do because it is you don't have to mobilize the nerve so much.
Yes. So first you have to see the all upper division branches
Yeah.
until its complete course, so that you have to work deep to the facial nerve in the depth of the masseter.
Yeah.
You can protect the facial nerve branches properly.
Yes.
And then between the branches, between the zygomatic and the temporal branch, you have to look for the mesenteric nerve.
Good.
That is how you can do. Any questions, sir, before we move on to the next stage?
There is one question by Sunil Sende, which is a very basic question and a good question. Do you use negative suction drain or a simple corrugated or a gloves drain in this case from Nagpur?
Corrugated drain,
Okay.
never a negative pressure in such a small resection.
Yes.
Simple corrugated and a pressure dressing for a day or two and then remove the drain. I don't want to damage the exposed
Yes.
facial nerve branches by the drain.
Then there is Kalal Vani from Chennai asking how will superficial lobe tumor spread to the deep lobe, sir?
Yeah, certain percentage of patients, not only malignancies but adenomas too.
Yes.
And obviously, if there is deep lobe extension, you have to. The best thing is identify preoperatively. Give patient prognosis is little, once you deal in the deep lobe, the affection of the facial nerve is much more than a superficial parotidectomy.
So it should be a guarded prognosis to explain to patient.
Manipulation. So now you need to explain patient once you are dealing in a deep lobe tumor.
Okay.
There's a chance
Last question of the series. Last question I take up. Dhiren Kumar from, just a minute. Let me finish, Sanjeev. Dhiren Kumar from Sivan. He want to ask, many times perichondrium on medial aspect of the cartilage lead to adhesion. How far it is true?
Medial aspect of the
perichondrium. I don't think there is any chances of getting adhesion to the nerve.
No. I think this question is for the tympanoplasty. This is not. This doesn't apply here.
Okay, fine. Okay, then I finished with from my side. Yeah.
Question, sir. So nicely you have done the periodictomy with microscope. Is there any question to think about retrograde periodictomy?
Yes, very important question.
If there is, in which situation you approach in that way?
Yeah. That's a very important question from master. Retrograde parotidiectomy, when is to be considered? Retrograde is what I have done is antegrade parotidiectomy.
Yes.
Identify the trunk of the facial nerve and then went distally. Retrograde is
from periphery to
when you identify one of its branch and go proximally. So when it is required, number one, many a time in revision cases with fibrosis and you are finding difficult to identify the trunk of the facial nerve, and too much of the manipulation can injure the nerve in that situation. In that situation, you can come from one of the peripheral branches. Maybe the simplest at the gonian, the marginal mandibular branch.
Yeah.
Cervical branch, by simply identifying the retromandibular, you have seen the close relationship.
Yeah.
And then come proximally. So one of the situation is revisions. Second most important situation is where the tumor is more proximally situated.
Yes.
Okay.
The tumor is situated more proximally where the facial nerve is coming out of the mastoid.
Yes.
There extreme laterally the tumor lateral to the nerve, then it is better to identify one of its branch distally and follow it proximally rather than going through the tumor. So that's
excellent.
Yes. So this is the advanced stage of doing surgery, parotid surgery, I think. So beginners should always keep in mind.
Yes.
That
so in a regular situation, primary situation, not a big tumor.
Yeah.
You don't need to do that.
Yeah, exactly.
But one must be well versed in identifying this patient now in the
this is more
fashion.
Important.
Yes. We must know.
Thank you very much, sir.
We must practice on the cadaver.
The most important message, we follow the disease. Yes.
We should be able to identify the main trunk through any of its branch available.
Okay, sir. That is the main crush of this whole discussion. Thank you very much, sir. So nice of you for a great surgery and great demo. Thank you very much.
Thank you. Do we go ahead with the next case?
Yeah, sure, sir.
So let me tell you, this patient is a 50-year-old who has taken several courses of antibiotic steroid somewhere, and we did a lot of assessment of this patient who had polyps also. And this is the picture after the steroid course, what you are getting.
Oh.
Yeah.
So first of all, in the chronic rhinosinusitis, the role of CT scan, the timing of CT scan, and the kind of CT scan required. So the role of CT scan is not for diagnosis. 99% of the time sinusitis can be diagnosed on the clinical grounds. With clinical history, the most important is the history and then endoscopy. The CT scan is required to give you anatomical details for surgery, to rule out any other thing than sinusitis. That is the second reason to order CT scan. If you suspect something else, like you have some funny symptoms which warrants you to get CT scanned, and the patient sometimes says endoscopy is negative, history of cold, recurrent cold, this and that, and severe headache, then you have to rule out something else. At least to rule out that this is not sinusitis. But most of the time when it comes to sinusitis, the role of CT scan is to give anatomical details for the surgery. And for that, the kind of CT scan required, what you see on the screen here, 0.5 mm on DVD. 0.5 mm so that you can reconstruct in all planes with full details you have on DVD. So I like this particular scan.
Yeah.
This is 0.7 mm. See this. How many slices are there? 421. Because the area scanned is almost 25 centimeter. 0.7 mm, 25 centimeters scanned in the axial plane. Only axial plane. We shoot only in axial plane. And it gives 421 slices. Now let me reconstruct in all planes. How will it be? 1263 slices now. Now I will change my soft tissue window. Different window settings. See this?
Yeah.
Double the number of slices. More than 2500. How a patient can carry.
Yes.
दोनों दो है दो है ये ले ले मैं पता हाँ दूसरा ले ले अंडर कर देना. So it is practically impossible to carry patient for all those printouts for 2500 slices. So it is not required as well to get, simply have the data in the DVD, only axial, and then your software will reconstruct to everything.
Yes.
And more than
This
that,
is
you
the
will get
DICOM
a
software.
dynamic detail. You
Dr.
will get
Satish,
a
this
dynamic
is
detail in all planes. See that?
this is DICOM software.
This is DICOM.
Yeah.
So
Please go
now
ahead.
you get the dynamic information in all planes, and this is the best tool to learn the anatomy also.
Yeah.
Suppose I want to see which cell is this. See this cell in axial. You can see in the coronal, you can see in the axial and the sagittal, two anterior cell, two anterior. It cannot be anything else than the intersinus septal cell. See that? So dynamically, you can see each and every structure right from the origin to insertion, which gives you 3D orientation of the structure you are going to deal with. You can get a print out and see this patient has a sinusitis, but that doesn't give a full dynamic anatomical information, because this surgery is the surgery having very low threshold of complication. You are millimeter away from the skull base and orbit. You have to have a complete 3D information of the surrounding. In some millimetric information, what you get dynamic is something important to prevent complications. That's why we need dynamic. Every structure you can find dynamic, information. Each and every structure you can get. This is uncinate process. See where it is going. It is merging with the, lamina, this aganage cell, and going up to the lamina. Each and every structure you can follow. Sometimes on a snapshot, you may be confused whether it is onodi or not. See dynamic, whether it is onodi or not, how the cell is placed in relation to the sphenoid sinus, how it is going beyond the sphenoid sinus. Everything is possible. It simplifies your orientation.
Yes.
In sinus surgery, we have two goals. One is, like in this patient, we are going to do a full sinus surgery. We have two goals: to complete the procedure in one go with complete removal of the septations to ensure that drug reaches, the steroid reaches post-operatively everywhere, at the same time preventing complications. That is very, very important, because the margin of safety is very less in sinus surgery because of its close proximity to the orbit and skull. Right, division? So this is how you need to look at the CT scan. Now, coronal is the most important. It gives you information in the same plane in which you operate. And you need to see the CT from beginning, see all anatomy of the nasal bone, the beak, below the floor of the frontal sinus, beak. This is the intersinus septal cell. Now the beak is going, the ethmoid starting. The frontal sinus is gone now. The ethmoidal roof has started. And this is what? The supraorbital cells, more developed on this side as compared to the other. And then it is the ethmoidal, the frontal outflow, the ethmoidal outflow. This is crista galli. And at this point, see this canal emerging from the orbit going to here to the skull base. This is orbitocranial canal harboring the anterethmoidal artery.
Anterethmoidal, yes.
See, if I come anteriorly, this is frontal sinus. Now see, I am going posteriorly. How posterior is the anterethmoidal artery? See now.
Yeah.
How posterior it is. So once you are operating in the frontal sinus, you don't have to terrified with the anterethmoidal artery. Let me tell you, if I run in all planes, where exactly the anterethmoidal artery in the anteroposterior plane. See, this, my cursor in the coronal plane is at the anterethmoidal artery. Now see in the sagittal. If you are operating in the frontal, your anterethmoidal artery is far behind.
Yes.
See, with this cross edge is the level of the anterethmoidal artery I have placed here. And see, this is the beginning of the ethmoid here. This is the end of the anterethmoid. And immediately behind the anterethmoidal artery is the beginning of the postethmoid. These three, 1, 2, 3 are larger postethmoidal cells. A millimeter behind the anterethmoidal artery. See, this is anterethmoidal artery here. A millimeter or so behind the postethmoid starts. So you can say the anterethmoidal artery runs through the posterior most part of the anterethmoidal roof. And that is a landmark for the beginning of the postethmoidal roof. That is how you can take this artery as a very good landmark on CT scan. So these are fine points. That reading a CT scan requires time. I am just going through quickly to run through some important points, and you can see the opacification everywhere.
Yes.
Some deviation of the nasal septum, extreme deviation. The sphenoid sinus, this is the pterygoid process, what we drilled in the mucor case. In mucor case, I showed you two nerves.
Yes.
Medially was the median and laterally was the V2.
V2.
And this entire process we drilled off right from here till here.
Yeah.
Where the mucor was invading.
Yes.
And just about this is the floor of the middle cranial fossa. This V2 comes from the floor. See the opening. It comes from the floor of the middle cranial fossa as a branch of trigeminal. And just about the temporal lobe. And when we drill this temporal, this pterygoid, I showed you the dura. That is the level of the dura there.
Yes.
This is how the tumors from here easily spread to the temporal lobe. You see the angiofibromas, many malignancies, and even the mucor spreads to the temporal lobe right from here. So this pterygoid is a very important anatomy, not in sinus surgery, but in other areas, other surgeries, and then behind is the sphenoid sinus with minimal opacification.
Dr. Satish, one message to juniors.
Yes.
Those who are not very conversant as to understand radiology, it takes good time. Somebody asked about the DICOM software that can be downloaded. Free version is available on Google. And they must sit with the radiologist on the console and try to understand with him for the beginning.
Yes,
is that correct approach? Yeah.
Yes. See, once you start acquiring your data in DVD, with this software only you can understand the entire radiology in all planes.
Right.
Because suppose I am running in the coronal plane and want to see what cell is what.
Yes.
You can easily see.
Easily,
See, if I run this, see now this is supraorbital cell. This is supraorbital cell going beyond. This is supraorbital cell going beyond. Now see, this is about the orbit. See relationship to the orbit in all planes.
Yes.
Now, if I am coming to the frontal sinus, you see all the frontal sinus
Right.
in all planes.
Yes.
Any possible cell, see this is cella,
Yes.
where my cursor is.
Yeah.
This sphenoid sinus,
Yeah.
could this be ONOD?
Yes.
See this? Yes, this sphenoid sinus is dividing horizontally here.
Yes.
This could be possible ONOD on the right side.
ONOD, yeah.
Yes.
So the radiology can be best understood on the software.
Yes.
On this, if you acquire the data, the soft
And
data,
this gives a three-dimensional view, so hardly any structure that can be missed if you watch
any
it
structure
properly.
you can see.
Yes.
Any 3D relationship,
Yes.
you can reconstruct in more planes. Oblique sagittal,
Yes.
oblique longitudinal, oblique coronal, anything you can do. You can measure the
Yes.
distances, sir.
Yes.
Suppose you want to measure any distance. Suppose you want to measure the distance from the anterior wall of the sphenoid to posterior wall. See this? Just a minute. Yeah, let me, any distance. Suppose sphenoid sinus.
Yes. Yes.
I can measure the distance.
Yeah, there is a scale. Yeah.
Angles, distances, anything you can do.
Yes.
This is your medial rectus muscle, and this is your lamina papyracea anteriorly. There is 4.5 or so, 4.8 millimeter fat
Yes.
between the lamina and the muscle anteriorly,
Muscle.
in the anterior
Yes.
thmoid. Posterior thmoid, there is no fat in between. If you injure
Yes.
the lamina, your muscle is right there.
Yes.
Any distance you can measure in any plane, any angle. This is carotid artery. This is the prominence of the carotid on both
Yeah.
sides.
Mm-hmm.
So radiology, you can ask me anything. It is, I'm not going in detail myself. These were the fine points I touched upon.
Yeah.
Anything, any questions so far, so that we can go ahead with the case? I'm going to
No,
demonstrate
please
case
go
on
ahead
both
with the
sides.
case, sir. Yeah, please. Go ahead, sir.
Okay, sir.
For the viewers, apart from DICOM, there is another software, Horos, which is also available almost free of cost. Probably it's free of cost.
On Mac, on the Mac platform, it is Osirix,
Osirix, yeah.
same like Radiant.
Yeah. So what was the presentation of this patient, Satish?
This patient is a classical, nasal obstruction, nasal discharge,
Mm-hmm.
sometimes headache.
Okay.
And on endoscope, it was very obvious of sinusitis. Had
Yeah.
good response in between with the antibiotic steroids.
Okay.
That's why he has been, passing
Pulling on so long. Yeah.
treatment several times.
Yeah.
Yeah. So in sinus surgery, the first thing when it comes to surgery is the preparation.
Yes.
We need to prepare our patient thoroughly to get a good surgical field. The preparation has a role to improve the surgical field, and that should start even days before the surgery to reduce the vascularity. This is unprepared nose. Can you see? Hello?
Yes, yes.
See, no decongestion has been done so far. Unprepared. And what you see there are the polyps. Can you see?
Yes.
Yes, yes.
How is the picture now?
Excellent. Now you are out of it.
Okay. So now, as I was talking about the preparation, pre-operative preparation is important, and equally important is the intraoperative. In pre-operative, we reduce the inflammation by giving steroids. If secondary infection is there, then antibiotics as well. And intraoperatively, decongestion to reduce the vascularity. And the best way of decongestion, what we believe, we have stopped infiltrating for more than 10 years now. See this?
Yeah.
This is the marrow cell sponge, a piece of marrow cell. We divide the marrow cell in 8 to 10 pieces, 2 marrow cell, soak in saline adrenaline. This is 1:1 combination. This is not a cardiac patient or anything. And we can use it topically, not for infiltration. No infiltration at all. Just topical application you can see to improve the status of the mucosa to decongest the capillaries. In this surgery, the main source of bleeding is capillary, not the arterial like tumors like angiofibromas. It is always the capillary bleeding which is need to be controlled, which is responsible for the, good surgical field, responsible for the bleeding. Now see the picture after the first application of the.
Yes, yes, yes.
It has opened up the space. There was hardly any space earlier.
Yeah.
And see, this is simply application. You don't have to press hard this.
Yes.
Our job is to apply adrenaline, not to apply pressure.
For how long you keep the adrenaline?
This entire decongestion requires 5 to 10 minutes, sir. Yes. To all mucosal surfaces. Why I'm saying not to press hard is, if you press hard this marrow cell on the mucosa, it is going to be counterproductive.
Yes.
By means of blocking the venous drainage, it will rather result in more bleeding. More troublesome, more frustrating bleeding. So never pack tightly with anything.
What is the ratio of the saline and the adrenaline?
This case, 1:1 I am using.
1:1, okay.
In elderly cardiac patients, I can dilute to 1:4. In young patient, children, I don't mind using pure. 1:1000.
Okay.
Okay. And steroid pre-op, how long you give? 3 to 5 days?
Yeah, 7 to 10 days, depending upon the other condition. Sometimes we have a long distance patient who come for surgery. We tell them on phone to start some treatment. Sometimes we don't have too much time for the patient to stay and all that. We may have to do in 3 to 5 days. But yes, in routine planned patient, 7 to 10 days at least.
7 to 10 days. Dr. Man Prakash Sharma is watching and he has commented, great surgical demonstration, dear Satish.
I am his, he is my favorite teacher.
Yeah.
Grateful to sir.
Yeah, that's why I brought it.
Thank you, sir, for always being with us. He's a great person.
Yeah.
Great teacher. And a lot to learn from him, always. He encourages always, supports always for everything.
Yeah.
This is the middle meatus now. My pack is in.
Yes.
To decongest. See, the polyps have been decongested.
Yeah.
The initial picture, what you had seen and now, is altogether different.
Right.
I showed you the unprepared nose with full of polyps.
Yes.
And now see.
Dr. Satish, one thing, most of the people want to do it under local anesthesia, and in that case, the preparation will be altogether different,
Let me tell you about that. See what I'm doing here, it's out fracturing the inferior turbinate.
Yes.
To get more space,
Yeah.
Now coming to your point of local anesthesia.
Yeah.
Number one, why it was introduced earlier. Why we always discuss.
local anesthesia gives you a great feedback.
Yeah.
If you cross your limits of sinus cavity and approach to the adjacent area like skull base or orbit,
Mm-hmm.
whatever local anesthesia, good anesthesia you have given, patient will invariably experience the pain.
Yeah.
And that is the amazing feedback to the surgeon that you are crossing the limits.
Right.
So that is the value of the local anesthesia, how it was introduced.
Yes.
But now, with the advancement in the anesthesia technology, with the advancement in the anesthesia, with good, prevention of vasodilatation. Local anesthesia, another advantage was
Yeah.
you can reduce the vasodilatation. That is one of the reasons for more
Right.
bleeding. And it was supposed that the
Mm-hmm.
overall bleeding is less in local anesthesia as compared to general. But now with the advancement in the anesthesia technology, we can have a better field under general anesthesia, number one.
Yeah.
Number two, you can more freely use the powered instruments.
Yes.
In under local anesthesia, in a wake-up patient, if you use a debrider, is a you can think of if somebody is running some drill in your head.
Yeah.
You know how much discomfort one can expect. So the cooperation of the patient is a big problem sometimes. And third is the airway security.
Yes.
Now we are so secure about the airway with the intubation, cuff, the throat pack, and then we leave another pack over here. There's no question of any aspiration.
Yes. I think airway security and the hypotensive anesthesia or the technique of anesthesia which gives less hemorrhage is probably the key.
Pardon?
The hypotensive anesthesia nowadays giving less and less of the bleeding, controlled bleeding, and secure of the airway is probably much more important.
Yes. That's why we always do under general anesthesia.
Yes.
Now this is about the preparation part. I told you 5 to 10 minutes.
Yeah, it is.
Topical application.
Yeah.
I keep the head 15 degree up for the better venous drainage from the head. This is the only preparation we do intraoperatively.
Yeah.
No injection, no infiltration. Infiltration has its own adverse effects. They have been proven, published. Infiltration going into one of the internal carotid artery circulation, anterothomoid circulation going to the ophthalmic artery leading to blindness.
Blindness, yes.
Yes.
Infiltration going in the systemic circulation leading to arrhythmia, cardiac arrest reported. So why to take such a chance in such a benign disease unnecessarily? Now see, these are polyps which have been compressed. See this? These are
Sir, one more question, sir.
Yes.
Completely
Sir,
decongested.
Sir, what about the heart rate? Would you like to comment something upon that?
Yes.
Heart rate.
So our patient, let me tell you our monitor. I tell you, we never believe in hypotensive anesthesia. Always normotensive. We don't want to put our patient under risk. See this. If you see our monitor, our blood pressure is 133/89. Can you see?
Yes.
Yes, sir.
Mean blood pressure 104. No question of hypotensive, but look at the pulse.
Yes, sir.
Around 50, 60.
Yeah.
Reduced cardiac output is the major determinant of the overall bleeding, and that is achieved best by bradycardia.
Yes, sir.
And it is safe for the cardiac patient also. You reduce the cardiac output, you reduce the cardiac load.
Yes.
So the best thing is to reduce the heart rate rather than reduce the BP. In a cardiovascular labile patient, coronary labile patient, a reduction of the BP can result into ischemia.
Yes. And
Now the first thing what I am doing,
by giving repeated injections,
debridement of the polyps. Yes, sir.
Yes. I said by giving local injections, you create the mucosa to be unhealthy. Yeah.
Yes.
You have some bleeding points with the needle points, So
See all these polyps I am removing. And you will be able to see the anatomy better now.
Yes.
Now I can see the landmarks better in the lateral nasal wall.
Yeah.
This is your uncinate process. This is your bullite modulis. This is your middle turbinate.
Yeah.
Can you see better now?
Yes, yes.
Yes, sir.
After debridement of all the polyps now
Yeah.
here, again, I will use my marrow cell. We call it as a magic marrow cell at this point of time. Soaked in the same solution. I told you, we cut in 8 to 10 pieces, soak in the same solution, again and again, rinse into the saline, soak in the same solution. Throughout the surgery, we can use it. At the end of the surgery, soaking in the steroid, we can pack in the ethmoidal cavity as well. So just apply the marrow cell for few seconds to take care of the oozing. See this?
Yeah.
See, this is a soft pack, not a pressure pack.
Yes.
Just to apply the adrenaline. I'm leaving this gauze in the nasopharynx to prevent trickle behind.
Yeah.
Why not marrow cell? Why this pack? Because you can suck over the pack better.
Yes.
Now see the field. Wash. Every time you can improve
It's
the field.
bloodless. It's bloodless as well as you got more space to work also because of the decongestion.
Yeah. See this? Now, coming to the steps of the sinus surgery, I'm going to show only one side.
Yes.
This is the same repetition I've shown so many times. So the first step of sinus surgery starts with the uncinectomy.
Uncinate.
So important a step to carry out a total uncinectomy. Improper, incomplete uncinectomy can be a cause of mechanical cause of failure, which is certainly avoidable.
Yes.
Sir,
You said you have demonstrated so many times, but I think these steps are probably the foundation stone, you know. In spite of telling so many times, still proper uncinectomy and everything is very, very important. Yes, Dr. Kranti, you wanted to add on something.
no, I just wanted to ask Jain sir's view regarding his enterostomy size. There was this webinar where I just, the concept of mega enterostomy and enterostomy depending type of lesion which you're operating upon. So what is, do you do have you had a plan for enterostomy size disease wise, or it is somewhat uniform for?
Yes, that's a very important question from Dr. Kranti. See, first of all, why this question arises? What is relevant to the size of the enterostomy? The reason is earlier it used to be believed like a bigger enterostomy can lead to more air currents directly coming to the maxillary sinus, leading to headache. It leads to diffusion of the nitrous oxide, which doesn't concentrate, which is considered to be bactericidal and can be hazardous. It has all been disproven, number one. Number two, the size of the enterostomy now is related to the demand of the topical steroid post-operatively.
Okay.
For example, the patient with a massive eosinophilic profile, I would like to create a mega enterostomy to deliver more and more topical steroid.
Yes.
Patient with a more massive fungal disease, I would like to create a more massive mega enterostomy for the lifetime surveillance. You know, lifetime irrigation, surveillance, more steroid going in, all are the purpose for mega enterostomy. And second is for non-sinus surgery as an approach to go behind. In a regular situation, not having massive mucosal disease, not having massive eosinophilic disease, there is no point in creating a mega enterostomy. That is the perfect way of, defining the need of mega enterostomy, I believe. Now, this is your uncinate process. Can you see?
Very well, sir.
Everted. See this everted?
Very
Why
clear.
it was everted?
Yes.
Yeah.
Because of the polyp
disease. Yeah.
See, this is uncinate. This is uncinate. Why it is uncinate? Sometimes there are
mobile.
you can't identify uncinate so easily. See this. See the mobility.
Yes.
Yes.
Only structure in the entire nasal wall, from anterior to posterior, right from here. Nasolacrimal, that this, bulla, everything there, the only mobile structure is uncinate.
Uncinate.
So in difficult situation, you can identify the uncinate very easily by its mobility. And you must be able to identify it properly as well, because in the beginning, if you are disoriented, you are likely to give complication by means of entering into the orbit or anything else, because this uncinate has a closest anatomy with the relationship with the orbit. Immediately lateral to the uncinate is the orbit. I will show you. So that is important. So now where to go, how to remove? See, this is uncinate, this is bulla, in between this is a two-dimensional hiatus semilunaris inferioris. Okay?
Yeah.
And this hiatus leads into a three-dimensional area where my probe is going.
Yes.
That is infundibulum.
Yes.
And in the infundibulum laterally is the ostium of the maxillary sinus. So my goal is to uncover this area completely. So what I will do, I can remove this uncinate using a sickle knife also here. I can take a sickle knife right from here to here, but you never know. This orbit is very close to the laterally to the uncinate. You can enter into the orbit very easily in the beginning. So the best way is go behind. We know the space there. That is infundibulum. Go behind, engage your reverse biting, and bite through it. Come anteriorly and bite through it. This step is known as infundibulotomy.
Yes.
The only concern while coming this anteriorly is the nasolacrimal system.
And
yes.
You have to be careful. If you find any hard thing coming across, stop there rather biting through the nasolacrimal system. See, I am just removing. What I have done is infundibulotomy.
Yes.
This three-dimensional space is infundibulum.
Yes.
Where the polyps are coming. Now, this is uncinate upper part, this is uncinate lower part. See this? Now I fracture the lower part of the uncinate. See this? To open up the maxillary sinus. This is middle meatal enterostomy.
Yes.
See all these polyps? See the maxillary sinus?
Yeah. Beautiful.
This is the simplest way. I haven't removed the upper part of the uncinate yet.
Yes.
This is my red 40 microdebrider and a wide angle 0 degree. Though the interior of the maxillary sinus we will see later.
With the 70 degree.
With the 70 degree.
Yeah.
And see the massive, polypoidal mucosa. This patient has a eosinophilic disease. Profile is purely eosinophilic. I will create a little
bigger one
enterostomy so that I can deliver more steroids.
Yes.
More effectively in the post-operative period.
Dr. Satish.
Yes, sir.
For the sinonasal polyposis, one concept is now growing very well regarding this ethmoidal part and the maxillary part. That people are removing the middle turbinate and superior turbinate entirely to prevent the further recurrence of the polyp. How do you see this, and how do you
so this removal of the middle turbinate
is
a great idea in certain situations. That removal, the definition of removal we need to understand. Definition is not chopping the middle turbinate completely of the insertion.
Yes.
Not completely chopping to the level of the skull base. Removal of the lower half of the middle turbinate,
lower half,
third, to ensure the steroid going more effectively in a massive mucosal disease. To ensure that the turbinate doesn't fall back and close the ethmoidal access. In those massive mucosal disease situation, it is always better to resect the part of the turbinate. That doesn't mean that you chop it off completely.
What about the superior turbinate?
Superior turbinate, again the lower 1/3. Not entirely, because lower 1/3 of the turbinate, if you improve the access to the sphenoid sinus. Otherwise, the superior turbinate doesn't limit any access to any other sinus.
Right.
Only lower 1/3, which we always remove.
Right. Right.
Always remove.
And one more question, sir, here.
Yes.
When you are approaching maxillary sinus, please enlighten us how to approach anterolateral and what could be the possibility to reach there.
Yes,
The
that's a
different
great question. Again, I tell you,
different instrument.
anterolaterally, to reach anterolaterally, first of all, you can use your 70-degree and your angle instrument, but sometimes it is not all that easy and still it doesn't give that much of access. In that situation, what we do, the simplest way, if you want, I can show you.
Yes, sir.
We use the trocar and cannula to make an opening in the sublabial region, 4 millimeter opening, and pass our debrider through that and 70-degree from inside the nose. You can
Sir,
access
what about
each and every nook and corner of the maxillary sinus.
Yes, yes.
So
And
what about the pre-lacrimal approach, sir? Nowadays, everybody is
Pre-lacrimal is a
talking about
different approach.
pre-lacrimal.
This is not pre-lacrimal, find out. This is
Obviously,
not
this is
pre-lacrimal.
sublabial, but do you go for pre-lacrimal approaches?
Yeah,
for,
let me pre-lacrimal again is a good approach for certain indications. Pre-lacrimal is simple, not to get confused with any other dankers or all. See, this is the what you call that piriform aperture.
Yes.
Yeah.
So, oh gosh, please, oh, let me put a Merocell here for a while. Yes. So in pre-lacrimal, this is your piriform aperture. And your nasolacrimal duct is right here. See this? Coming more anteriorly here.
Yeah.
1 centimeter from the attachment of the anterior end of the inferior turbinate. So your nasolacrimal duct is coming here. To access the maxillary sinus head on, what you can do, I can make a simple incision. See this? Very good approach. I can make a simple incision at the piriform aperture like this. Right deep to the bone and elevate this flap completely. Okay?
Okay, sir.
And then with the drill, I can make an opening in the anterior part up to the level of the nasolacrimal duct. That opening, pre-nasolacrimal duct. You can open, you can go head on in the maxillary sinus, do your work, and come back, reposit your flap back here and put a suture. Without damaging the lacrimal duct, working anterior to it to enter into the maxillary sinus and work there. Elevate the flap and reposit it back is a pre-lacrimal approach.
Okay.
Okay?
And what about the inferior enterostomy approach combined?
Inferior enterostomy is now no longer practiced. Advent of pre-lacrimal, sublabial, enterostomy and dankers and all these approaches. Inferior is, it's a blind procedure. You can traumatize and it is never a long-lasting approach. Okay? So this is the first part, that is middle meatal enterostomy. Okay? Now the second part, this is my uncinate.
Yes.
Yes. I told you my concern is this uncinate is immediately medial to the orbit. See this upper part of the uncinate, what I am doing, going behind with the angle curate, come anteriorly. Every movement should be anterior away from the structures behind to prevent damage. Once you dislodge, you can debride it. You can use a through biting also. See this, completely debride upper part of the uncinate and you will be right at the lateral limit of your dissection, that is orbit. See the lamina peperetia?
Yeah.
This is lamina peperetia.
Yeah.
So while removing the uncinate, you have to be careful not to damage the
lamina.
Yes. That's why we don't recommend the sickle knife. Look at the CT scan. If the space is not much, not to use the sickle knife, rather use a reverse biting.
Yes.
Sir, I had one more question regarding dankers. So, yeah, in these angiofibroma, I also do modified dankers for all these approaches. But I have had 2 patients with nasal valve collapse. because
Nasal wall
you
collapse.
removed the piriform upper. Yeah, so it was actually alar collapse. That's a
Yes,
very
so
big
that
problem,
is important.
sorting it out.
I always mention doing Denkers. See this. This is your anterior limit. You have to make sure that you don't come anterior to the piriform aperture at all. See, this is
Okay.
piriform aperture.
Yes.
You come anteriorly, this is your lower ala.
Yeah,
If
okay.
it is lower ala, then you need support.
Yeah.
So be careful.
So piriform aperture is the landmark that you should never cross.
Yes.
Okay.
Now see the important landmark here. I've already shown you the entire lateral limit of our surgery.
Yeah.
That is lamina papracia. That is the beauty of removal of this upper part of the uncinate. Okay. So my corridor lateral limit is lamina, medial limit is turbinate. Okay.
Yes.
Now this upper part of the turbinate, see this. This upper part of the is the uncinate. It fuses with the agar negi, medial wall of the agar negi, and then insert along with that on the lamina papracia. See that?
Yeah.
That is how I am removing. This is still with a 0 degree.
Yeah.
See the 0 degree, completely with a 0 degree so far, red 40. And see the entire medial wall of the orbit is skeletonized. Can you see? With complete mucosa intact. Now, at this point of time, see what you see in front is the bulla.
Yes.
Yeah.
I haven't done anything to the bulla. At this step, there is reason to, I will tell you, we changed to 70 degree to do the frontal sinus work. For the reason I'll tell you, because we have more landmarks at this point of time to carry out a safe and an easy frontal sinus work. Let me tell you. This is the point. And the thing which is important behind that is the 70 degree. Without 70 degree, one cannot carry out a good, confident, a complete, comprehensive frontal sinus work. Believe me. Now with the 70 degree. See the view with the 70 degree up?
Yes.
That is your axilla.
Yeah.
Now with the 70 degree view, see this bulla?
Yes.
See this turbinate? What I have removed is the part of the agar negi. See this. For my frontal sinus like, you know, it's like a box. See, this is the floor of the frontal sinus. This is all is the floor. Here is all is the frontal sinus right from anterior to posterior. And this floor is formed by this beak. This is beak.
Yes. Yes.
Okay. Give me a merocell, small merocell to show you clearly. Let me show it clearly. Anybody has any doubt in the frontal sinus, let me tell you the simplest way to carry out the frontal sinus work in the most difficult situation. Don't get confused. The frontal sinus is not difficult. What all you need to have is a 70 degree and certain landmarks in orientation. Simplest landmark. And the simplest here is the beak. I showed you on CT scan the floor of the frontal sinus formed by the beak. See the beak?
Yeah.
Yes.
Secondly, this middle turbinate goes up to insert on the lateral lamella of the cribriform. So stay lateral to the middle turbinate. See this middle turbinate?
Yes.
All the way stay lateral to it. Don't go medial to it, otherwise you can damage the cribriform. See that? And this is the upper end of the bulla. This agar negi I have removed, and this is the beak, total beak.
Yeah.
All along the beak, between the medial and the lateral limit, there cannot be anything else than frontal sinus. 1000% it is always frontal sinus. If you have a clear understanding of three things. Number one, see this? I told you my lateral limit is what? Orbit. Medial
Orbit,
limit is what? Turbinate.
Middle turbinate.
Turbinate.
This is all beak.
Yes.
And where the beak ends, is going to be what? The frontal sinus.
Frontal sinus opening.
Cannot be anything else. All you need to see under vision is through the 70 degree. And see now, let me show you. See, I told you once you work far anteriorly here, you don't have to look for the anterethmoidal artery at all. See my beak, where the beak is ending. See where the beak is ending. What is there?
Yes.
Frontal.
Again. This is the beak. Can you see?
Yeah.
Beak, and the beak ending is frontal sinus. What you need to see is stay between the lateral limit, medial limit, go along the beak where it ends in the frontal. And you're working in the anterior trajectory. Your anterethmoidal artery is miles away.
Yes.
It is in the posterior most part of the anterethmoidal roof. Once you're working in this region, you don't need to terrify with the anterethmoidal artery. First, the beginning of the anterethmoidal roof is more than a centimeter from the beak. More than a centimeter behind is the beginning of the anterethmoid. And the end of the anterethmoid is going to be the anterethmoidal artery.
Yes.
So don't get terrified. Number one. Now I can enlarge this beak with a special instrument. I love this instrument. This is,
Satish sir.
Yes,
Satish sir. So nicely you have given the point. We have been working for many years for inventing always a different instrument for frontal sinus approaches.
See now, more frontal is coming in the way.
Yes.
I am removing this beak with this, this special instrument.
Yeah. What kind of a special instrument and what are the curvatures and what is the crossover phenomena during surgery?
This is an amazing tool from Karl Stores.
Yeah.
See this. See the frontal.
Exactly.
Thoroughly. This is articulated punch.
Yeah, so for residents' sake also, if you could say how suprabular recess can be differentiated from a frontal recess,
Yes,
and how you
I
have
will.
to go medial to that.
Definitely, I will show you now. All these fancy cells, all these fancy named cells in the paranasal sinuses, mind it, all are ethmoidal cells. Like Dr. Kranti is saying, suprabular cell, infrabular, Heller cell, Onodi cell, the frontal cell, this cell, moon cell, all these fancy named cells are ethmoidal cells invading the surrounding bones. That's how they are named.
Yeah.
So like what she's asking for the suprabular cell. Now that's a very, very important question, because if suprabular cell is there and if you are not aware, you can give complication. So to understand the suprabular cell, let me tell you where is bulla first. And where could be a suprabular cell? Can you see the bulla here?
Yes.
And how the bulla is ascending up to the level of the skull base?
Yes.
That happens majority of the time. Majority of the time, what happens? Like this. The bulla goes right up to the skull base.
Yeah.
The bulla from here goes right up to the skull base.
Yes.
And behind the bulla is the anterethmoidal artery. If I fracture this bulla like this, you'll find the anterethmoidal artery protected by it. What's my point?
Yes.
Yes, sir.
And that's a very good protection for the anterethmoidal artery. Let me show you. Now, what Dr. Kranti is asking about the suprabular cell. When this bulla is not ascending to the skull base, that area is occupied by a cell. Can you see the artery behind? Let me show you.
Yes, very clear. You can just see the leg.
I just fractured the bulla to show how the bulla protects the artery. See the artery there?
Yes.
Can you?
Yes.
So what I did just to show you why I approach the frontal sinus first before removal of the bulla. This is bulla.
Yeah.
I did not remove it and did the frontal sinus job first because the bulla itself protects the anterethmoidal artery from surgeon.
Yes.
Yes.
What's my point?
Yes,
So
sir.
that's an additional protection for the anterethmoidal artery. And now what Dr. Kranti is asking about the suprabular cell means the bulla is not ascending to the skull base.
Yes.
It is not protecting the anterethmoidal artery now, because the anterethmoidal artery runs along the skull base and bulla is not reaching there. And there is a cell there. So then the anterethmoidal artery remains unprotected. Got my point?
Yes.
So what is the difference? What is the difference? Suprabular
That is
recess and
suprabular
suprabular
cell. That is suprabular cell. You need to see on CT scan whether there is suprabular cell. Your anterethmoidal artery may be more exposed, to be injured.
So, yeah, any difference between suprabular cell and suprabular recess?
Suprabular cell and recess are same things. No difference into it. See now, recess, why do people call it recess? Let me tell you. Now, I fractured the bulla to show you anterethmoidal artery. I'll come to your point, sir, again.
Yeah.
See this. I fractured this bulla to show that anterethmoidal artery is behind. Can you see that?
Yes.
Let me clear that
Yes.
region to show you first. And what is the difference in case you don't protect the bulla? Section and a very small marrow cell. See this. I will show you something. God has given a lot of protection to prevent complications. Still, surgeons are difficult. See, I'm decongesting to show you the artery better and the recess. This patient has a suprabular recess, I tell you. There are many names to that. Now see the artery better or not?
Yes.
This is the artery. See there?
Yes.
Running obliquely. This is the artery. Okay? And what is this small recess above?
This is the suprabular problem.
Suprabular.
Yes. See this. This bulla, which was coming over here, it was going on the skull base where this was the attachment of the bulla.
Yes.
See this?
Okay.
The septa which I have broken.
Yes.
This was attachment of the bulla and the artery was behind that, protected. Okay? And this small recess is suprabular recess. This is, what you see above is the roof. Can you see that? See, I'm using the reverse blade here. The so-called adenoid blade to remove this tip of the bulla, anterior part of the bulla, to show you something more. And see why this has other names also. See the suprabular recess?
Yeah.
Can you see very clear? This is also known as fovea. Fovea is a literal meaning means impression. This is ethmoidal cell, and this roof where I am touching, this cell's roof is formed by the frontal bone. So it creates an impression on the frontal bone above. That's why it is known as fovea ethmoidalis as well.
Sir.
Impression.
Yes, sir. What about hiatus seminaris superioris? Could you put in a word about that?
Hiatus seminaris superioris?
Yes, sir.
Yeah. Let me show you. I showed you between the bulla and the uncinate process, that was hiatus seminaris inferioris. Okay?
Yes, sir.
And the other fissure is between, other fissure is between this bulla and the middle turbinate. See this space? Bulla and the middle turbinate. Can you see this space?
Yes, sir.
This is hiatus seminaris superioris, and this leads to retrobular recess. See this? This is hiatus seminaris superioris, and this leads to retrobular recess. And I can go behind and fracture the bulla completely anteriorly now.
Yes.
Is it required to open this space, Dr. Satish?
This bulla is completely fractured out now. Yes, sir?
Yes.
Is it important to remove this space? The bulla removal, is it important? If the disease is only to the maxillary sinus?
No, in the isolated maxillary situation, you don't need to do that.
Yeah, that is what.
This is required in the eosinophilic and massive disease requiring a complete surgery, not in every case. See now, what we have done, we have removed the bulla.
Yes.
And now what we have achieved, we have exposed the anterethmoidal artery running along the skull base. See that?
Yes.
Now in the situation what Dr. Kranti was mentioning is suprabular recess. This bulla would not have been going to the skull base. And in that situation, you would find the anterethmoidal artery like this, exposed. So if you work along this region, you are more likely to damage the artery, not aware of the fact.
Yes.
Be careful. This is the simplest way of carrying out
that
the...
means what I perceived, Satish, that the fovea, the retrobular recess and the suprabular recess are the representing the same anatomical part posterior to the bulla from above downwards.
All the way, all the way.
Yes.
Now see, this is a complete anterethmoidectomy done.
Yes.
This is complete anterethmoidectomy done with preserved mucosa everywhere. Sinus surgery means functional endoscopic sinus surgery, and that function is served by the mucosa, fess. If you remove the mucosa, it is not fess, that is mess.
Yes.
Always preserve the mucosa, otherwise you don't preserve the function.
What about anterior ethmoid artery, which we have seen? Can it be left as such, or it should be coagulated from the center?
Anterethmoidal artery?
No.
Which we have exposed or shown just now, it is to be coagulated?
No, it is nothing is to be done.
Nothing is to be done. You can leave it as such.
See now, that is my maxillary sinus work done.
Yes.
Frontal sinus work done. See the frontal opening.
Yeah.
And then my anterior ethmoidal roof work done.
Yes.
Okay.
Yeah.
Now I will change back to 0 degree.
0 degree. Yes.
I told you one thing during CT scan, if you remember, this anterior ethmoidal artery runs in the posterior most part of the roof of the ethmoid.
Yes.
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 In the roof of the anterior ethmoid.
Yeah.
Means behind that, the roof of the posterior ethmoid should start.
Yes.
Yes.
Now see what is there. A few millimeter behind.
Yeah.
Just a minute. Clean up. That's a very important point I am going to mention now for orientation. Now, we have removed the bulla.
Yes.
What is this structure now? This one? After the bulla, give me the... This is ground lamella. That is ground lamella.
Yes.
What is ground lamella?
Ground lamella.
See this turbinate. This is the middle turbinate. It has 3 parts.
Yes.
The first one lying in the sagittal plane like this.
Yes.
Then it turns laterally. This is turbinate.
Yes.
It turns laterally to insert on the lamina.
Lamina.
So after the removal of the bulla, what you see in front of is what?
Ground lamella.
Ground
lamella. Basal lamella, which is a part of the middle turbinate lying in the coronal plane. See that?
Yes.
And it goes up to insert on the skull base.
Yes.
Yes.
It goes up to insert on the skull base. And it's an important landmark because all cells anterior to it, what we have done is anterior ethmoidectomy.
Yes.
Yes.
They drain anterior to what we have done. They drain anterior to bulla. This ground lamella.
Yeah.
Now all the behind are posterior ethmoids and sphenoid. They drain behind it. So it's an anatomical as well as physiological, importance to this ground lamella. Can you see ground lamella completely?
Yes.
How to know whether there is any retrobular recess present or not?
It was retrobular recess where I fractured the bulla from behind. Just before I told you, when somebody asked about the hiatus seminaris superioris, I went into that. Behind that was retrobular recess and fractured from behind anteriorly to get the bulla out. And after the bulla, now this is ground lamella. See now the ground lamella completely.
Yes.
See how the turbinate is continuing it. And we all know this is an important landmark because to enter the post-ethmoid, we need to go behind it.
Yes.
Fine?
Yes, yes.
Now, before going to the post-ethmoid, I will do certain things and show some important landmarks there. Now, the first of the question is, I mentioned the anterethmoidal artery and relationship, how it courses through the posterior-most part of the anterethmoidal roof. Behind that, the posterior-ethmoid starts. The posterior-ethmoid will start after the ground lamella.
Yes.
What's my point?
Yes.
Yes,
Yes.
yes.
This ground lamella's superior attachment to the skull base is few millimeters behind the anterethmoidal artery.
Yes.
What's my point?
Yes.
Now see, this is ground lamella. See its superior attachment to the skull base.
Yeah.
See this. This is ground lamella.
Yes.
And see its superior attachment to the skull base here. This is ethmoidal skull base anterior to the anterethmoidal artery. This is ethmoidal skull base behind the artery.
Yes.
And this is the area where this ground lamella is inserted on the skull base. Can you see here?
Yes.
Yeah.
This is here. And see roughly 1 or 2 millimeter behind the anterethmoidal artery is the ground lamella insertion. And behind that, the posterior-ethmoidal starts.
Yes.
That is the importance of anterethmoidal artery. A few millimeter behind is the upper attachment of the ground lamella.
Yes.
See, this is the upper attachment, this one, attached to the skull base, and behind that is the posterior-ethmoidal roof.
Yes.
This is important because now we have to enter into the posterior-ethmoid. Now, what landmark can I take to the posterior-ethmoid? What are the concerns? I can open anywhere the ground lamella and go in the posterior-ethmoid. What is the concern? Concern is I should not damage the skull base.
Yes.
Now, I have already shown you the upper attachment to the skull base. So, we would not like to go
Beyond that.
Oh,
Yes.
to make an entry there. What we will do? I will make an entry below. So what should be the level of entry? That is a very important landmark. I call it as a maxillary line. As a life-saving landmark for me. See this roof of maxilla?
Yes.
Draw a line parallel to it. This is maxillary line. Close to the transition between the first part of the turbinate and the second part. And here I will open into the ground lamella.
Okay.
Yes.
To enter the posterior-ethmoid. That is the site, safest region.
Yes.
Let me widen it big. The region is, if I go a little bit high up, see here, what is there? Skull base.
Yeah.
I can easily go and hit the skull base there. See that? See the skull base behind?
Yes.
And let me remove this just to show you something. That is the upper attachment of the ground lamella to the skull base. See there?
Skull base.
Up.
Yeah.
That is the posterior-ethmoidal artery, most likely. See that?
Yes.
So, see the fine bone which I left in between. This is
Yeah.
the upper attachment of the ground lamella to the skull base, which is just behind the
देखो जी माली होगा.
anterethmoidal artery. Got my point?
Yeah. Yeah.
So, the first thing is use the maxillary line and enter into the posterior-ethmoid. Number one. Number two, I don't want to complete the posterior-ethmoidectomy here because I don't know posteriorly comes where I accidentally enter into the sphenoid and damage the important structures there. So I have to be extra careful.
Yes.
So I will not do posterior-ethmoidectomy here first. I will search some landmark for the posterior limit of posterior-ethmoidectomy so that I don't enter into the sphenoid. So I will go here medially at the same point. See this? Medially and find
Superior
something.
turbinate.
Can you see?
Yes. Yes.
Superior turbinate. See the superior turbinate? And if I remove the lower 1/3 of the superior turbinate, we know where the sphenoid ostium is?
Yes. It is there.
Medial to that.
Medial to
Medial
that.
to the superior turbinate.
Yeah.
See that? This is nasal
Yes.
septum. This is nasal septum. This is superior turbinate. Now, where to look for the sphenoid ostium? Now, again, I told you this is my life-saving landmark. Maxillary line. If I don't take into consideration here, and suppose I look for the sphenoid ostium here, what can happen? The sphenoid ostium is not at the level of the floor of the sphenoid, not at the level of the floor, high up, close to the roof.
Yes.
If I don't take this line and go above that and open here, I will be right in the skull base.
Skull base.
Disaster. So
Yes.
always take this line into consideration. See this line? Line here. Stay close to the septum, not close to the turbinate.
Okay.
Close to the septum, and this is your
Sphenoid opening.
Yes.
mind it. What I'm saying, close to the turbinate, close to the septum, not close to the septum, not close to the turbinate.
Yeah.
Step flush to the septum. See this?
Yeah.
Flush to the septum at the level of what? Maxillary line. Can
Maxillary
you see?
line. Yeah.
Can you see?
Yes, yes.
Is there is this a case of the onodic condition?
Suppose.
Satish?
Now I have widened it. Suppose that is the roof of the sphenoid there.
Sphenoid, yes.
If I don't take into consideration this, and if I go there to open, would be a disaster.
Yes.
Would get a CSF leak.
Yeah.
That's why this maxillary line is so important. Now, why I saw this sphenoid first before the posterior thymoidectomy? Because now I know my posterior limit of posterior thymoidectomy.
Yes.
My all carotid, optic, whatever are going to be behind the level of the ostium. So I will accomplish my posterior thymoidectomy quick now.
Yeah.
Taking this sphenoid ostium as a posterior limit. Until the sphenoid ostium, I can carry out anything.
Okay.
I can guarantee that nothing will be injured till then.
What about onodi cells here?
Whatever.
Okay.
Whatever onodi cell is there or not, if during this step I don't cross the sphenoid ostium,
Yeah.
I will not damage anything. Simple.
Okay. True. So
See this
simplified,
now?
huh?
Everything I am removing.
Yeah.
Simple. See this?
Yeah.
See, this is like a box. Again, your lateral limit is lamina. See this?
Yes.
Medial limit is your turbinate. And I have an insurance here that I will never damage the optic or carotid as long as I keep my sphenoid ostium as my posterior limit of posterior
Posterior
thymoidectomy.
limit. Yes.
Now let me remove this lower 1/3 of the superior turbinate.
Yes.
See, somebody asked about the superior turbinate. It doesn't obstruct any other sinus but the sphenoid sinus.
Yes.
Is this the onodi cell?
Yes.
The upper one?
Yes.
Okay.
See this. Now I have removed the lower 1/3. Now, if there is onodi cell or not, I told you don't cross this limit of sphenoid ostium.
Yes.
See this? See this?
Yeah.
Yes.
Now, I am at the level of the sphenoid ostium. Wait. See this?
Yes.
Suppose I don't take into consideration this landmark and keep on going behind and doing a posterior thymoidectomy. See this? I can easily damage the optic now.
Yeah. Very close to.
Disaster. Can be a
Yeah.
disaster. So
Yeah.
now, having seen the sphenoid ostium now sphenoid is behind. See that?
Yeah.
I can remove this septation and widen the sphenoid and complete my surgery on this side. As simple as that. See
Sir,
this?
in case of thick bony anterior wall of a sphenoid,
Pardon?
there is, in case of thick anterior wall of the sphenoid and very
Yeah.
thin,
See what
very
I'm doing?
narrow.
I'm
opening.
using a Carrison punch.
Yeah.
Yeah.
I can use a sphenoid punch, Stemberger punch. I can use a drill,
Okay.
but never pull it. Use a sharp instrument to punch through. See that?
Okay.
Widen the sphenoid thoroughly. Now see the sphenoid.
Yes.
Yeah. Yeah.
I am not removing the entire superior turbinate, which is not bothering, and this upper part of the superior turbinate is important because on the other side is the olfactory mucosa.
Yeah.
See this, everything. This is not a great sphenoid, not very pneumatized, but still I can show you the landmark, what I see here. I can see the carotid prominence, show you. See that. This is my carotid prominence. Can you see this?
Yes, yes.
Yes, yes.
See this bluish? And this is
the
going to be the optic nerve prominence.
Yes.
Here.
Yes.
From
Yes.
here to here. This is carotid. The optico-carotid recess is not pneumatized. I can see the size of the sphenoid is not great. So not very pneumatized. So you see this in one view. What we have achieved is the full house face.
What about the ethmoid arteries
Our
here?
goal of surgery is two-pronged, to do a complete walk addressing all sinuses. That's why we call it full house safe phase. At the same time preventing complication, and so many landmarks we take into consideration to prevent complication. Right from the beginning. Every step you need a good landmark. See now with your 0 degree. In your outpatient department with your 0 degree, you can see everything.
Is the posterior ethmoid visible?
Posterior ethmoid artery is here.
This here, yes, yes.
Yes, 4 to 5 millimeter, 5 to 6 millimeter anterior to the optic nerve. Optic nerve is here.
Yeah.
This, so this should be posterior ethmoid.
And anterior?
Anterior
Still more anterior.
Still more anterior, but
that is. So see the wide opening of the sphenoid, maxillary, entire ethmoidal roof, frontal sinus anteriorly, both ethmoidal arteries. This is orbit.
Satish, there was the retroorbital cell in the frontal. So that was not visible in this.
On other side. The
on the other side. Okay.
Yes.
Okay. This is on the
Here
right.
it is very, very shallow. I can tell you the location. That is supraorbital cell. And this is the middle turbinate. See how nicely it is lying close to the septum. The best treatment of the middle turbinate is not to disturb it. And if you happen to damage it, you may have to do a partial resection or something like that, bulgarization, anything.
Sir, could you tell conditions in which you at times would like to cut the partial part of middle turbinate?
Many a time.
Huge AFRS.
Massive mucosal disease, we do it intentionally.
Okay, for better delivery of steroid.
Yes. No question of blocking it further. Now see this recess.
Yes.
This recess, it was shallow on this side, posterior to the frontal sinus, that is supraorbital, and that is quite shallow on this side. It is more deeper. See this. This is the frontal sinus, and behind this recess going up above the orbit. This is very shallow. This is supraorbital.
Yes.
Not very important on this side. So this is about the full house face on this side. Any questions?
Sir, one thing more. Sir, in the post-operative period, could you put in a word or comment upon the way of dosing? So for more effective steroid
I will show you through one of the pictures.
Yes, sir. Because that is a very important
This is the final picture.
Yeah.
Just 5 minutes, we will irrigate with the saline. Then we'll irrigate with the Dexona. And we will leave Dexona soaked same marrow cell pieces into the ethmoidal cavity. See, the goal of this surgery now, this patient who would take the oral steroids again to control his symptoms. Now, we have removed the disease load. We have improved the access to the topical reaching everywhere in the sinus. Now, no need of oral steroids. We'll train him for douching to ensure your topical steroid reaching everywhere. To ensure that your topical steroid reaching everywhere.
थोड़ी देर में कॉल करते हैं, जरा एक वर्कशॉप में है. Okay.
Any comment regarding intranasal corticosteroids drop and spray?
No drops, no spray. It is douching. Douching means you have to irrigate the way it should reach to the depth of all sinuses.
point?
Satish, there is a question. Satish, there is a question.
Yes, sir, please.
In the full house face, if disease is to one side, should you do it bilaterally or that side only?
No, no, on the side of the disease. Why to go bilaterally once there
Right.
is no disease at all?
And then there are some comments from Ahila Swami, BK Singh, and Nasir that excellent dissection. I mean, excellent work, Satish. These are the comments. Yeah. Go ahead.
What is the douching material, Satish?
Huh?
Douching
What is
material.
the?
Douching material.
Yeah, the douching material we use is basically the budanoside solution.
Yes.
And budanoside is the one we mix in saline and do a high volume irrigation reaching paranasal sinuses.
Yes.
So,
In
let me
Namaz
show you.
position or like that.
Yes, Namaz position.
Satish.
Yes, sir.
And I want to make one comment which I heard from our one of the ENT colleague from Pakistan.
Sir.
That he heard of Taj Mahal in India, he heard of Lata Mangeshkar, but he was able to heard about Satish
Oh, come on.
in the webinars.
It's too much, sir. Thank you. Sir, can you see this picture?
Yes.
Yes, this is
our
the one.
preferred position we advocate a patient, and young patient can do it easily.
Yes, sir.
You know, head down
It
forward, 40 to 60 degree, and whatever you introduce, it reaches the olfactory cleft and the frontal sinus well.
Yes.
And this is easy. It's a prayer position. You bend down on your knees with the head forward, resting on the floor. This prayer position, and you can then douche. It will reach everywhere. Our goal is to make the steroid solution reaching everywhere.
Yes,
So
sir.
that these patients can be switched from the oral steroids to topical steroid.
Yes.
Without this sinus surgery, the steroid was not possible to reach to the depth of the sinuses. Now the surgery has made this solution reaching everywhere in the sinus. That is the role of surgery. That's why we have to counsel our patient properly. I never tell my patient that surgery is going to cure you, but the surgery is the way to cure you.
How long you are going to give the
Depending upon
doubting?
yes, I
How
will
long?
do it, sir. That's a very
Symptoms.
important question.
Yeah.
So, and another position, and some people can't do the head down position. Then this lying head back position. It will again allow the solution to reach to the frontal sinus and olfactory area in the equally, efficient way. So this is regarding the position.
Yes.
And we need to counsel a bit. Don't tell your patient that you will do sinus surgery and the patient will be cured. It's a joke.
Yes.
It's a joke. He cannot be cured. It is a way to the cure in the sense that we need to counsel patient. Without surgery, we can't give topical. And without surgery, you need to take oral steroids again and again, which have their own adverse effects.
Yes.
To avoid using oral steroids, to make the topical steroid using topical steroids effective, you need a sinus surgery. But you need this douching for long. And now this is to answer how long what Prakash Mukhar has asked. So tell your patient, like cardiologists tell, after an angioplasty, you have to keep the stent patent by taking anticoagulants. And the patient will definitely take, he will never afford to get the stent blocked.
Yes.
Similarly, you have to tell that if you don't douche post-operatively, you don't deliver steroid, either you'll have to take oral steroid or you have to get again and again operated. He will never miss it.
Yes.
He will again use it. So it is a matter of counseling, how you counsel your patient. Don't give them a hope that to lure a patient that we will cure you. You need surgery, you will be all right. It can't happen.
But Dr. Satish, more practical is when they are get rid of symptoms, they stop taking the douching and then again they have the symptom.
Yes.
So will you
what you can do, these patients requires a regular
cleaning
periodical
up and follow up.
endoscopic monitoring.
Yes, that is there. Another question, after the polyp surgery, steroid sprays are given, the rationale and how long it should be given?
Zero role. Now
Okay.
you have opened the sinuses. You have opened the access to the solution to reach everywhere. What will sprays do?
Yes.
Spray cannot cross more than anterior 1/3 of the nasal cavity.
Yeah.
They were used in the medical treatment pre-operatively because the sinuses were blocked.
Yes.
Now, once you open the sinuses, no role of sprays, no role of drops.
I think this is a clear message. This is a clear message to all, because many still prescribe post-op, say some steroid spray for 3 months, 6 months.
No way.
Yeah, please go ahead.
You need to deliver steroid. Now you open access the steroid to reach all sinuses.
Right.
That is the goal of surgery. The goal of surgery is changed now. The goal of surgery is to make topical steroid effective. You can use topical steroids long lifetime without or hardly any adverse effects as compared to the oral steroid. That is the goal.
Yes.
Sir, how do you tell the do you get a preformed budesonide for these patients, or do you tell them to make it?
No, we tell them to make in a range of a solution 250 microgram per 250 ml to be delivered every time. In the sense, what we tell them to mix 1 ml of budesonide in 1 liter of saline.
Saline, okay.
Yes.
And that they can.
Milligram. Now see, 1 milligram only. Out of that, 250 milligram is being delivered every time.
Okay.
There is hardly any steroid, and that too only topical. You rinse and it comes out immediately.
And how much?
Hardly any systemic side effects. We have seen our patient using for years together without any side effects. So many studies done with no effect on the HP axis.
HP axis. And sir, how many, like, would you say do it
once daily,
a day?
once daily, twice daily?
Yeah, initially to begin with, 3 months is twice daily, without until it heals completely. That's what I was coming to. Then on a regular periodical follow-up, you can see when everything heals up and patient's profile is not very eosinophilic. That is why I put up this slide. You can start reducing the concentration and the frequency. You can reduce the concentration to 0.5 milligram and once a day. The still patient maintains the mucosa well. You can call after a month or two. If it is maintained well, you can still reduce. And if they start developing edema or polypoidal mucosa, you can again increase the strength. So depending upon the symptoms, depending upon the endoscopic finding, you have to keep playing with the dose and frequency, you know. And how do you ascertain is this slide, that how eosinophilic the patient is. You need to have a good information of the mucosal eosinophilia. That's why we take at least one sample of the mucosa, what we remove for the histopathology to see the mucosal eosinophilia. If that is more than 10 eosinophils per high power field, is a straightforward, you can tell your patient, boss, you may require this solution for lifetime because you have too significant eosinophilia.
Yes.
Don't think of stopping this on your own, otherwise you may have to come back for the surgery. So there are so many things. This is our investigation panel for every patient of particularly polyposis, to rule out any adjuvant pathology, adjuvant comorbidity. This is not a simple sinus disease. Many a times it's like a syndrome. You need to rule out, you know, antibiotics particularly hardly ever needed because this is a eosinophilic disease, and still the need of antibiotic can be ascertained by getting the CRP procalcitonin done. If it is high, then only the need of antibiotic, otherwise no need. You have to get the eosinophil count, IgE, immunoglobulin deficiencies, not uncommon. In up to our 10% of our patients, we find some sort of immunodeficiency, particularly who come for, you know, revision surgeries, massive disease. There are so many immune conditions affecting the this disease as well. So if immunity is low, whatever you operate is never going to work. You have to improve the underlying immune condition. Aspirin sensitivity, if it is there, particularly in polyp patients having asthma, we must get done the aspirin sensitivity. Now we have over 350 patients who are undergoing aspirin desensitization. because their basic pathway is different. Disease pathway is different. Basic underlying pathophysiology is different. The underlying pathophysiology is the arachnoid acid dysmetabolism, wherein they're sensitive to aspirin, so you have to desensitize them. Otherwise, more and more leukotrienes will form, more and more polyps will form. 100 times you operate, he is going to come back again. So all patients with polyps and asthma must be assessed for aspirin sensitivity. Vitamin D again must assess and improve the immunity by supplementing if it is extremely low in mucosal stuff. So these are the investigation, you need in almost every patient to prognosticate them. Every patient is the first question, doctor, will I need to come back for surgery again? I have heard, I have Googled this surgery is notorious, this disease is notorious, and patient have to repeatedly get operated. And you need all this information to get the patient's profile, disease profile, ongoing disease profile, to answer him that how severe your disease is. You can't treat every patient on the same line. Chronic sinusitis has several endotypes. Every endotype has a different pathophysiology, and you have to treat separately on that line. Like allergic fungal sinusitis is a different pathophysiology. This allergic respiratory, AERD, aspirin exaggerated disease, is a different pathology. Cystic fibrosis is a different underlying pathology. You don't have to treat every patient on the same line, rather going into the pathophysiology of the disease and then operate or take a call for management.
Dr. Satish, can I in this moment?
Sir, it is 2:10. Yes.
Basically, the award session is going to start.
Yes, I know.
Hello.
So we have to call it a day here for the live surgical part.
The people can move to the workshop next.
Hello.
Yeah, sir.
Next case you are planning the thyroid surgery?
Yeah, we have theater going on. If you want, I can demo, but I don't want to spoil your. I know the time was scheduled till 1 o'clock. It has already crossed 2 o'clock, and
Yeah, no, I know 2 o'clock was optimal. So I think the people can start there, and rest of the people on all India level, they have logged in. Will they continue or?
If you want, I have no issues. I have to anyhow operate.
Pardon?
I have no issues in continuing demonstration.
Okay.
Anyhow, we have to operate. We have to finish all cases.
So next you are taking a thyroid.
Continue. If your time permits, I can continue demonstration. Otherwise, as you say.
Okay. No, I think let the Bihar, Jharkhand people should move to paper presentation, because that will be an impetus for the PGs and all that who are presenting. If nobody is there attending, it won't be nice. So,
but sir, I have no issues. But I got the message from one of the
same
organizers
continue.
that if I continue, the people will be distracted. Nobody will be in the sessions then.
That's exactly what I was thinking. That is there.
Okay,
yeah, because for certain nobody can have satisfaction of seeing it.
Sir,
So
sir,
we call it
sir.
Okay, and we will keep doing our series of webinars in the
Dr.
future. Like
you want to add on something?
Pardon, sir?
I mean, it's our pillar.
Sir, just I am speaking Dr. SP Singh, sir. Sir, I am speaking Dr. SP Singh, sir. Sir, Dr. Munka.
Yeah, continue. We are listening.
Okay, sir. Sir, I am very thankful to Dr. Satish Jain, who has given a very good presentation for the webinar of our association. And I want to quit from this webinar, and I should start the next session. But this operative session should continue, and we will join the other webinar for the other presentation. So this those who want to share this operation, they can continue, and I will start from the second webinar with this other presentation of the PGs. Okay, sir. Thank you so much, sir.
Thank you. And for everyone, we are going to continue our webinars like we have been doing for last 6 months. as per schedule, twice in a month, on different themes and different variety of cases in ear, nose, throat, and skull base.
Yeah.
So our next webinar will be in the end of the December now, which we will advertise very soon. So thank you very much for being with us, and big thanks to the organizing team of the AOICON Bihar and Jharkhand for giving this opportunity. Special thanks to SP Singh sir. I've been to his medical college twice with an amazing, setup and experience there. Amazing with the Farouk with a huge setup in Bhagalpur, and he probably does the maximum number of surgeries there.
Okay, sir.
And big thanks to Prakash Muka sir.
Thank you so much, sir. Okay.
Pleasure.
Thank you so much.
It's all our pleasure, Satish. It's all our pleasure. You are always in the teaching.
Hello.
Anything academic, we always
big thanks to Dr. Kranti, Dr. Ashwini Verma, Dr. Samit Lal, Dr. Sanjeev Kumar.
Thank you, sir. Thank you very much, sir. So nice of you and your endeavor.
And so you are the best teacher. But for me, most of my surgeries are after I see your vision.
Oh, definitely. For all of us.
We all are in the same league, learning from each other.
Thank you so much for teaching like that, sir. And all
Thank you, sir.
Yours was the first workshop we attended when we were postgraduates. And that was endoscopy workshop. And from there to now, you have been a splendid teacher. Thank you so much.
We would have loved to spend some more time with you, sir, but our state presentation is about to commence. Thank you, sir.
There's many other aspects. Thank you.
Yes, sir.
Thank you so much.
Thank you, everybody.
Have a great day, sir.
See you soon in our next webinar. Thank
Sure,
you.
sir.
Yes, sir. Thank you, sir. Sure, sir.
Thank you, sir.
Dr. Kranti, are you still around?
Yes, sir. I'm around, sir. So we are going to have the presentation on this only. Hello. Hello. Hello.
Dr. Kranti, can you hear me?
Yes, sir. I can hear.
Yeah, you can move to that session because probably first paper is by Nisa or somebody there in the consultant ward.
Okay,
Yeah.
sir. I'll do that. Okay, sir.
See, if we continue here, that will be not encouraging for them.
Okay, yes.
We can join up once that is over. Dinesh ji, can you listen to me?